Chapter 40. Behavioral Emergencies. Introduction. Problems related to abnormal behavior are commonly the result of mental health problems, implying that they originate in some ephemeral place called the mind, as opposed to real medical problems, which originate in the solid, tangible structures of the body. In reality, the mind and the body are not separate entities, they are inseparable parts of a whole human being. When a person becomes ill with any disease, that illness will inevitably affect the individual's behavior, often making him or her anxious or depressed. Similarly, changes in mental state influence the body's physical health. A depressed person, for example, may lose appetite or become more susceptible to bodily disease. Thus, whenever you examine a patient, it is important to view the patient as a whole person, and try to understand both their physical and the mental factors that contribute to the patient's distress. What is a behavioral emergency? The concept of behavior has been widely debated over the years. Most experts define it as the way people act or perform, for example, how they react to a situation. Behavior includes all the things people do, and the reasons why they do those things. Who defines when the behavior becomes abnormal is also a source of debate, as is who defines what is normal: society in general, a particular community or social group, a parent, a boss, a friend, or even a stranger. Abnormal behavior alone may not be a medical problem, and is hardly cause for alarm. The real questions are, when does abnormal behavior require medical intervention, and when does it require emergency medical services? Almost all disordered behavior represents the individual's effort to adapt to some stress, whether internal or external. In most cases, the disruptive behavior is a temporary action, abating when the individual has managed to mobilize his or her psychological defense mechanisms. A behavioral disorder is a disorder of mood, thought, or behavior that interferes with a person's ability to perform activities of daily living, and is caused by organic and/or psychiatric illness. Activities of daily livings are normal, everyday activities such as getting dressed and taking out the garbage. When a person becomes so depressed that he or she cannot get up in the morning, shower, and make breakfast, or when someone has delusions or hallucinations that prohibit holding a job, a behavioral disorder exists. A behavioral emergency exists when the abnormal behavior threatens a person's health and safety or the health and safety of another. The most extreme examples are psychiatric emergencies in which a person becomes suicidal, homicidal, or has a psychotic episode. In a psychotic episode, a person often experiences delusions, false beliefs, or hallucinations, false perceptions, that result in loss of contact with reality. For example, a patient who has taken illicit drugs may experience an alteration of reality called a bad trip. Psychotic episodes may be dangerous because the person's behavior may become so disorganized due to exaggerated fear or paranoia that they fail to care for him or herself, undertake risky behaviors, or become violent. Regardless of how textbooks define a behavioral emergency, the operative definition is provided by the person who dials 911. Often, what makes a behavioral emergency an emergency is panic on the part of the patient, the family, bystanders, or all of the above. That panic, in turn, may translate into a demand for action, and you may, therefore, face intense pressure to do something, such as transport the patient to an emergency department with a crisis unit. Paradoxically, it is precisely in this situation, when the patient is behaving strangely and bystanders are clamoring for action, that the paramedic may feel least able to do something. Most paramedics would much prefer to deal with a train wreck than with the tangle of confused and frayed feelings presented by a behavioral emergency. Most people prefer to operate in areas in which they feel competent. For paramedics, that means dealing with problems like broken legs, cardiac dysrhythmias, or narcotic overdoses. Some paramedics feel much less confident in their ability to deal with emotional disturbances, especially because some paramedic training programs do not delve sufficiently into such matters. Furthermore, paramedics tend to be action-oriented people. They like to see tangible results of what they do: a hypoglycemic patient coming around after a bolus of glucose, A clinically dead patient restored to life by cardiopulmonary resuscitation and defibrillation. What tangible rewards can there be in escorting a confused, hallucinating patient to the hospital, let alone in dealing with a belligerent and violent patient who is screaming obscenities? Pre-hospital intervention is possible and often critical in behavioral emergencies. You can make a huge difference in the life of a patient who is disturbed, and the skills for doing so can be learned just like any other skill. Indeed, the skills for dealing with abnormal behavior may ultimately be much more important to your work than skills such as tracheal intubation. After all, how many calls require placing an advanced airway? Many more calls require you to deal with people who are angry, depressed, agitated, panicky, or out of control. Clearly, it is worthwhile learning an organized and systematic approach to emergencies that involve abnormal behavior. Causes of abnormal behavior. Anyone who has seen a paranoid, belligerent diabetic transformed into a model of courtesy and charm by the mere addition of 25 grams of glucose to the bloodstream knows that not all behavioral problems are caused by psychiatric illness. Similarly, no one would diagnose mental illness in a person who was stunned and mute after the unanticipated death of a spouse. Abnormal behavior typically results from a complex interaction of biologic or organic causes, developmental factors, psychological stressors, emotional stimuli, and socio-cultural influences. Those causes can be classified into 4 broad categories. 1. Biologic or organic causes. 2. Causes resulting from the person's environment. 3. Causes resulting from acute injury or illness. And 4. Causes that are substance-related. Biologic or organic causes of abnormal behavior. Many patients reporting psychiatric symptoms are actually affected by biologic or organic factors that interfere with normal cerebral function. Such patients are generally classified as having organic brain syndrome. Diabetes, seizure disorders, severe infections, metabolic disorders, head injury, stroke, alcohol, tumors in the brain, and drugs may all cause derangements in behavior. When faced with abnormal behavior, always look for organic and situational causes, as they are the ones you will be best able to treat in an acute emergency. The selected disease states that can produce psychiatric symptoms are summarized in Table 40-1. Besides intoxication with alcohol or drugs, other common forms of organic brain syndrome include delirium and dementia. Delirium is characterized by a global impairment of consciousness and cognitive function that comes on quite rapidly and may fluctuate in severity over the course of a day. Delirium is most often a consequence of a general medical condition. Dementia is a more chronic process with an insidious onset, producing severe deficits in memory, abstract thinking, and judgment, and even some psychotic features such as paranoia. Psychosocial causes of abnormal behavior. Normal individuals may develop abnormal reactions to stressful psychosocial events, for example, childhood trauma, or developmental influences, for example, parents who deprive them of love, caring, support, and encouragement. When a person's basic needs are threatened, that person faces a crisis. A person in crisis has 2 alternatives for dealing with this threat. 1. Cope with it, finding ways to alter the situation or his or her perception of it so that it is no longer so stressful, or 2. Attempt to alleviate the discomfort by escaping from the stress. Escape may take many forms, including alcohol, drugs, psychiatric symptoms, and even suicide. Sociocultural causes of abnormal behavior. Chapter 2 considered the responses of patients, their families, bystanders, and rescue personnel to the stresses of emergencies, and the various ways that people react to death and dying. Humans are social, we prefer to live in groups. Unsurprisingly, social and cultural factors directly affect biology, behavior, and responses to the stress of emergencies. For example, the effects of assault, rape, and racial attacks or the death of a loved one may produce significant changes in a person's behavior. Psychopathology. Many factors contribute to disturbances of behavior. Some of these influences are easily identified and treated, whereas others may never be clearly understood. The causes, signs, symptoms, and management of abnormal behavior can be grouped into several categories of psychiatric disorders: cognitive, thought, mood, neurotic, substance-related disorders, and addictive behavior, somatoform, factitious, impulse control, personality. The remainder of this chapter focuses on these areas of psychopathology. Before considering those categories in detail, however, you need to learn about assessing a patient with a behavioral emergency. Psychiatric signs and symptoms. When a person's physical health is challenged, the human body mobilizes various defenses to correct the abnormality. The patient experiences the effects of those abnormalities and corrective measures as symptoms, and the paramedic observes their effects as signs. Physical symptoms and signs reflect the body's attempts to maintain its balance in the face of physical stress. Psychiatric signs and symptoms serve the same function for the mind. They reveal the personality trying to maintain the optimal internal balance in the face of a stressor. Like the symptoms and signs of physical illness, psychiatric symptoms and signs can be grouped according to the systems they affect. Here, however, the focus is on systems of psychological, rather than physiologic, functioning. The psychological functions involved are consciousness, motor activity, speech, thought, affect, memory, orientation, and perception. Psychiatric signs and symptoms are categorized by disorder in Table 40-2. Consciousness. Consciousness refers to the degree to which a person is aware of and attentive to the external world. Disorders of consciousness such as delirium, stupor, and coma usually indicate an organic basis for the patient's disorder. Other disorders of consciousness, however, are seen in psychiatric patients. Confusion refers to impaired understanding of one's surroundings. Motor activity. Motor activity in a disturbed patient may be increased, decreased, or bizarre in some way. Restlessness refers to the situation in which a patient cannot sit still. When restlessness occurs in association with extreme excitement, it is called agitation. At the other end of the spectrum, a very depressed or psychotic patient may exhibit exceptionally slow movements. In some cases, the patient appears to have little or no control over motor activity. Stereotyped activity involves a repetition of movements that do not seem to serve any useful purpose, for instance, a patient's repetitive touching of the elbow, nose, and forehead in succession. Compulsions are repetitive actions that are carried out to relieve the anxiety of obsessive thoughts. Speech. Like motor activity, speech may be abnormally fast or abnormally slow. Speech delay is seen in severely depressed patients, whereas manic patients often show accelerated speech and pressure of speech, that is, words pour out like water escaping under pressure. The words the patient uses may themselves be strange or unusual. Neologisms are words that the patient invents. In echolalia, the patient echoes the words of the examiner. When the patient does not speak at all, the condition is called mutism. Thinking. Thinking is the highest of the mental functions, requiring integration of knowledge, perception, and memory. Thinking may be disordered in its progression or in its content. The progression of thought, like motor activity and speech, may be sped up or slowed down. Flight of ideas, which occurs in some manic conditions, refers to accelerated thinking in which the mind skips so rapidly from one idea to another that the listener finds it difficult to grasp the connection between them. At the other end of the spectrum, depressed patients may experience retardation of thought, in which it seems to take a very long time to get from one thought to the next. In circumstantial thinking, the patient includes many irrelevant details in his or her account of things. Perseveration refers to repetition of the same idea over and over again. The content of thought may also be abnormal in a patient with psychiatric problems. The patient may, for example, express delusions, fixed beliefs that are not shared by others of the same culture or background, and that the patient is not willing to change by reasonable explanation. With delusions of persecution, the individual believes that others are plotting against him or her. With delusions of grandeur, the patient believes he or she is someone of great importance. Other delusions that suggest psychoses include thought broadcasting, the belief that others can hear one's thoughts, thought control, the belief that outside forces are controlling one's thoughts, and ideas of reference, the belief that external forms of communication, such as television, radio, and newspapers, are directed specifically at that person. Obsessions are thoughts that will not go away, despite attempts to forget them. Usually, the person with an obsession knows that the idea is unreasonable, but cannot stop thinking about it. Patients may, for example, have an obsessional belief that the gas stove has not been turned off, so they will return again and again to the kitchen to make sure. Each time they do so, their anxiety will be relieved for a short time, but then they must go back and check yet again. Phobias are obsessive, irrational fears of specific things or situations, such as fear of heights, fear of open places, fear of confined places, or fear of certain animals. Mood and affect. Mood refers to a person's sustained and pervasive emotional state. Affect is the outward expression of a person's mood. A person's mood may be described as depressed, euphoric, or anxious. Affect is described as appropriate or inappropriate. A patient who puts on a waxy smile as he tells you of a parent's death would be considered to be showing inappropriate affect, that is, the emotion expressed is inconsistent with the situation. Affect is characterized as labil when it shifts rapidly, as in the patient who is laughing one moment and crying the next. With a flat affect, the patient does not seem to feel much of anything at all. Memory. The most profound disorder of memory is amnesia, the loss of memory. Memory is a complex process consisting of 4 separate functions: registration, the ability to add new items to the cerebral data bank; retention, the ability to store those items in an accessible place in the mind; recall, the ability to retrieve a specific piece of stored information on demand; and recognition, the ability to identify information that one has encountered before. Amnesia may reflect the disruption of one or several of those functions. In delirium, for example, a person may be unable to register events properly and thus cannot recall what happened while he or she was delirious. When painful memories are repressed, recall is impaired. Sometimes patients with severe memory deficits from organic brain disease will invent experiences to fill in the gaps in memory. This behavior is called confabulation. Orientation. Orientation refers to a person's sense of who one is, person, where one is, place, at what day of the week or time of the day one finds him or herself, day, and an understanding of events leading up to where one finds him or herself, events. A person who is confused about those particulars is said to be disoriented. Disorientation is most common in organic brain syndromes. Perception. Perception refers to the way a person processes the data supplied by the 5 senses. 2 disorders of perception are illusions and hallucinations. An illusion is a misinterpretation of sensory stimuli, for example, mistaking a piece of rope for a snake or a cat's meowing for a human voice. A hallucination is a perception that has no basis in reality, and occurs without any external stimuli. Hallucinations may involve any of the 5 senses. A person may hear, see, feel, taste, or smell something that is not there. Auditory hallucinations, for example, hearing voices, are the most common. Hallucinations involving other senses, for example, the frightening visual hallucinations in delirium tremens, suggest an organic cause. Intelligence. Intelligence refers to a person's intellectual ability. A person's intelligence is not necessarily a function of his or her education. For example, a person with a disorder of intelligence may have been born with a developmental delay or may have sustained a disease that makes it more difficult to process, remember, and communicate information. Assessment of the patient with a behavioral emergency. The first step in assessing a patient with a behavioral emergency is directed at ruling out an organic illness. Further evaluation of the patient with a behavioral emergency differs in at least 2 ways from the methods of patient assessment studied so far. In assessing the patient with trauma or acute illness, you use a variety of diagnostic instruments to measure vital functions and detect abnormalities, a stethoscope to evaluate breath sounds, and a sphygmomanometer to measure the blood pressure. In assessing the disturbed patient, you are the diagnostic instrument. You must use your thinking processes to evaluate someone else's thinking processes, your perceptions to test the validity of someone else's perceptions, and your feelings to measure someone else's feelings. This skill takes practice, because most emergency medical services providers are not accustomed to using their feelings in this way. For example, if you feel angry at something someone says, your natural instinct may be to respond angrily to him or her. In working an emergency call, however, a more useful paradigm is, I feel infuriated with that patient, so it's likely he is paranoid, because paranoid patients often elicit anger in others. A second way in which the assessment of a patient with a behavioral emergency differs from that of a patient with an isolated organic medical problem is that the assessment is part of the treatment. As soon as you speak to the patient, your voice and manner will influence his or her condition, for better or worse. The very process of listening to the patient describe the issue at hand can also mitigate the problem. Scene assessment. Observe the scene carefully for weapons, remembering that almost anything, a chair, a lamp, or a book, can be used as a weapon. Prior to entering a scene, ensure that you have a clear exit route available for personal safety. If you have any questions about your ability to manage the situation safely, call for assistance. The patient's overall condition, and the nature of his or her psychiatric problem will determine how much of the assessment you are able to perform. A disturbed patient may prefer not to be touched, and you must respect that wish unless there is a compelling medical reason for doing otherwise. For example, profuse bleeding from slashed wrists or a decreased level of consciousness from an overdose. At the very least, you should be able to assess the patient's general appearance, for example, the patient's dress, cleanliness, and grooming, all of which provide clues to the way the patient perceives himself or herself. Pay attention to the patient's posture. Does the patient appear frustrated, angry, grief-stricken, or catatonic, lacking expression or movement, or appearing rigid? You must also carefully assess the pupils because they may indicate other causes of altered mental status. For example, constricted pupils may indicate opiate ingestion, or unequal pupils may indicate cerebral trauma. Initial assessment. Identify yourself clearly. Tell the patient who you are, and what you are trying to do. If the patient is confused or delusional, you may have to explain who you are at frequent intervals. Do so without arguing, in an emotionally neutral tone of voice. No, Mr. Jones, I'm not from CSIS. I'm a paramedic with the City Ambulance Service, and I'm here to help you. Attend first to priority problems, airway, breathing, or circulatory concerns. Your assessment must look for signs and symptoms of abnormal functioning as well as abnormal behavior. Be prepared to spend time with the disturbed patient. Do not be in a hurry, rather, convey the message that you have the time and concern to learn what is bothering the patient. Assess the patient wherever the emergency occurs. Do not rush off immediately to the hospital, because the hospital is likely to be a strange, intimidating place for the patient. Your haste to get there may reinforce the patient's belief that something is terribly wrong. Let the patient recover his or her bearings in familiar surroundings when medically possible. Patients who are seriously disturbed should be seen by a physician, and evaluated for possible hospitalization. Many of these patients will agree to their transport to the hospital. Others may not want your help and try to prevent you from taking them to a hospital. Because this kind of transport deprives the patient of his or her human rights, it must never be undertaken lightly. Even an experienced psychiatrist may find it difficult to define what kind of behavior justifies removing a person from society or what constitutes dangerous behavior. Furthermore, laws vary from one region to another, so it is important to be familiar with the legal requirements in your community. As a general rule, consent is required to take a competent, conscious adult to the hospital. If consent is withheld, a patient may be taken against his or her will if he or she is deemed incompetent and is felt to require hospital care. Additionally, patients expressing thoughts of self-harm or harm to others should be taken against their will to the hospital. In all cases where patients are transported against their will, police must be involved. The same policy applies to the use of forcible restraint. When such measures are deemed necessary, law enforcement officers should be summoned. In addition, every ambulance service should have clearly defined protocols, drawn up with legal advice, for dealing with patients who require involuntary treatment and transport. Follow those protocols to the letter, and consult direct medical control, if present in your system. Focused history and physical examination. Begin your focused history and physical examination for people who are behaving abnormally by obtaining both their past medical history and their history of present illness. To gather the needed information, talk with the patient and use your interviewing skills. Set some ground rules for your interview. Let the patient know what you expect and what he or she may expect of you. It's okay to cry or even scream, but we aren't going to let you hurt yourself or anyone else. Allow the patient to tell the story in his or her own way. Do not attempt to direct the conversation, but allow the patient to vent his or her feelings. Interviewing techniques. When evaluating a trauma patient, you can generally obtain enough information to provide appropriate initial treatment just from the physical examination, even if the patient is unconscious and cannot give a history. When evaluating a patient with a behavioral emergency, by contrast, virtually all of the diagnostic information, and much of the therapeutic benefit, must come from talking with the patient. Skill in interviewing a disturbed person, therefore, is central to dealing with psychiatric emergencies. Here are some guidelines. Begin the interview with an open-ended question. An open-ended question does not provide possible answers for the patient, but rather allows the patient to select the answer. For example, say it's clear you've been feeling bad. Tell me something about the kind of troubles you've been having. You may begin with more direct questioning when you must obtain specific information in a hurry, such as what kind of pills did you take? How many? Let the patient talk and tell the story in his or her own way, even if it takes a little more time. Letting patients talk allows them to gain some control over themselves and their situation. At the same time, it enables you to assess the patient's speech, affect, and thought processes. Listen, and show that you are listening. Your facial expression, posture, eye contact, and an occasional nod, all of these things can convey to the patient that you are paying close attention to what he or she is saying. Do not be afraid of silences, even though they may seem intolerably long. Maintain an attentive and relaxed attitude until the patient takes up the story again. It is especially important to be silent when the patient stops speaking because of overwhelming emotion. Avoid the temptation to jump into the silence to comfort the patient or to forestall the patient's expressions of emotion, such as crying. The expression of feelings is often therapeutic in itself, and the patient will likely be better able to express himself or herself after this emotional release. Furthermore, your silence gives the patient a chance to get control of himself or herself in his or her own way. Acknowledge and label the patient's feelings. The patient who is disturbed may feel overwhelmed by intense and chaotic feelings. Identifying those feelings, and giving them a name, for example, "You seem very angry," can help the patient gain control over them. Do not argue. If the patient misperceives a reality, make note of the misperceptions, but do not try to talk the patient out of them. When a misperception is very frightening or distressing to the patient, you might try just once to provide a simple and factual statement, in a neutral tone of voice, "Yes, that does look a lot like a snake, but actually it's just a shadow." However, do not get into a dispute on the nature of reality. Facilitate communication. Facilitation is a technique of encouraging the patient to communicate by using gestures or non-committal words, such as a nod of the head or a phrase like "Go on, I see," or "What happened after that?" You can also use facilitation to return the patient to a topic on which you would like some elaboration. For example, a patient may have made a passing reference to suicidal thoughts, and then move on to another subject. When the patient finishes, you might comment, "You say you've had thoughts of suicide?" This remark tells the patient that you have been paying attention to the story, and would like to learn more. Direct the patient's attention. Confrontation refers to pointing out something of interest in the patient's conversation or behavior, thereby directing the patient's attention to something he or she may have been unaware of. Confrontations describe how the patient appears to the interviewer based on observations, not judgments. For example, the interviewer might remark, "You seem worried," or "You look very sad." Such comments often elicit a freer expression of feelings from the patient. Confrontations must be carefully phrased so they will not sound nagging or condescending. Ask questions. When the patient finishes giving the initial account of the problem, you will have to ask questions. Keep the questions as non-directive as possible. Avoid asking questions that can be answered with a yes or no, "Are you very angry?" or asking leading questions, "Do you think that your husband is a part of the problem?" Instead, pose open-ended how and what questions. How did you feel when that happened? What factors have contributed to how you're feeling right now? Adjust your approach as needed. Some patients have difficulty with the lack of structure in open-ended questioning and may become anxious during silences. This reaction is especially common among adolescents, patients with severe depression, and patients who are confused or disorganized. When your open-ended questions meet with incomprehending silence, try another approach, and perform a more structured interview. The mental status examination. The mental status examination is a key part of your focused physical examination of a patient who is experiencing an acute psychiatric problem. To conduct the mental status examination, you must check each of the systems of mental function in an orderly way. A useful mnemonic for the elements of the mental status examination is COAST-MAP, also discussed in Chapter 17. Consciousness. Determine the patient's level of consciousness: alert, confused, responds to pain, unresponsive. Note the patient's ability to pay attention to a discussion and concentrate. Is the patient easily distracted, or can he or she focus on the events at hand? Orientation. Ask the patient the current year or month. Ask the patient to state where he or she is at the moment, the country, province, town, or specific location. If the patient is not sure, have the patient make a best guess. Activity. Examine the patient's behavior. Is the patient restless and agitated, pacing up and down? Experiencing tremors? Sitting very still, scarcely moving at all? Making any strange or repetitive movements, scanning of the environment, odd or repetitive gestures? Speech. Identify the form, rather than the content, of the patient's speech. Note the rate, volume, flow, articulation, and intonation of speech. Is it too fast or too slow? Too loud or too soft? Is the speech garbled or slurred, dysarthria? Is the patient stuttering or mumbling? Using any strange words? Thought. Listen to the patient's story. What is on his or her mind? Is the patient making sense? Is there anything unusual about his or her reasoning? Is the patient expressing apparently false ideas, delusions, such as a belief that the Canadian Security Intelligence Service is after him or her? Is the patient experiencing any false sensory impressions, hallucinations, such as hearing voices? Is he or she experiencing a flight of ideas, rapid shifting of ideas? Memory. Form an impression of the patient's memory: recent, remote, and immediate. If memory loss is present, determine whether it is constant or variable. Some patients may create memories to take the place of things they cannot recall, confabulation. Affect and mood. The patient's mood may be objectively noted via body language. Is the mood euphoric or sad? Is it labil? Does the affect, the expression of inner feelings, seem appropriate to the situation, or is it animated, angry, flat, or withdrawn? Perception. Detecting disorders of perception may be difficult, because patients often hesitate to answer direct questions about hallucinations or illusions. Sometimes it is helpful to ask the patient, "Do you ever hear things that other people cannot hear?" You can conduct nearly all of the mental status examination just by watching and listening, and knowing what to watch and listen for. Only the assessment of memory, orientation, and perhaps perception requires you to ask some direct questions. Practice being an observer. Get into the habit of noticing how other people talk, move, and express their feelings, and practice describing those things to your partner using COSMAP. Patients with psychiatric problems may be taking any of several types of psychotropic medications, that is, medications that affect mood, thought, or behavior. During your assessment, you should determine which medications have been prescribed for your patient, and whether he or she is actually taking them. Psychotropic medications are among the most widely prescribed medications in Canada. Most of these medications target the autonomic nervous system by either inhibiting or enhancing the sympathetic or parasympathetic nervous systems. The wise paramedic will have a thorough understanding of these two systems as well as knowledge of how the medications in the paramedic's kit may potentially interact with these types of medications. Many acute problems arise when patients fail to take their medications. Acute symptoms can be relieved by transporting the patient to a hospital safely and quickly. In the hospital, crisis workers can assist patients in getting their medications to prevent recurring episodes. The rest of the focused history and physical examination. While much of your focused history and physical examination involves interviewing the patient about psychiatric history and performing the mental status examination, you must also look for signs of an organic cause of the patient's behavior. Vital signs. Obtain vital signs, including the Glasgow Coma Scale score, to identify fever or indications of increased intracranial pressure. Skin. Examine the skin temperature and moisture and note any prominent tattoos. Scars may indicate self-mutilation in borderline personality disorders. Head. Inspect the head for evidence of trauma. Pupils. Check the pupils for size, equality, and reaction to light. Pupillary abnormalities may indicate a toxic ingestion or an intracranial process as the source of the patient's behavior. Odors. Note any unusual odors on the patient's breath such as poisons, alcohol, or ketones from diabetic ketoacidosis. Extremities. In examining the extremities, check for needle tracks, tremors, and unilateral weakness or loss of sensation. Detailed physical examination and ongoing assessment. Based on your transport time and the patient's mental status, a full head-to-toe assessment may not be practical. However, it is essential to perform a sufficiently detailed physical examination to rule out any medical or trauma problems. Additionally, transport time affords a good opportunity to assess more details of your patient's mental status and provide ongoing reassessment. Many times, patients with abnormal behavior may have settled down physically, but their minds may still be in a state of flux. This could lead to very impulsive behavior. Monitor patients vigilantly for sudden changes in thought or behavior, particularly as you near the hospital. If patients do not want help, they may try to jump from the ambulance or hurt themselves. Your report to the medical facility should include your usual report of medical and mental health history, medications prescribed, and assessment findings based on local or regional protocols and guidelines. Be sure to include pertinent information from the mental status exam to create a clear picture of your patient. If there is a need to control behavior, such as use of medications or physical restraints, be sure to notify the receiving facility so they can mobilize security or additional help prior to your arrival. General principles. The following guidelines apply to the care of any patient with a psychiatric problem. Be as calm and direct as possible. Patients who are disturbed are often frightened of losing self-control. Your behavior should indicate that you have confidence in the patient's ability to maintain control. One of the main purposes of the interview is to help the patient reestablish some self-mastery. If you show anxiety or panic, you merely affirm the patient's conviction that the situation is overwhelming. Exclude disruptive people. In most cases, you should interview the patient alone. Relatives and bystanders should wait in another room where your partner can interview them. Some patients, however, become anxious if separated from an important person, such as a parent or a friend. If another person has a calming effect on the patient, ask that person to remain present. Sit down to interview the patient. A 45-degree angle from the patient is preferable so you do not encroach on the patient's personal space. You should maintain a clear exit route at all times to allow for a rapid escape should the patient become aggressive. Maintain a non-judgmental attitude. Accept the patient's right to have his or her own feelings about things, and do not blame, judge, or criticize him or her for those feelings. Provide honest reassurance. Give supportive, truthful information. You might say, many people go through periods of hopelessness like you're having, but today we have effective treatments for those feelings. Avoid excessive reassurance, however, such as everything's going to be all right. Such statements will merely convince the patient that you do not understand how bad things are for them. Action plan. After the patient has finished telling his or her story, and you have concluded your assessment, develop a definite plan of action. This step gives the patient the feeling that something is being done to help, which in turn relieves anxiety. Furthermore, people in crisis need direction. Do not confront the patient with an array of decisions, for example, do you want to go to the hospital, or would you rather stay at home and call your doctor tomorrow? Rather, state what you think is the best course of action. I think it is important for you to go to the hospital. There are doctors there who can help you. Once the plan has been determined, and you have begun to carry it out, allow the patient to make choices, and thereby exercise some control over the situation. You might ask the patient, for example, whether he or she prefers to be carried on a stretcher or to walk to the ambulance on his or her own. These small decisions may seem minor, but they allow the patient to attain a measure of autonomy and self-respect. Encourage some motor activity. Moving about often helps ease anxiety. If you are taking the patient to the hospital, have the patient gather up the things he or she wants to bring along. Let the patients do as much for themselves as possible to reinforce the feeling that you expect them to improve. Stay with the patient at all times. Once you have responded to the emergency, the patient's safety becomes your responsibility. Do not allow the patient to leave you. For example, allowing the patient to go to the bathroom alone might allow the patient to swallow the contents of a bottle of pills. Bring all of the patient's medications to the hospital. If the patient is receiving treatment for psychiatric problems, knowing which medications have been prescribed can help physicians at the hospital identify the condition for which the patient has been treated. In addition, medications for other medical conditions may cause adverse effects or unusual interactions that alter behavior. Never assume that it is impossible to talk with any patient until you have tried. Even if the patient sits silently and appears unaware of your presence, assume that he or she can hear and understand everything you say. General management. General management of the patient with a psychiatric problem follows the approach stressed throughout this text. After ensuring that the scene is safe, which may require assistance from law enforcement personnel, focus on any life-threatening conditions discovered in the initial assessment. If immediate life threats are not present, perform a focused history and physical examination to uncover any medical abnormalities that should be considered. If the erratic behavior might possibly be caused by a medical disorder, for example, hypoglycemia, overdose, or hypoxia, treat the individual for the medical disorder before presuming that the patient's behavior is due to an emotional or psychiatric cause. These measures may include oxygen therapy, testing of the blood glucose level, and administration of 50% dextrose in water, as well as general interventions for hypothermia or shock management. Disorganization and disorientation are not diagnoses, but rather ways in which various conditions such as organic brain syndromes, for example, head injury, drug ingestion, and metabolic disorders, or schizophrenia may present themselves. These presentations account for a large number of ambulance calls, particularly for older people. While you do not need to make a specific diagnosis in such cases, you do need to know how to manage these patients in the pre-hospital setting. Disorganized patients are characterized by uncontrolled and disconnected thoughts. They are usually incoherent or rambling in their speech, although they may be oriented to person and place. Often such patients are found wandering aimlessly down a street, dressed peculiarly, uttering meaningless words and sentences. A thorough examination of such a patient is rarely possible, and your principal objective is to transport the patient to the medical facility without trauma. The disorganized patient needs structure. Explain in plain language what you are doing, and what the patient's role will be. Directions should be simple, consistent, and firm. It may be useless to try to take a detailed history. A name and address may be all that can be obtained. Explain to such patients that they need to be seen by a doctor, and that you will take them to the hospital to get help. In managing the patient experiencing disorientation, the key is to keep orienting the patient to time, place, and the people in the environment. Tell the patient who you are, and explain what you are doing. You may have to identify yourself several times en route. Reassure the patient, and point out landmarks that will help the patient orient himself or herself. Specific conditions. Anxiety disorders. Anxiety disorders are mental disorders in which the dominant moods are fear and apprehension. Everyone experiences anxiety occasionally, and a certain amount of anxiety helps people adapt constructively to stress. Patients with anxiety disorders, by contrast, experience persistent, incapacitating anxiety in the absence of external threat. Almost 1/5 of adults will experience some form of anxiety disorder in any given year. Several types of anxiety disorders, including generalized anxiety disorder, phobias, and panic disorder, are likely to elicit a call for an ambulance or affect the delivery of pre-hospital care. Generalized anxiety disorder. Although some anxiety in everyday activity is normal, when a person worries about everything for no particular reason, or if that worrying is unproductive and the individual cannot decide what to do about an upcoming situation, the person may be experiencing generalized anxiety disorder. To make a diagnosis of generalized anxiety disorder, symptoms, anxiety and worry, must be present more days than not for a period of at least 6 months, and the worry must be difficult to turn off or control. Generalized anxiety disorder is one of the most common anxiety disorders. Patients experiencing generalized anxiety disorder are often treated with both pharmacologic agents and counseling. The acute symptoms of anxiety and worry can become overwhelming in generalized anxiety disorder, however, prompting the patient, a family member, or colleague to call for an ambulance. When dealing with a patient with generalized anxiety disorder, identify yourself in a calm, confident manner. Listen attentively to the patient, and talk with the individual generally about his or her feelings. Phobias. Phobic disorders involve an unreasonable fear, apprehension, or dread of a specific situation or thing. The patient with a simple phobia focuses all his or her anxieties onto one class of objects, for example, mice, spiders, dogs, or situations, for example, high places, darkness, flying. Almost 1/10 of adults have social phobias, or fear of everyday social situations, such as fear of going to parties, meeting new people, or speaking or eating in public. When confronted with a feared object or situation, the person experiences intolerable anxiety, and all of the autonomic symptoms that anxiety brings. The patient usually recognizes that the fear is unreasonable, but is unable to do anything about it. In managing a patient with a phobia, explain each step of treatment in detail before you carry it out. First, we'll give you oxygen to help you breathe. Then we're going to move you onto the stretcher, so that we can carry you downstairs. Panic disorder. Panic disorder is characterized by sudden, usually unexpected, and overwhelming feelings of fear and dread, accompanied by a variety of other symptoms produced by a massive activation of the autonomic nervous system. Women are more likely to be affected by this condition than are men, and the disorder tends to run in families. The attacks usually begin when the patient is in his or her 20s. Most affected people can identify a stressful event that preceded their first attack, such as an illness or loss of a loved one. Thereafter, the attacks may come out of the blue, without any apparent precipitating stress. If allowed to continue, panic attacks may cause severe restrictions in the patient's lifestyle. The patient becomes afraid to go to work, to go shopping, or to leave the house at all, out of fear that an attack will occur away from home. The fear of going into public places is called agoraphobia, fear of the marketplace. The classic signs and symptoms of panic disorder are summarized in Table 40-3. A large percentage of the signs and symptoms, such as palpitations and sweating, are a consequence of autonomic nervous system discharge, while others, chest discomfort, paresthesias, may reflect hyperventilation. The symptoms usually peak in intensity within approximately 10 minutes and last approximately 1 hour. By the time you arrive at the scene, the patient having a panic attack may be surrounded by a horde of anxious and excited people, who will themselves contribute to the problem. Accordingly, you will need to take control of the situation quickly. Separate the patient from panicky bystanders. However, if you can find a calm friend or member of the patient's family, then having this person present may be helpful. Create a calm environment. The environment should be as calm as possible as you transport the patient to the hospital. Be understanding of the patient's condition. The patient having an anxiety attack may not be able to cooperate or answer questions at first because of intense fear and distress. Your manner must convey that everything is under control. Reassure the patient that he or she is safe. The word safe can often reduce symptoms to a more manageable level. We're going to take you down these stairs on the stretcher. It's going to be okay. We'll go slowly and be very careful to keep you safe while we move you. Give the patient's symptoms a name. After you have checked the patient's vital signs and the electrocardiographic monitor, reassure the patient that he or she is not in immediate danger of dying. I know that the sense of panic you're feeling is very distressing, but it's not life-threatening. Help the patient regain control. Encourage the patient to do things for himself or herself to the extent that he or she can, to help regain a sense of control. Panic attacks may mimic a range of physical disorders in their presentation. Conversely, symptoms of anxiety may be the chief complaint in medical conditions such as cardiac dysrhythmias, withdrawal states, anaphylaxis, hyperthyroidism, and certain tumors. Therefore, any patient experiencing a panic attack, especially a first panic attack, should be fully evaluated in the hospital. Hyperventilating patients should not be treated with paper bag therapy. If you use a paper bag, then patients whose anxiety results from an unsuspected pulmonary embolism or cardiac problem may experience serious complications and even die from the hypoxemia. Hyperventilation is best managed by coaching patients to slow their breathing until they regain control. Post-traumatic stress disorder. Traumatic events occurring in a general population have increased in both frequency and intensity in recent years. An acutely traumatic situation creates a great deal of stress for the person experiencing the trauma, as well as those around that person. You are not immune to this stress. Post-traumatic stress disorder is a severe form of anxiety that stems from a traumatic experience. In this condition, the individual relives the stress of the original situation. Causes of post-traumatic stress disorder can include military combat, terrorist attacks, motor vehicle collisions, or sexual assault. One symptom commonly associated with post-traumatic stress disorder is flashbacks, sudden memories in which the victim relives the event. Sleep disturbances, including nightmares, and depression or survivor guilt are other signs and symptoms of post-traumatic stress disorder. Treatment in the pre-hospital setting is intended to protect the patient, support the individual in a positive way, and transfer the individual to a medical facility for a more thorough evaluation. Medications for anxiety. Several classes of medications are effective in the treatment of anxiety disorders, including many antidepressants. In the past, medications that exert a tranquilizing or sedative effect, thereby reducing anxiety, were the most commonly prescribed, and overprescribed, psychotropic agents. Today, much safer medications, such as the selective serotonin reuptake inhibitors, are more frequently prescribed. Benzodiazepines serve such functions, as anti-anxiety agents, muscle relaxants, anticonvulsants, and sedatives. Unfortunately, they are often the source of overdoses. In addition to use of these medications for chemical restraint, Paramedics can administer benzodiazepines to treat status epilepticus and to provide sedation prior to external pacing or synchronized cardioversion. Beware of the signs and symptoms of potential overdose: severe hypoventilation, severe hypotension, bradycardia, slurred speech, altered mental status, and impaired coordination. Management of a benzodiazepine overdose includes airway management, intravenous fluids for hypotension, and the potential medical control option of flumazenil to reverse the effects of the benzodiazepine. Flumazenil should not be used in patients with chronic benzodiazepine use or mixed overdose due to the risk of inducing an acute withdrawal state or seizure. Mood disorders. Mood disorders, formerly known as affective disorders, are among the most prevalent psychiatric disorders. As much as 10% of the population will experience a mood disorder, such as manic depressive illness or a major depression, at some point in their lives. Although feelings such as depression and joy are universal, mood disorders differ from normal bouts of sadness or happiness. In mood disorders, the changes in affect are accompanied by other symptoms, and the net effect is to cause a major disturbance in the person's ability to function. Patients who experience either depression or mania have a unipolar mood disorder, that is, their mood remains at only one pole of the depression-mania continuum. Patients who alternate between mania and depression, both poles of the continuum, have bipolar mood disorder. The majority of patients with unipolar mood disorder have depression. Unipolar mania is relatively rare. Depression and suicidal behavior. Depression is the leading cause of disability in people between 15 and 44 years of age. It affects women more frequently than men, and may occur at any age. The mean age of onset is 32 years. The patient with depression is often readily identified by a sad expression, bouts of crying, and listless or apathetic behavior. He or she expresses feelings of worthlessness, guilt, and pessimism. These patients may want to be left alone, asserting that no one understands or cares, and that their problems are hopeless. Depression may occur in episodes with a sudden onset and limited duration. This is common in major depressive disorder, in which the patient feels substantial suffering and pain that interfere with social or occupational functioning. In other patients, the onset of depression may be subtle and chronic in nature. When a person experiences signs and symptoms of depression for most days over at least 2 years, he or she may be experiencing a chronic form of depression known as dysthymic disorder. The signs and symptoms of dysthymic disorder cause social and occupational distress, but rarely require hospitalization unless the individual becomes suicidal. The diagnostic features of depression are most easily remembered by the mnemonic gas pipes. Guilt and self-reproach are characteristic features of depression. One way to explore the patient's guilt feelings is to ask a question such as, "Are you down on yourself, or do you ever feel as if you're worthless?" Appetite is abnormal in depression. Usually it is decreased, but a minority of patients with depression may report increased appetite. Sleep disturbance usually takes the form of insomnia. The typical patient with depression reports that he or she awakens at 0300 or 0400 hours, and cannot get back to sleep. Paying attention is difficult for the depressed patient. The ability to concentrate is impaired, sometimes severely. Ask the patient, when you're reading a book or an article, can you get all the way through what you're reading, or does your mind start to wander after a couple of minutes? Interest. The patient with depression loses interest in things that were once important. He or she can no longer summon enthusiasm for work or hobbies. You might ask the patient, "Are you a local team name fan?" If the answer is yes, ask, "How are they doing this season?" The patient will tell you, "Well, I haven't really been following them lately." Psychomotor abnormalities. In the patient with depression, psychomotor abilities can be either increased, from agitation, or slowed. Although many patients seem to do everything in slow motion, a significant percentage of patients with depression show agitated behavior, such as pacing, wringing their hands, or picking at themselves. Energy. People with depression have no energy. They are tired all the time, and do not feel like doing anything. Suicide. Most worrisome, people with depression tend to have pervasive and recurrent thoughts of suicide. Medications for depression. Antidepressants are prescribed to combat the symptoms of depressive illness. The main types of antidepressants are as follows. Selective serotonin reuptake inhibitors are the most commonly prescribed medications for depression. Side effects include headaches, dizziness, sexual dysfunction, nausea, diarrhea, and insomnia. Abrupt cessation of selective serotonin reuptake inhibitors can cause a discontinuation syndrome that results in flu-like symptoms. Heterocyclic, tricyclic and tetracyclic antidepressants and related medications, like the neuroleptics, produce side effects that are either anticholinergic, for example, dry mouth, metallic taste, blurred vision, constipation, sedation, mydriasis, agitation, and delirium, or cardiotoxic, for example, nonspecific T-wave changes, prolonged QT interval, varying degrees of atrioventricular block, and atrial and ventricular dysrhythmias. Orthostatic hypotension is common in the older adult. Heterocyclic antidepressants are not often prescribed today because of these serious adverse effects. Monoamine oxidase inhibitors are recommended for atypical major depressive episodes. Monoamine oxidase inhibitors also are sometimes useful in selected cases of heterocyclic refractory major depression and panic disorder. One potential adverse effect is orthostatic hypotension, which, although occasionally severe, usually responds to supportive therapy. Other adverse effects include central nervous system irritability, including agitation, motor restlessness, and insomnia. Selective norepinephrine reuptake inhibitors include the very widely prescribed venlafaxine, Effexor. Miscellaneous agents include trazodone, which has many uses, depression, anxiety, sleep aid. Suicidal ideation. Suicide is any willful act designed to end one's life. It is the third leading cause of death among those 15 to 25 years of age, and the fourth leading cause of death in the 25 to 44-year age group. For people aged 45 to 64 years, suicide rates are the eighth leading cause of death. Although suicide attempts are more common among women, successful suicides are more common among men, especially those who are Caucasian and single, widowed, or divorced. The risk of suicide is also high among patients with depression, 1/6 of whom will succeed in taking their own lives. Alcoholism is another important risk factor. Notably, more than 1/2 of all successful suicides have made a previous attempt, and 3/4 have given a clear warning of their intent to kill themselves. The risk factors for suicide are summarized in Table 40-6. Suicide attempts typically occur when a person feels that close emotional attachments are endangered or when the person has lost someone or something important in his or her life. The person who is suicidal may also have feelings characteristic of depression, feelings of worthlessness, lack of self-esteem, and a sense of being unable to manage his or her life. Evaluation of suicide risk. The assessment of every depressed patient must include an evaluation of the suicide risk. Many paramedics are reluctant to ask a patient directly about suicidal thoughts because they fear that they might put ideas into the patient's head. You should realize, however, that suicide is not an original idea, and that a patient with depression will have thought of it. Most patients with depression, in fact, are relieved when the topic is brought up because it gives them permission to talk about their suicidal ideas. Often, it is easier for both the paramedic and the patient to broach the subject in a stepwise fashion. You might start by asking, "Have you ever thought that life wasn't worth living?" From there, you may proceed by degrees. "Did you ever feel that you would be better off dead? Have you ever thought of harming yourself? Do you feel that way now? Do you have a plan for going about it? Do you have the things you need to carry out the plan? Has anyone in your family ever died by suicide? Have you ever tried to kill yourself before?" Patients who have made previous attempts, those who have fashioned detailed, concrete plans for suicide, and those with a history of suicide among close relatives are at higher risk, and must be evaluated at the hospital. Many patients make last-minute efforts to communicate their suicidal intentions. When a person phones to threaten suicide, someone should stay on the line until the rescue squad has reached the scene. On arrival, quickly survey the area for any implements that the patient might use to injure himself or herself and discreetly remove those items. Be sure to protect your own safety. Encourage the patient to discuss his or her feelings. Ask about the patient's suicidal ideas and plans. Management of the patient at risk of suicide. Whenever you find a patient with severe depression or you have another reason to suspect that a patient is at risk of suicide, follow these guidelines. Do not leave the patient alone. The patient's well-being is your responsibility until he or she is transferred to the care of another medical professional. Collect implements. Bring any implements of potential self-destruction you may have found at the scene, pill bottles, weapons, to the medical facility. Acknowledge the patient's feelings. Do not argue with his or her wish to die, but provide honest reassurance. For example, it's not unusual for a person to feel like you do after losing someone close to them. Sometimes it helps to talk about it. Encourage transport. If the patient refuses transport, then try to get the people who are close to the patient to help the patient cooperate. If resistance persists, obtain police assistance. When a person has attempted suicide, medical treatment has priority. The patient who has taken an overdose of sedative or depressant drugs must be managed for possible respiratory depression or circulatory collapse. The patient who has slashed his or her wrists must be treated to control bleeding and restore circulating volume. Nonetheless, if the patient is still conscious, try to establish communication and ask the patient to talk about the situation. A person who attempts suicide is in enormous distress. Among the most important skills that any healthcare provider can acquire is the ability to see beyond another person's behavior to the underlying distress. When called to treat a person who has attempted suicide, say something to communicate empathy to the patient, such as, "Life must have seemed unbearable for you to do something like this. It's time to get some help." Such a statement is also a good reminder to yourself to be compassionate in such situations. Manic behavior. Mania is one of the most striking psychiatric conditions. Typically, a bystander or family member calls for an ambulance because the patient is unlikely to believe there is anything wrong. To the contrary, the manic patient is more apt to report being on top of the world. "I've never felt better in my life." People experiencing mania typically have an exaggerated perception of happiness, joy, or euphoria, with hyperactivity and insomnia. Medications for mania. Pharmacologic therapy for bipolar, manic depressive disorder usually requires multiple medications. Anti-anxiety medications may help reduce agitation or anxiety, while antipsychotic medications may help reduce psychomotor activity and delusions or hallucinations. Antidepressants may help reduce depression. While these agents may be used for a limited period of time, mood stabilizers are considered lifetime therapy for bipolar patients. Lithium carbonate and valproic acid, dipaquine, are most often used as first-line therapy. Unfortunately, some patients taking lithium preparations develop symptoms of toxicity, including nausea and vomiting, dysarthria, tremors, and lethargy. Lithium toxicity may lead to brain damage if not treated, so patients showing signs of toxicity require medical attention. Anti-epileptic medications such as valproic acid, dipaquine, or carbamazepine, Tegretol, are frequently used for those who do not respond to lithium, who account for 20% to 40% of bipolar patients. The mental status examination in the manic patient. In patients with mania, the mental status examination is likely to reveal the following findings. Consciousness. Awake and alert, but easily distracted. The patient may report an inability to concentrate. Orientation to time and place. Commonly disturbed in manic patients. Activity. Markedly hyperactive. Almost all manic patients report a significantly decreased need for sleep, and they may go for days without sleeping. Speech. Pressured and rapid. The patient is also very talkative. thought, flight of ideas and delusions of grandeur. Patients may report that their thoughts are racing, their monologues may skip rapidly from one topic to another, tangential thinking. Their ideas are often grandiose, such as unrealistic plans to embark on a large business venture or to run for high public office. Patients may also believe that they have special powers or they are famous and wealthy. Memory. Usually intact in those with mania, but may be distorted by underlying delusions. Affect. An apparently elated affect, the hallmark of mania. The patient seems to be on a high, and is unusually and infectiously cheerful. The good cheer may be quite brittle, however, and the person may quickly become irritable, sarcastic, and hostile with very little provocation. Perception may be disturbed. A person having an acute manic episode may show psychotic symptoms such as hallucinations. Management of the manic patient. People experiencing acute manic episodes often get themselves into trouble of one sort or another. They may go on wild spending sprees, make foolish business investments, drive recklessly, commit sexual indiscretions, or pick fights. Generally, it is when the person has gotten into some sort of trouble, or when his or her behavior has become intolerably disruptive, that an ambulance is summoned. Because manic patients are unlikely to consider themselves ill, they may not agree that they need treatment. When dealing with the manic patient, be calm, firm, and patient. Do not argue or get into a power struggle. Minimize external stimulation. Talk to the patient in a quiet place, away from other people. Meanwhile, have your partner obtain the history separately from relatives or bystanders. When it is time to transport, do not use sirens. If the patient refuses transport, consult direct medical control if available in your service. Obtain police assistance for transport if the patient continues to refuse, and hospital evaluation is necessary. Personality disorders. According to the American Psychological Association, personality disorders are a way of thinking, feeling, and behaving that deviates from the expectations of the culture, causes distress or problems functioning, and lasts over time. Common definitions of personality include an individual's distinctive character. How people think or behave in a world, and with others may be suspicious, outgoing, fearful, or overly dramatic. When these ways of relating to others become dysfunctional or cause distress to other people, that person is considered to have a personality disorder. Often, the person with the personality disorder does not feel any subjective distress, but such distress may be acutely felt by others. The DSM-5 classifies personality disorders into 3 clusters. The first includes disorders with odd or eccentric behavior, the second includes erratic or emotional behavior, and the third includes anxious or fearful behavior. True personality disorders are rare in the general population. When a person does have a personality disorder, the person is likely to have another psychiatric illness at the same time. Such patients tend to do poorly during treatment. For example, patients who are depressed in addition to having a personality disorder usually have more difficulty managing the depression when compared with patients who do not have a personality disorder. You may have difficulty treating personality disorders over the long term because of your limited interaction with patients. Nevertheless, you need to understand these abnormal behaviors so that you can respond appropriately when you encounter them. For example, a patient with an antisocial personality will not hesitate to hurt you if agitated, and a patient with a histriotic personality may be demanding and dictate the level of care. Be calm and professional in your interactions with patients exhibiting these traits. Somatoform disorders. People who are overly concerned with their physical health and appearance may have a somatoform disorder if their preoccupation dominates their life. A hypochondriac provides the classic example of a somatoform disorder. In hypochondriasis, patients have extreme anxiety or fear that they may have a serious disease. They are so convinced that they are ill that even a physician cannot convince them otherwise. With somatization disorder, people also have multiple complaints, but are more concerned with the symptoms than with their meaning. In conversion disorders, a physical condition, for example, paralysis, blindness, or seizures, has no identifiable pathophysiology, but results from malingering or faking a physical disorder. As opposed to conversion disorder, in factitious disorders, the symptoms the patient is experiencing are under voluntary control, but there is no obvious reason for them except to assume the sick role and receive extra attention. This type of behavior has also been referred to as Munchausen syndrome. When a parent, typically a mother, intentionally makes a child sick to garner attention and pity, it is referred to as factitious disorder by proxy or Munchausen syndrome by proxy. This is an atypical form of child abuse. Dissociative disorders. People who have mild feelings of being detached from themselves, as if they were dreaming, are said to be having a dissociative experience. When this dissociation becomes so intense that they lose their identity, and assume new ones or are unable to function because they have sustained a loss of memory or sense of reality, a dissociative disorder may be present. Somatoform and dissociative disorders have been linked historically and share many common traits. Management of these patients centers on careful observation to prevent injury and management of symptomatic signs and symptoms based on local protocols. Because treatment to correct the disorder is difficult and often unsuccessful, it should be carried out in the safety and security of a hospital. Talk with the patient about what is happening so you have detailed information to report to the hospital staff. A stressful event, exhaustion, or physical or mental pressures, usually extreme in nature, may cause a feeling of dreaming or slow motion. These alterations in perceptions of reality are often referred to as dissociative experiences. They can be either mild and readily explained or extraordinarily frightening. Two types of experiences are distinguished: depersonalization and derealization. You may have responded to a horrible motor vehicle collision where a patient described the event as dreamlike or as if time had stopped. In such a case of depersonalization, the patient loses his or her own sense of reality. In derealization, objects seem to change size or shape. People may seem dead or behave like robots. In their most severe forms, dissociative disorders result in abnormal functioning, amnesia, a trance, or even a new identity, formerly known as multiple personality disorder. Eating, impulse control, and substance-related disorders. Disorders of personal control, addiction, and substance use generally evolve over a relatively long period of time. Because of the chronic nature of these problems, emergency medical services will typically be called when an acute exacerbation of the underlying problem occurs. For example, when a bulimic patient experiences electrolyte imbalances that produce a sudden onset of weakness, dizziness, cardiac or respiratory problems, or seizures, or when an alcoholic sustains respiratory depression from binge drinking. Emergency management of these patients typically focuses on treating symptomatic reports and the presenting signs and symptoms. Eating disorders. The reported incidence of eating disorders began to increase rapidly in the 1950s and 1960s. Today, eating disorders are common in the developed world and are emerging as a problem in developing countries. Some countries are experiencing a fourfold increase in eating disorders. The people most likely to be affected by these disorders are young females of upper middle class or upper class socioeconomic status who live in socially competitive surroundings. There are two major types of eating disorders: bulimia nervosa and anorexia nervosa. In both forms, severe electrolyte imbalances may occur, leading to cardiac conditions, seizures, and renal failure, as well as erosion of dental enamel and salivary gland enlargement. Anxiety, depression, and substance abuse disorders are noted in as many as 2/3 of those diagnosed with eating disorders. Bulimia nervosa is characterized by consumption of large amounts of food, typically more junk food than fruits and vegetables. Many people with this disorder describe their eating as out of control. Most patients compensate for the binge eating by purging through vomiting, laxatives, diuretics, or excessive exercise. Patients with bulimia are humiliated by both the problem and the lack of control. People with anorexia differ from those with bulimia in one important way: they lose so much weight that they jeopardize their health, and even their lives. They may even binge, albeit on smaller quantities of food. People with anorexia lose weight by exerting extraordinary control over their food consumption. The typical person with anorexia has low body weight for age and height and demonstrates an intense fear of obesity despite being underweight. If the person with an eating disorder is a woman of childbearing age, then she may experience amenorrhea, the absence of menstruation. Impulse control disorders. People who have impulse control disorders lack the ability to resist a temptation or cannot avoid acting on a drive. Examples of impulse control disorders include intermittent explosive disorder, acting on aggressive impulses involving the destruction of property, kleptomania, acting on the urge to steal things, pyromania, acting on the urge to set fires, and pathologic gambling. Of course, not every arsonist has pyromania, and not everyone who steals has kleptomania. Impulse control disorders are typically associated with other disorders, such as depression, antisocial or borderline personality disorders, and Alzheimer's disease. Treatment relies on cognitive and behavioral interventions to identify underlying triggers and influences. This group of disorders is rare, only 4% of arsonists are diagnosed with pyromania, for example. Substance-related disorders. Substance-related disorders include psychological disorders associated with the use of alcohol, tobacco, illicit drugs, and other substances that change the way a person feels, behaves, or thinks. These cost thousands of lives, and billions of dollars annually. It was not until 1980 that substance-related disorders were recognized as a complex biologic and psychological problem rather than a sign of moral weakness, however. Substance-related disorders are grouped into 4 levels. In substance use, a person may use moderate amounts of a substance without seriously affecting activities of daily livings, for example, a social drinker. Substance intoxication describes use that results in impaired thinking and motor function, for example, a drunk driver. Substance abuse describes when the use of a substance disrupts activities of daily livings, for example, a person has difficulty with work, school, or relationships. Substance dependence describes an addiction to a substance. The person who is physiologically dependent often requires increasingly larger amounts to produce the same effect. An addict may display drug-seeking behaviors. Examples include the repeated use of the substance, taking desperate measures to ingest more of the substance, stealing money, or standing out in the cold to smoke a cigarette. Determining the most effective treatment for substance-related disorders requires an integrative approach of examining the social, biologic, cultural, cognitive, and psychological dimensions of the problem. It will be difficult for you to explore these areas during a short transport to the hospital, particularly because much of your time will be devoted to ensuring the safety of your crew, and the patient's airway, breathing, and circulation. Opioid use disorder, and unintentional drug overdose due to a drug supply that has become contaminated with high-potency opiates, such as fentanyl and carfentanil, has become a public health crisis in Canada. A rapid deterioration of consciousness of unknown cause in any patient may indicate superopiate intoxication, and naloxone, Narcan, should be given. Understanding the complex nature of substance-related disorders is the first step in providing professional, competent, and compassionate care to all affected people, from the homeless drug addict to the substance-dependent business person. Psychosis. Psychosis is a state of delusion in which the individual is out of touch with reality. Affected people are tuned into their own internal reality of ideas and feelings, which they mistake for the reality of the external world. To the person experiencing an acute psychotic episode, the line differentiating reality from fantasy is blurred, not distinct, as it is in those without psychoses. That internal reality may make patients belligerent and angry toward others. Alternatively, these patients may become mute and withdrawn as they give all their attention to the voices and feelings within. Psychoses or psychotic episodes result from many causes. These causes may be biologic or organic, or may result from mental illness or drug abuse. The use of mind-altering substances is one of the most common causes. Other causes include intense stress, delusional disorders, and, more commonly, schizophrenia. Some psychotic episodes last for brief periods, and that psychotic episode may be limited to the time that the substance is being metabolized within the body. The use of methamphetamine and derivatives can produce a prolonged psychotic state that often exceeds 24 hours in duration. Some episodes last a lifetime. Schizophrenia. Schizophrenia is a complex disorder that is neither easily defined nor readily treated, yet has a dramatic effect on society. 1 in 100 people will be affected by schizophrenia in their lifetimes. An estimated 0.2% to 1.5% of the world's population has schizophrenia. The typical onset occurs during early adulthood, with dysfunctional symptoms becoming more prominent over time. Some people diagnosed with schizophrenia display signs during early childhood. Their disease may be associated with brain damage sustained early in life. Other influences thought to contribute to this disorder include genetics, neurobiologic influences, and psychological and social influences. Patients with schizophrenia may experience positive, negative, or disorganized symptoms. Positive symptoms include delusions and hallucinations. Negative symptoms, a lack of normal behavior, include apathy, mutism, a flat affect, and a lack of interest in pleasure. Disorganized symptoms include erratic speech, emotional responses, and motor behavior. Schizophrenia can be divided into several subclasses. The paranoid type is characterized by delusions or hallucinations usually centered on a specific theme, while cognitive functions remain intact. People with a disorganized type of schizophrenia usually display the wrong emotion for a particular situation, and have disorganized speech behavior. Patients with the catatonic type display odd motor activity, such as strange expressions in their face or remaining rigid, while the undifferentiated type features behaviors that do not fit neatly into another category. Medications for psychosis. Antipsychotic medications are separated into two groups: atypical antipsychotic agents, and typical, traditional, antipsychotic agents, also known as neuroleptics. The pharmacokinetics of all antipsychotic medications are similar. Antipsychotic medications are listed in Table 40-9. Patients taking typical antipsychotic agents may occasionally experience an acute dystonic reaction, in which the patient develops muscle spasms of the neck, face, and back within a few days of starting treatment with the medication. An acute dystonic reaction can be rapidly corrected by giving diphenhydramine, Benadryl, 25 to 50 mg intravenously, but the muscle spasms are apt to occur after the diphenhydramine wears off. Typical antipsychotic medications also have atropine-like effects, anticholinergic effects, so patients taking antipsychotic medications may experience the side effects associated with atropine use, such as dry mouth, blurred vision, urinary retention, and cardiac dysrhythmias. The atypical antipsychotic agents are often used as first-line therapy because they not only relieve symptoms such as delusions and hallucinations, but also improve the patient's quality of life by reducing the affective symptoms of anxiety and depression and reducing suicidal tendencies. However, the atypical antipsychotic medications may cause metabolic side effects such as glucose deregulation, hypercholesterolemia, and hypertension. The mental status examination of the psychotic patient. The most characteristic feature of psychosis is a profound thought disorder, often accompanied by disturbances in mood and perception. The following list outlines disturbances of mood and perception. Consciousness. The psychotic is awake and alert, but may be easily distracted, especially if paying attention to hallucinations. If the level of consciousness is fluctuating, suspect an organic brain syndrome. Orientation. Disturbances are more common in organic disorders than in psychoses, but the patient with severe psychosis may be disoriented as to time and place. Activity. Most commonly accelerated, with agitation and hyperactivity, but it also may be reduced. Bizarre, stereotyped movements are common. Speech. May be pressured or sound strange because of unusual words that the patient has invented, neologisms. Thought. Disturbed in progression and content and may show any of the following disorders. Flight of ideas, with the patient's mind plunging from one thought to another. Loosening of associations, in which the logical connection between one idea and the next becomes obscure, at least to the listener. In extreme cases, the patient's speech may be entirely incomprehensible. Delusions, especially of persecution. Thought broadcasting, the belief that thoughts are broadcast aloud and can be heard by others. Thought insertion, the belief that thoughts are being thrust into his or her mind by another person, and thought withdrawal, the belief that thoughts are being removed. Memory can be relatively or entirely intact in psychosis. It may be difficult to obtain the cooperation of the patient for formal memory testing. Affect and mood likely to be disturbed in psychosis. The disturbance may take the form of euphoria, sadness, or wide swings in mood. Affect may reflect those inner states or be flat. Patients may have an inappropriate affect where they're happy when others would be sad, that is, laughing at a loved one's death, or sad when others would be happy, that is, feeling depressed at winning the lottery. Perception. Auditory hallucinations are common in psychosis. Patients hear voices commenting on their behavior or telling them what to do. Suspect that patients are hearing such voices when they seem to be attending a conversation other than yours or talking to themselves. Management of the patient with psychotic symptoms. Dealing with a patient with acute psychosis is difficult. The usual methods of reasoning with a patient are unlikely to be effective because the person has his or her own rules of logic, and these rules may be very different from those that govern non-psychotic thinking. Furthermore, you are likely to feel uncomfortable in the presence of a person with psychosis. Those uncomfortable feelings are one of your built-in diagnostic instruments. They are elicited by the fear, suspicion, and hostility that the patient is broadcasting through body language. Use your uncomfortable feelings to help make a tentative diagnosis of a psychotic problem, then proceed as follows. Assess the situation for danger to yourself or others. Identify yourself clearly, and explain your mission. I'm Gloria Goodhart. I'm a paramedic with the ambulance service, and this is my partner. Stand steadfast. We've come to see if we can help. Can you tell us about your problem? Be calm, direct, and straightforward. Your calmness and confidence can do a great deal toward calming the patient. Maintain an emotional distance. Do not touch the patient, and do not be overly friendly or effusively reassuring. Convey an attitude of emotional neutrality. Do not argue. Do not challenge patients regarding the reality of their beliefs or the validity of their perceptions. Do not go along with their delusions simply to humor them, but do not make an issue of the delusions either. Talk about real things. Explain your expectations of the patient. We're not going to let you hurt anyone with that baseball bat. Explain each step of management. Let's walk downstairs to the ambulance. Involve people the patient trusts. These may include family or friends. They can be helpful in managing the patient and gaining cooperation. Special considerations. Pediatric behavioral problems. Behavioral disorders are estimated to affect as many as 1 in 5 children and adolescents, with 2/3 of those having a mental health problem not receiving proper treatment. When not treated properly, such a problem will most likely persist into adulthood. Given that suicide is the 3rd leading cause of death in adolescents, and the 7th leading cause of death in school-aged children, medical professionals have given increased attention to mood disorders, anxiety, and other behavioral problems in this population. Children are also more likely to have coexisting problems, for example, attention deficit hyperactivity disorder, conduct disorder, and oppositional defiant disorder, along with the more traditional mental health disorders. Some undiagnosed developmental disorders in children can lead to difficulties with assessing and managing pediatric patients. Autism is characterized by abnormalities in social interactions, communication skills, and repetitive behaviors. Attention deficit hyperactivity disorder, on the other hand, is a developmental disorder that presents with distractibility and inattention, and can often be accompanied by hyperactivity. Mental health problems in children are difficult to diagnose because the lines between normal and abnormal behavior are less clear in this population. Diagnosis and treatment may be difficult when trying to distinguish among organic, genetic, and environmental causes. Cultural and ethnic factors also blur the line between normal and abnormal coping mechanisms. The mental status assessment of the child is similar to that of an adult, but takes the child's developmental level into consideration. Abnormal findings in the developmental examination and mental status examination are often related to adjustment disorders and stress rather than the more serious disorders. Your assessment of any child must include suicide risk. Geriatric behavioral problems. As people age, they are exposed to new experiences and changes to routines that may have been established over many years. Some of these experiences may result in physical and psychological changes in the older adult. For example, dementia, a gradual loss of mental capabilities, may result from Alzheimer's disease, chronic alcohol abuse, cumulative effects of multiple strokes, or nutritional deficiencies. The loss of loved ones or family moving away may cause loneliness. Financial worries, dissatisfaction with living arrangements, or doubts about the significance of one's life accomplishments may become a significant concern as well. Such thoughts often produce psychological distress and physical pain, which may manifest as abnormal behavior. Anxiety disorders, substance abuse disorders, particularly alcohol abuse, and mood disorders such as depression, and even suicide are common among older people. All too often, health care providers incorrectly consider anxiety and depression to be a normal part of aging, a belief that can be considered ageism. Ageism is discrimination against older people because of their age. To avoid engaging in ageism, and to provide proper care for the geriatric population, particularly those with mental health conditions, you must first identify your own attitudes toward older people and the mentally ill. With this awareness, you will be able to perform a complete physical and psychosocial assessment without bias, and will understand the complexity of caring for older people. Hostile and violent patients. Few situations are as difficult for the paramedic as dealing with a hostile, angry patient. It takes a great deal of maturity and a lot of experience to understand that anger may be a response to illness, and aggressive behavior may be the patient's way of dealing with feelings of helplessness. Sometimes the patient seems to be implying, "There's something very wrong with me, and you're not doing everything possible to help." The temptation is to respond with anger, but doing so rarely serves any useful purpose. Most angry patients can be calmed by a trained person who conveys an impression of confidence that the patient will behave well. It may be helpful to ask the patient directly about his or her anger. "Can you explain why you're so angry with me?" Giving the patient a chance to talk about these feelings often enables the patient to overcome them. One of the most difficult challenges a paramedic faces is a patient who is violent or threatening violence. He or she must prepare beforehand, both psychologically and tactically, to deal with hostile or violent behavior. An encounter with a violent patient carries the constant risk that someone may get hurt, including the patient, a bystander, the paramedics, or all of the above. Most paramedics are exposed to some form of violence during their careers. This violence can include verbal intimidation, verbal abuse, physical abuse, sexual harassment, or sexual assault. Stay alert for possible violent encounters, and take measures to prevent them. Assessing the potential for violence is not merely an academic exercise. In a 2014 published survey of 1,676 Canadian paramedics, 75% reported having experienced workplace violence in the past 12 months. Of those incidents, 67% reported verbal assault, 41% intimidation, 26% physical assault, 14% sexual harassment, and 3% sexual assault. The paramedic who does not look out for a possible violent encounter may become a statistic like those just cited. Identifying situations with the potential for violence. Preventive action starts with being psychologically prepared for a possible violent encounter, and keeping that possibility somewhere in the back of your mind and your response to every call. Do not rely too heavily on the information you get from your dispatcher. Being psychologically prepared for violence does not mean becoming paranoid or treating every patient with distrust. It does, however, mean developing a nose for danger, also known as survival awareness. Risk factors for violence. Scenarios in which violence is more likely to occur include any situation where alcohol or illicit drugs are being consumed, for example, tavern, party, incidents involving large crowds, and incidents in which violence has already occurred, for example, shooting, stabbing, domestic disturbances. People who are more likely to be violent include those who are intoxicated with alcohol or drugs, especially phencyclidine, PCP, lysergic acid diethylamide, LSD, amphetamines, and cocaine, experiencing withdrawal from alcohol or drugs, experiencing psychosis, especially manic and paranoid types, or experiencing delirium from any cause, for example, hypoglycemia, sepsis. The most important clues to the patient's potential for violence are found in the person's behavior and body language. Look for these warning signals. Posture. The patient who sits tensely at the edge of the chair or grips at the armrest. Speech. Loud, critical, threatening, full of profanity. Motor activity. Unable to sit still, pacing back and forth or in circles, easily startled. Other body language. Clenched fists, avoidance of eye contact, turning away when spoken to. Your own feelings. Your own gut response to the patient. If your instinct tells you that you are in danger, pay attention. Management of the violent patient. Once you have concluded, for any reason, that there is a potential for violence in a situation, take the following steps. Call for backup. This includes police attendants, if indicated, as well as other personnel who may be needed if a show of force or physical restraint is required. Assess the situation. Are factors in the surroundings contributing to the escalation of violence, for example, friends who are encouraging the patient's behavior? Can those factors be removed? Does evidence suggest drug use, alcohol use, or head injury? Can anyone present give you some background information? Did the patient's behavior come on gradually or suddenly? Does he or she have a history of violent behavior? Are there any known medical problems, such as diabetes? Observe your surroundings. Make sure you have an escape route. Place yourself between the patient and the door, but do not move behind an agitated patient. Do not turn your back on the patient, not even for a moment. Note any furniture or other potential barriers. Scan the area for anything that could be used as a weapon, for example, heavy or sharp objects, if the level of violence escalates. If a violent patient is armed with a weapon, do not try to deal with the situation yourself, back off and notify law enforcement authorities. Make sure that others at the scene are not endangered while you await the arrival of the police. Maintain a safe distance. Moving too close to a potentially violent patient is likely to increase his or her anxiety level. Maintain a safety zone of 2 arm lengths. If the patient is backing away from you, it is a sign that you are too close. Let the patient find a comfortable distance. Do not position yourself directly face-to-face with the patient, but rather slightly to the side at a 45-degree angle, with your escape route unobstructed. Try verbal interventions first. Anger and aggressive behavior are often responses to illness or to feelings of helplessness. Just talking to the angry person in a calm, sympathetic way may diffuse some of the anger. Take a moment to concentrate your own thoughts so that you can convey an impression of calmness and self-control to the patient. Identify yourself as medical personnel who is there to try to help. Keep your voice low. The technique forces the patient to stop what he or she is doing to focus on what you are saying. Acknowledge the patient's behavior, and restate your willingness to help. You look very upset. How can we help you? Encourage the patient to talk about what is bothering him or her. Listen to what is said, and show that you are listening by paraphrasing the words back to the patient. I think I understand. Are you saying that? Ask the patient specifically if he or she might lose control or is carrying any sort of weapon. Define your expectations of the patient's behavior. Acknowledge his or her potential to do harm. You could really hurt someone with that crowbar. But assure the patient that losing control will not be permitted. If verbal de-escalation is not working, back off and get help. Sir, I think we need to take a break to see if you can get hold of yourself, but I'm not leaving. We'll try talking again in a few minutes. If that doesn't work, then I'm going to have some people with me to keep you from hurting anyone. When verbal restraint fails, use physical restraint. Some restraint devices may be improvised from materials in the ambulance. Others are commercially made from leather or nylon that is padded for comfort and safety. Most commercial restraints are applied to the wrists and ankles to prevent movement of the arms and legs. Some are placed around the waist to restrict movement of the torso. Vest-type restraints are applied from the front of the patient, and may include sleeves to restrain the arms from moving. Make sure you are familiar with the restraints used by your agency before you enter a situation requiring their application. Make sure you have sufficient personnel before you attempt to overpower the patient. You must have overwhelming force to apply a physical restraint, which means a minimum of 5 trained, able-bodied people, 1 for each limb. Assign a specific limb in advance to each responder, and 1 for the head. Appoint 1 leader, who will direct the team, and maintain verbal contact with the patient. Sometimes the show of force may be enough to calm the patient. The mere sight of 5 police officers, for example, has been known to have a remarkably tranquilizing effect on even the most belligerent patient. Do not move toward the patient immediately. Give him or her a chance to make a graceful retreat to a non-violent alternative behavior. If the show of force does not calm the patient, emergency responders must prepare to restrain the patient. Remove any equipment or jewelry from your own body that could be used as a weapon, for example, name badge, scissors worn on the belt, keychain, earrings. Make sure you have adequate restraining devices, preferably padded leather or nylon restraints, immediately available. The best position in which to secure the patient to the stretcher is the supine position, with both legs and both arms secured to one side of the stretcher. This position will turn the patient's head to the side, so that he or she will not aspirate in case of vomiting. Never place your patient face down because you cannot adequately monitor the patient in this position. This position also may inhibit the breathing of an impaired or exhausted patient. Be careful not to place restraints in a way that compromises the patient's respirations. Never tie the patient's ankles and wrists together as one. This type of restraint has been known to result in death. Never hobble tie a patient, tying only the feet together. Placing a patient face down in a Reeves stretcher can also be dangerous and can lead to positional asphyxia or aspiration. Throughout the process, someone, preferably you or your partner, should talk with the patient. Remember to treat the patient with dignity and sensitivity at all times. Keeping the patient informed in a calm, respectful manner reduces the amount of stimulus the patient experiences. Once the restraints are in place, do not remove them. Do not negotiate or make deals. Continuously monitor the patient for clear airway and breathing, vomiting, airway obstruction, and cardiovascular stability. Drug or alcohol intoxication initially may cause violent behavior, but then can lead to physical problems such as vomiting and aspiration or respiratory depression. Additionally, check the patient's peripheral circulation every few minutes to ensure that the restraints are not too tight. Check the radial pulses in the arms, and the dorsalis pedis pulses in the feet. Be careful if a combative patient suddenly becomes calm and cooperative. This is not the time to relax. Continue to remain vigilant. The patient may suddenly become combative again and injure someone. Document everything in the patient's chart, the reasons for using restraints, be specific, giving examples of the patient's behavior, and the indications of the violence potential, the number of people used to subdue the patient, the restraining devices used, and the status of the patient's airway, breathing, and peripheral circulation after restraints were applied. Skill Drill 40-1 shows the steps for restraining a patient. Skill Drill 40-1. Restraining a patient. Step 1. Make sure you have enough personnel to perform this skill, 5 trained, able-bodied responders. Bring down the patient into the prone position. Then, acting at the same time, secure the patient in a supine or left lateral position with wrist and ankle restraints. Some services require the use of the backboard for restraint, so a patient who becomes unconscious or who vomits can be turned onto his or her side quickly to manage the airway. Step 2. Use stretcher straps or sheets to secure the patient's legs. Step 3. Fasten the remaining stretcher straps. Step 4. Continue to verbally reassure and calm the patient following physical restraint. Regularly check circulation to the extremities. This is the end of skill drill 40-1.
Chapter 39. Infectious and Communicable Diseases. Introduction. In 1913, Randolph Bourne said we can become as much slaves to precaution as we can to fear. This statement is particularly relevant to pre-hospital care because many paramedics are fearful when caring for patients who have or are suspected of having a communicable disease, that is, an infectious disease that can be passed from one person to another. A paramedic who does not understand how communicable diseases are transmitted, and how to take sensible precautions will be hesitant in caring for some patients, no matter what the cause of their illness. This chapter examines the ways in which communicable diseases are transmitted from one person to another. The communicable diseases that you are most likely to encounter in the course of your work are examined, as well as those illnesses that create the greatest anxiety among paramedics, and the public at large. Agencies responsible for protecting the public health. Several government agencies are responsible for protecting the health of the general public. Agencies at the national level include Health Canada and its Public Health Agency, the Public Health Agency of Canada. In Canada, the federal, provincial, and territorial governments jointly fund health care. However, health care and delivery of healthcare services is a provincial mandate. Provincial and territorial governments have different approaches to the delivery of public health services. In some cases, public health is managed at the provincial or territorial level, whereas in others it is managed at the local or regional level with provincial or territorial oversight. You should be familiar with the public health roles and responsibilities for each level of government in your province or territory. Regardless of which level of government bears the responsibility, the roles of public health departments and units include protection from disease, prevention of epidemics, and management of outbreaks. Although you may not feel that supervision of water quality, cleanliness of restaurants, and routine immunization and vaccinations programs relate directly to emergency care, clearly it is beneficial for emergency medical services agencies to know their local public health officials, and to work with them. When potential threats to a community's health exist, the severe acute respiratory syndrome outbreak in Toronto, the West Nile virus outbreak in Winnipeg, or the Escherichia coli, E. coli, outbreak in Calgary, a close working relationship between paramedics and public health agencies is essential. If you do not know your local public health professionals and officials, reach out to them and learn who they are. Host defense mechanisms. The human body provides built-in protection from pathogenic organisms with several defenses that protect against infection. Blood-borne pathogens are microorganisms that are present in human blood and can cause disease in humans. These pathogens include, but are not limited to, hepatitis B virus and human immunodeficiency virus. Skin, which covers the entire exterior of the body, offers a primary protective barrier, blocking pathogens' ability to enter through the intact surface. The normal secretions of the skin also provide an antibacterial property that protects against pathogen entry. Mucous membranes offer another protective barrier. For example, the eyes produce tears that dilute and remove foreign substances. The mucous membranes that line the urinary, respiratory, and gastrointestinal tracts also trap and remove organisms. Cells that line the respiratory tract secrete lysozymes that destroy bacteria, and macrophages trap and destroy bacteria. Thus, these mucous membranes serve as the first line of defense against airborne and droplet-transmitted diseases. Goblet cells lining the gastrointestinal tract produce highly acidic and alkaline secretions, which form barriers and prevent penetration by bacteria and some viruses. The immune system contains proteins that kill viruses. Immune response initiates the production of antibodies that are directed against specific invading organisms. Both B cells and T cells work together to fight infection. The cycle of infection. Infection involves a chain of events through which the communicable disease spreads. In some cases, solving the puzzle of why a particular individual or group of individuals developed a specific disease may be as simple as retracing steps to find the source of exposure. In other cases, the puzzle is more difficult to solve. It may take infectious disease experts years to find a pattern in the spread of a disease, and then to plan a strategy to break the chain of the infection. The study of infectious diseases takes into consideration population demographics that can affect the spread of a disease, such as age distributions, genetic factors, income levels, ethnic groups, workplaces and schools, geographic boundaries, and the expansion, decline, or movement of the disease. Here is a scenario that illustrates how easily disease may spread. In a local hospital pediatric unit, a visitor brought a box of candy for a child. Because of the no food rule, his attentive nurse placed the candy at the nurse's station. Another nurse had emptied a bedpan of stool from a child admitted for hepatitis A infection, but was in such a rush that she forgot to wash her hands. She then noticed the box of candy, poked a few selections, and finally found one she wanted to eat. The candy was consumed throughout the morning. Subsequently, another nurse came down with hepatitis A, a disease that is typically spread by the oral-fecal route. The chain of infection in this scenario could have been broken by hand washing. Transmission of communicable diseases. By the very nature of your work, you will come in contact with sick people. A certain proportion of those sick people have communicable diseases. Communicable diseases can be transmitted from one person to another under certain conditions. These conditions are listed in the formula for infection, and are dependent on dose, virulence, mode of entry, and the health status of the host. Infectious diseases cause illness in the patient, but do not always pose a risk to the healthcare provider, because not all infectious diseases are communicable. To understand the principles of prevention, you must first understand how diseases are spread. Communicable diseases are caused by pathogenic microorganisms, usually bacteria or viruses, but sometimes fungi and parasites. They spread from person to person by several specific mechanisms. Airborne transmission. Transmission of viruses and bacteria that, when expelled from the respiratory tract, are light enough to float in the air for a long enough period of time to be inhaled by another person. There are 3 common diseases that can be transmitted person to person via the airborne route: tuberculosis, measles and chickenpox, varicella. Airborne diseases are affected by air currents and ventilation, which may reduce their numbers, and thereby reduce their infectivity. The risk of spread of airborne diseases is minimized through good ventilation, use of respirators, and covering the patient's mouth, when coughing or otherwise. Droplet transmission. Transmission of disease is expelled from the body in large respiratory droplets through coughing and sneezing. These droplets are heavy, and only travel from 1 to 2 meters away from the person before gravity forces them to fall. They can be either inhaled, or they can land on unprotected mucous membranes of the eyes, nose, and mouth if you are within 2 meters of the person when they cough or sneeze. Large respiratory droplets can also be picked up off of surfaces by hands, and directly transferred to the eyes, nose, and mouth through touch. Diseases spread through droplet transmission usually cause symptoms of an acute respiratory illness, and include fever, coughing, and sneezing. The risk of spread of droplet-transmitted diseases is minimized through the use of barrier personal protective equipment, such as eye protection, gloves and gowns, covering the nose and mouth of a patient who is coughing or sneezing, proper decontamination and disinfection of equipment, and hand hygiene. Contact transmission. Transmission of diseases picked up from the environment, and transferred to non-intact skin or unprotected mucous membranes by unclean hands or pieces of equipment. Examples of diseases spread through contact include pink eye, conjunctivitis, and impetigo, caused by Staphylococcus aureus. Diseases spread through droplet transmission, such as influenza, can also be picked up from the environment when heavy respiratory secretions land on surfaces. The risk of contact-transmitted diseases is minimized through the use of barrier personal protective equipment such as gloves and gowns, property contamination and disinfection of equipment, and hand hygiene. Vehicle transmission. Diseases such as hepatitis A or B, salmonella, and E. coli can be transmitted when humans ingest contaminated food or come into direct contact with contaminated blood, such as a needle puncture. Vector-borne transmission. Disease is transmitted to humans via an intermediate carrier or reservoir. Examples of vector-borne diseases include malaria, rabies, and West Nile virus, where the carrier is a flea, mosquito, or other animal. Providers cannot acquire the infection from the patient directly, as infection only occurs when bitten or stung by the carrier or reservoir. Several factors determine a person's actual risk of contracting an infection following an exposure. An organism's mere presence presents a risk. However, other factors influence the level of risk, including the dosage of the organism, the virulence of the organism, its mode of entry, and the host resistance of the exposed person. Type of organism. Pathogenic organisms may be bacteria, viruses, fungi, or parasites. Bacteria grow and reproduce outside the human cell in an environment characterized by the appropriate temperature and nutrients. They cause disease when they invade and multiply in the host. Salmonella bacteria, for example, can multiply in potato salad that has been unrefrigerated, leading to human illness when the food is eaten. Viruses are much smaller than bacteria, and can multiply only inside a host. Viruses die when exposed to the environment. They cause disease when they invade and multiply within the host's tissues. For example, human immunodeficiency virus does not multiply or maintain its infectiousness outside a living host. Fungi are similar to bacteria in that they can grow rapidly in the presence of nutrients and organic material. Most fungal infections are acquired from contact with decaying organic matter or from airborne spores in the environment, for example, mold. Fungi often cause opportunistic infections in people with compromised immune systems. They range from relatively harmless infections of the skin, such as athlete's foot, tinea pedis, to life-threatening systemic infections, such as pneumonia, Pneumocystis jirovecii, formerly known as Pneumocystis carinii, in people with acquired immunodeficiency syndrome. Parasites live in or on another living creature. They take advantage of their host by feeding off its cells and tissues. Scabies and lice are examples. Parasites include both protozoa, single-celled, usually microscopic, eukaryotic organisms such as amoebas, ciliates, flagellates, and sporozoans, and Amoeba histolytica, for example, causes dysentery, and helminths, commonly called worms, which are invertebrates with long, flexible, rounded, or flattened bodies. An example of a helminth is Ascaris lumbricoides, which causes hookworm. Dosage of the organism. A certain number of organisms must be present for infection to occur. For example, a vast number of Salmonella organisms, 1 million to 100 million, are necessary to produce foodborne illness, but as few as 500 Campylobacter bacteria can also cause illness. Virulence of the organism. Virulence is the ability of an organism to invade and create disease in a host. It also encompasses the organism's ability to survive outside the living host. For example, human immunodeficiency virus does not pose a risk outside the human body because it dies upon exposure to light and air, while bacterium such as Salmonella can multiply every 15 to 20 minutes in the presence of the right temperature and nutrients. Mode of entry. If the organism does not enter the body by the correct route, infection cannot occur. For example, a respiratory virus that enters the body through a cut will not cause a respiratory infection, and likely will not cause any infection. However, an inhaled respiratory droplet could cause respiratory illness. Thus, if you apply a mask to a patient who might have a communicable respiratory disease, you will not inhale the droplets. Host resistance. The healthier you are, the less susceptible you are to infection. Your ability to fight off infection is called host resistance. Your immune system will protect you from acquiring disease even if all other risk factors may be present. Wellness programs and immunization programs serve to boost host resistance. Once a susceptible person has been exposed to an organism, it takes time for the organism to multiply within the body and produce symptoms. That period between exposure to the organism and the first symptoms of illness is called the incubation period. For example, it usually takes 12 to 26 days from a susceptible person's exposure to the mumps virus until the patient begins to feel feverish and unwell. The incubation period for the influenza virus is much shorter, usually 24 to 72 hours. Most communicable diseases are contagious only during a portion of the illness. A person may be sick with chickenpox for 2 to 3 weeks, but is capable of transmitting the virus to another individual for only approximately 1 week, from one day before the vesicles appear on the skin to 6 or so days after. The period during which a person can transmit the illness to someone else is called the communicable period. It is important to note that some diseases may be communicable prior to the onset of signs and symptoms. Hence the importance of routine infection prevention and control practices whenever potential exposure to body fluids may occur. Just as exposure and infection are different concepts, it is also necessary to distinguish between contamination and infection. An object that has microorganisms on or in it is contaminated. This term applies to water, food, dressing materials, linens, sharps, equipment, and even the ambulance. A person is not infected, however, unless the microorganisms actually produce an illness. With some diseases, such as hepatitis B or C viral infection, a person may have the disease and not be aware of it. There are no signs or symptoms, and the person is not ill. However, such carriers can pass the disease on to others through their blood or through sexual contact. In the context of communicable disease, a reservoir is a place where organisms may live and multiply. In institutional settings, for example, air conditioning systems and shower heads have been identified as reservoirs for the bacterium that causes Legionnaire's disease. In ambulances, the oxygen humidifier is commonly implicated as a reservoir for infection. Obviously, you have a responsibility not only to protect yourself from contracting communicable diseases, but also to ensure that you and your equipment do not transmit illness to others. Precautions for the paramedic. Although the risk of contracting a communicable disease is real, it should not be exaggerated and certainly should not be a source of fear and stress. Fear comes from lack of proper education and training, and there's no reason you should not be properly educated about disease transmission. Public Health Department. Provincial and local health departments are responsible for many activities related to infectious or communicable diseases, including collecting data on the incidence of diseases, performing contact follow-up, and running tuberculosis and immunization clinics. Each province also has a list of communicable diseases that, if identified, require reporting to public health officials. The goal of immediate reporting of these diseases is to ensure the rapid identification, control, and treatment of specific communicable diseases that may pose a threat to the health of the population should they occur in the community. Paramedics play a role in reporting diseases to public health officials if they identify any disease on the mandatory reporting list, and each emergency medical services service should have a system to facilitate this reporting. Public health departments also play a major role in outbreak investigations. The Public Health Department acts as a backup for exposure notification and determination of the need for medical follow-up treatment. The Public Health Department Medical Officer of Health, or their designate, serves as a liaison for problems that may arise regarding exposure notification by the medical facility, and the sharing of source patient testing results. The Public Health Department collects all disease statistics for each locality and shares the information with the provincial and federal government. Routine practices. Health Canada introduced routine practices in 1999. Routine practices merge aspects of universal precautions and body substance isolation into a new, more comprehensive standard of practice that relies on knowledge of signs and symptoms and communicable disease modes of transmission rather than diagnosis. The goal is for paramedics to use appropriate infection prevention and control measures when they recognize any potential sign or symptom of a communicable disease. Early recognition and appropriate protection may reduce the risk of acquiring and transmitting a communicable disease. You should use routine practices for every patient contact because all patients are potentially infectious. The components of routine practices include the following: hand hygiene, personal protective equipment, sharps safety, Patient accommodation and transport considerations. Routine equipment cleaning. Routine vehicle cleaning and disinfection. Routine practices require that equipment used to care for a patient and the environment in which the patient is cared for are cleaned and disinfected after each and every patient. This reduces the risk of spread of infection to patients and also to paramedics themselves. Routine practices must be included in every paramedic's daily practice. Additional precautions may also be needed, depending on the mode of transmission of a known or suspected infectious disease. A good sample history may identify a known infectious disease, and additional precautions may be necessary. For example, a patient with a cough, weight loss, and night sweats may be suspected of having tuberculosis. To take precautions against tuberculosis, additional precautions to prevent spread of airborne disease are needed. Asking whether a patient has recently traveled outside of the country may identify a patient with a higher risk of unusual infectious diseases. Knowing whether other contacts of the patient have been sick, such as close family members or other residents in a chronic care facility, will also give clues to the presence of a communicable disease requiring additional consideration for infection prevention and control precautions. Your service should have an infection prevention and control manual outlining routine practices and additional precautions necessary for specific suspected or known communicable diseases. You are urged to refer to this manual for specific, detailed procedures to protect yourself and your patients. Recommended immunizations and vaccinations. Keeping current with recommended vaccines and immunizations boosts host resistance and the immune response. It is up to each province and territory to determine a routine schedule of immunization and what parts of the program receive public funding. The federal government's National Advisory Committee on Immunizations and the Canadian Immunization Guide provide detailed information regarding immunizations. The effectiveness of provincial or territorial childhood immunization programs in Canada has eliminated wild-type poliovirus and decreased the incidence of Haemophilus influenzae type B and measles infections by more than 95%. However, in recent years, the reluctance of people to get themselves or their children immunized has led to a resurgence of several vaccine-preventable diseases. The most recent example is measles, with outbreaks occurring in Canada, the United States, and other developed countries. As a healthcare provider, you have a responsibility to protect your patients and prevent the spread of communicable disease. One very effective way to do so is to ensure that you are immune to common infectious diseases. If you are not, vaccination is the best way to get and maintain your immunization status against certain communicable diseases. The regulations regarding immunity and vaccination vary by employer and jurisdiction. It is your responsibility to ensure that you are appropriately immunized. You may have the right to decline immunization, but if you decline immunization, you may be prevented from working in certain circumstances, such as a communicable disease outbreak, when your non-immunized status poses a risk to your patients and colleagues. Personal protective equipment. Personal protective equipment serves as a secondary protective barrier beyond what your body provides. The selection and use of personal protective equipment depend on the task and procedure at hand. Your emergency medical services infection prevention and control manual should contain a listing of its risk procedures and the recommended use of personal protective equipment. All personal protective equipment and patient care equipment should be latex-free. Health Canada states that hand washing is the single most important procedure for preventing infection. Contaminated hands are a frequent cause of infection in the healthcare setting. Hand washing includes both washing the hands and proper skin care. Paramedics should pay attention to the condition of their skin and use moisturizers, as required. Moisturizers help prevent dry, cracked skin. Healthy, intact skin is an effective barrier to infection. One standard for hand washing is the use of antimicrobial soap, alcohol-based foams, or gels. However, you should note that most alcohol-based products are not a substitute for hand washing when hands are dirty or grossly contaminated. In addition, alcohol-based products do not remove organisms that form spores, such as Clostridium difficile. If C. difficile infection is known or suspected, you must wash your hands with soap and water to properly remove the spores and prevent cross-contamination. The best practices for performing proper hand hygiene include the following. At the beginning and end of the shift. Before and after patient contact. Prior to putting on and after removing personal protective equipment. Before any invasive procedures. After cleaning or disinfecting equipment and the vehicle. Before leaving the hospital. Before and after handling food. Before and after smoking. After personal body functions, sneezing, coughing, using the bathroom. Anytime hands are visibly soiled. Anytime you cannot remember when your hands were last washed. You should consider the following points when washing your hands. Remove all hand and wrist jewelry. Jewelry should be cleaned and disinfected prior to being put back on. Do not wear artificial nails. Use warm water. Use adequate amounts of soap or hand sanitizer. Rub the hands vigorously to create friction. Wash for at least 20 seconds, ensuring that all parts of the hands and wrists are covered. Rinse well with water. Refrain from habits such as nail biting. Avoid hand contact with the mucous membranes and conjunctiva. If you have open cuts or sores on your hands, you should cover the area with a dressing. If the area is too large to cover, you should not perform high-risk tasks and procedures. Personal protective equipment should consist of, but not be limited to, disposable gloves, protective eyewear, cover gowns, surgical masks, N95 respirators, or similar semi-micron respirators, waterless hand-washing alcohol-based foam or gel, needle-safe or needle-less devices, biohazard bags, and resuscitative equipment. Personal protective equipment, save for submicron particulate respirators, and protective eyewear, should never be worn in the driver's compartment of a vehicle because it may contaminate surfaces and equipment. The exception to this is when transporting a patient with signs and symptoms of a respiratory illness such as severe acute respiratory syndrome or a viral hemorrhagic fever. Although controversy may exist regarding the necessity of a submicron particulate respirator over a standard surgical mask, many emergency medical services agencies in Canada use this level of respiratory protection. You should use a submicron particulate respiratory mask, or the mask dictated by local or regional regulations, under the following circumstances. Febrile patient without a known source. Coughing patient. Patient with a communicable disease transmitted by respiratory droplet or airborne routes. When blood or body fluid splash is likely. When performing procedures such as intubation or suctioning that could result in aerosolization. When cleaning the vehicle and equipment following the transport of a patient with a known or suspected communicable disease transmitted by the airborne or the respiratory droplet route. When cleaning gross amounts of blood or body fluids. Gloves should be non-latex, vinyl, nitrile, or rubber to help reduce the risk for developing latex allergy or sensitivity. You should use gloves in the following situations. When a patient is febrile without a known source. When there is the possibility of blood or body fluid contact. When in contact with mucous membranes or non-intact skin. When there is non-intact skin on the hands. When performing procedures such as intravenous line insertion, intubation, or any other invasive procedure. When treating or transporting a patient with a known or suspected communicable disease transmitted by contact, respiratory droplet, or airborne routes. When cleaning the vehicle and equipment following patient transport. You should always remember that gloves are an additional measure, and not a substitute for proper hand hygiene. In addition, hand hygiene should never be performed with gloves on because soap and hand sanitizers break down the integrity of gloves. You should not handle personal items or items in the driver's compartment of the ambulance when wearing gloves, because you may contaminate these items. Utility-style gloves, dishwashing gloves or similar, should be used for cleaning activities. These are washable and reusable as long as they are free of tears or holes. Hands should be washed after glove removal because gloves are not a primary protection. Many gloves contain holes, and can absorb viruses and bacteria. This is termed viral penetration. Surgical masks protect against splatter into the mouth or nose. Patients thought to have airborne or droplet-transmitted diseases may be asked to wear them because they filter what goes out through the mask. N95 respirators are required for severe acute respiratory syndrome, smallpox, and patients with active tuberculosis. The N95 respirator may also be considered when caring for a patient with an infection that may be transmitted via the droplet or airborne route. A full respiratory protection program must be in place if these devices are on emergency medical services vehicles. A respirator filters what comes in through the mask. Note that an ill-fitting respirator provides false assurance and inadequate protection from diseases spread via the airborne route. You should ensure that you know which mask fits you through appropriate fit testing. In the event of changes in facial structure, such as due to significant weight loss or gain, fit testing should be repeated to ensure that the mask selection remains appropriate. Protective eyewear blocks splatter of blood and body fluids into the eye. Prescription glasses may be worn with disposable or reusable side shields. To prevent contamination, you should not touch your eyes or face during care for a patient. Remove eye protection carefully to prevent self-contamination. Finally, perform appropriate hand hygiene after removing eye protection. Goggles should not be worn over prescription glasses because vision may be distorted. If you wear contact lenses, you should be aware that your lenses may become contaminated if goggles or other protective eyewear are not worn. Some emergency medical services also provide protective face shields. The face shield provides additional protection for your eyes and face. Face shields are particularly useful when performing advanced airway skills, such as airway insertion and intubation, or when there is a danger of blood or body fluid splash. As with other eye protection, face shields must be removed carefully to prevent self-contamination, and proper hand hygiene is necessary after removal. Cover garments are recommended for large splash situations such as childbirth or managing an uncontrolled hemorrhage. Gowns can be washable or disposable. If they are washable, the gowns should be washed in a designated decontamination area at the base or sent out for laundering to a service equipped to handle contaminated clothing. You should never take contaminated garments home. If using gowns or other cover garments, you must ensure that the gown covers you completely in the front and in the back. You must also remove the gown once patient care responsibilities are complete and wash or discard it according to local procedures. Gowns and disposable garments must not be worn in the driver's compartment of the ambulance. The final part of personal protective equipment is knowing how to put it on and remove it properly. Knowing the proper sequence ensures that you are adequately protected and prevents you from self-contamination. When putting on personal protective equipment, follow this order: gown or coveralls, submicron particulate respirator mask, eye protection, and then gloves. When removing personal protective equipment, remove the gloves first, then the gown or coveralls, eye protection, and finally the submicron particulate respiratory mask. Gloves are removed first because they are likely the most contaminated. When removing personal protective equipment, always remember to practice proper hand hygiene. Removing personal protective equipment is when you are most likely to contaminate yourself. If you suspect that you might have contaminated your hands during the process of removing personal protective equipment, do not hesitate to clean your hands with an alcohol hand rinse as often as needed during the process. Give particular attention to avoiding touching clean clothing or skin with contaminated gloves. The most frequent cause of bloodborne infection in healthcare settings is a needle stick injury. There are an estimated 50,000 needle stick injuries to healthcare workers each year in Canadian hospitals. Paramedics handling sharp devices are at risk of occupational exposure to bloodborne infectious agents. The risk is very low, but it is necessary to have a sharp safety system for handling all sharps to prevent injuries. To handle sharps safely and prevent injuries, you should do the following. Communicate with other personnel, for example, sharps out, sharps clear. Count the number of sharps used and ensure that all of them have been disposed of at the end of the procedure. Dispose of sharps in an appropriate sharps container immediately after use. Never leave sharps to be disposed by other personnel. Never carry uncapped sharps in pockets. Never pass exposed sharps from person to person. Remain clear of the person using the sharp. Do not recap needles. Never bend or break a needle. Use a needleless system and use safety cannulas and needles. Dispose of sharps containers in an appropriate biohazard container when the full line is reached. All needle stick injuries should be reported to an immediate supervisor. you should be assessed promptly by a physician at the local emergency department to determine the risk of infection and the need for post-exposure prophylaxis. Post-exposure medical follow-up. Post-exposure medical follow-up is your third line of defense against communicable diseases. If an exposure occurs, you should immediately seek medical care in the local emergency department. This will ensure that you receive proper medical treatment, including counseling and post-exposure prophylaxis, if necessary, to protect you against the disease to which you were exposed. Post-exposure medical prophylaxis, prevention, is available for many diseases, except hepatitis C virus infection. If hepatitis C virus is acquired, it can often be cured. Exposure to blood-borne pathogens can occur in several different ways. A contaminated needle stick injury. Blood or other potentially infectious materials splattered into the eye, nose, or mouth. Blood or other potentially infectious materials in contact with an open area of the skin, fresh cut or abrasion or dermatitis. Cuts with a sharp object covered with blood or other potentially infectious materials. Human bites involving blood exposure. The source is the person who is bleeding, not the biter. If one of these events occurs, you should contact your supervisor and seek medical attention immediately. Post-exposure medical management begins with the source individual, not the exposed employee. Blood work for the source patient includes human immunodeficiency virus testing, hepatitis B virus antigen, and rapid hepatitis C virus antibody, if the human immunodeficiency virus or hepatitis C virus test is positive. Syphilis testing also occurs. Human immunodeficiency virus testing requires patient consent, but your jurisdiction may have an exception for occupational exposure of healthcare providers. Post-exposure medical counseling and treatment should begin within 24 to 48 hours, unless testing of the source patient yields information that necessitates more rapid follow-up. Department responsibilities. Every emergency medical service must have a comprehensive infection prevention and control manual and plan to protect its staff from exposure to blood-borne pathogens. This document lays out the specifics of how the service plans to reduce the risk of exposure to infectious agents and provide post-exposure medical follow-up if needed. Key elements of the manual and plan include proper education and training related to blood-borne pathogens and airborne and droplet diseases, and establishment of post-exposure medical follow-up procedures. Another key component of the plan is compliance monitoring. Management must make spot checks to ensure that staff members are following the infection prevention and control plan and that the plan is working effectively. Although management is responsible for developing and implementing the plan, employees are required to follow the plan. A part of the infection prevention and control plan that will benefit both department personnel and patients is the work restriction guidelines. These guidelines indicate when employees with various illnesses may or may not be at work, and when they may not care for high-risk patients. Work restriction guidelines require employees to use sick time, unless the illness is the result of an occupational exposure, in which case it is covered under workers' compensation. Following work restriction guidelines is particularly important during the flu, respiratory influenza season. General assessment principles. The assessment of a patient suspected to have an infectious disease should be approached much like any other medical patient. First, the scene must be evaluated for safety, and routine practices taken. Once you can be ensured that the scene is safe, proceed with the initial assessment, assess the patient's mental status, airway, breathing, and circulation, and prioritize treatment of the patient. With most patients who have a potentially infectious disease, and are being seen in the pre-hospital setting, the next step will be a focused history and physical examination, using the OPQRST mnemonic to elaborate on their chief complaint. Typical chief complaints include fever, nausea, rash, pleuritic chest pain, and difficulty breathing. Be sure to take a sample history and obtain a set of baseline vital signs, giving particular attention to medications the patient is currently taking, the events leading up to today's problem, and also whether the patient has recently traveled. Always show respect for the feelings of patients, family, and others at the scene. General treatment principles. The general treatment of the patient with the suspected infectious disease first focuses on any life-threatening conditions that were identified in the initial assessment, airway maintenance, oxygen and ventilatory assistance, bleeding control, and circulatory support. Remember to be empathetic. Because most of these patients will have a fever of an unexplained origin or mild breathing problems, place the patient in the position of comfort on the stretcher, and keep him or her warm. If the patient has early signs of dehydration, a preliminary intravenous line, and a fluid infusion of normal saline or lactated ringer solution may be appropriate. Remember to take standard precautions, and to properly dispose of sharps, even needle-safe devices. Always follow your agency's infection prevention and control plan in cleaning the suction unit, and any reusable equipment, and properly discard any disposable supplies and linens. Airborne diseases. Common communicable diseases of childhood. The most striking aspect of common communicable diseases of childhood is that they are no longer so common, at least not in developed countries. 40 years ago, few children reached their teens without having had measles, chickenpox, and usually mumps. In Canada, all children are offered a wide range of immunizations against many vaccine-preventable diseases. Most of these immunizations are provided free of charge by provincial and territorial governments, but which vaccines are free varies by province and territory. Canada has a very high rate of immunization against preventable diseases, and has virtually eliminated many of them. Nonetheless, there are still sporadic cases, and even occasional epidemic outbreaks of those diseases, including some related to religious waivers from vaccination. Measles. Measles, also known as rubella, hard measles, or red measles, is a highly communicable viral disease characterized by fever, conjunctivitis, and coryza, acute rhinitis. Onset of coughing, a blotchy red rash, which often starts on the head, and whitish-gray spots on the buccal, mouth, mucosa, known as Koplik spots, follow. Transmission occurs by airborne aerosolized droplets or direct contact with the nasal or pharyngeal secretions of an infected person. Less commonly, measles can be spread by contact with articles recently soiled by the patient's nasal or throat sections, such as tissues. The incubation period is approximately 10 days. The onset of fever is generally between 7 to 18 days after exposure, and the rash appears approximately 14 days after exposure. The communicable period begins when the first symptoms appear, approximately 4 days before the rash, and then diminishes rapidly to end approximately 4 days after the rash appears. Although placing a mask on the patient may prevent droplet transmission, the only certain protection against measles is immunity. Anyone who has had measles or received live virus measles vaccine should be immune to measles. If you did not receive live virus vaccine, you should be revaccinated. Post-exposure treatment includes a vaccine if you are not immune. No special disinfection measures are required for the ambulance after carrying a patient known to have measles. Simply washing patient contact areas and laundering any soiled linens is sufficient. Rubella. Rubella, also known as German measles or three-day measles, is characterized by a low-grade fever, headache, runny nose, swollen lymph glands, and usually a diffuse rash that may look a bit like the rash of measles. When it occurs in children, rubella is ordinarily a mild, uncomplicated illness. When it occurs in women during the first 3 to 4 months of pregnancy, however, rubella may cause severe abnormalities in the developing fetus, including deafness, cataracts, mental retardation, and heart defects. Rubella occurs most commonly during the winter and spring and is highly communicable to susceptible individuals. Transmission occurs by direct contact with the nasopharyngeal secretions of an infected person, either by droplet spread or by touching the patient or articles freshly contaminated with the patient's secretions. The incubation period is from 12 to 23 days following an exposure event. An infected person can remain contagious up to 7 days after the rash appears. As with measles, the only certain protection against rubella is immunity. You should be immunized against rubella before starting your employment. No special measures are needed to disinfect the ambulance after carrying a patient known to have rubella. Prevention measures include masking the patient with a surgical mask. Post-exposure treatment includes a vaccine if you are not immune. Take standard precautions, and employ routine cleaning after transport of a rubella patient. Mumps. Mumps is a viral disease that occurs most commonly in winter and spring. Signs and symptoms in children include fever plus swelling, and tenderness of one of the salivary glands, usually the parotid. Mumps in males past the age of puberty may have a very painful complication. Inflammation of the testicles occurs in up to 25% of cases, but this does not result in sterility. Thus, although rubella is a matter of concern for female patients, mumps should particularly worry any male paramedic who did not have the illness or receive immunization against it as a child. You should be immunized against mumps before starting employment if you are not already immune. Transmission of mumps occurs by droplet spread or direct contact with the saliva of an infected person. The incubation period is 16 to 18 days following exposure. The communicable period lasts 9 days after the salivary glands swell. As a precaution, place a surgical mask on the mumps patient. Wear gloves when in contact with drainage, and perform routine cleaning following patient transport. Post-exposure treatment with a vaccine is not recommended. Work restriction will apply. Chickenpox. Chickenpox, also known as varicella, is a highly contagious viral disease that produces a slight fever, photosensitivity, and a vesicular rash that gradually crusts over, leaving a series of scabs. The rash spreads in crops, moving from the covered areas of the body to uncovered areas. The same virus can lead to herpes zoster, shingles, in adults. Herpes zoster arises when the chickenpox virus takes up residence in the ganglion of a nerve. When the individual later becomes stressed, physically or emotionally, lesions may appear along the affected nerve pathway. Herpes zoster can be extremely painful. Transmission of varicella virus occurs by direct contact or droplet spread of respiratory secretions from patients with chickenpox. Contact with the vesicular fluid of patients with either chickenpox or herpes zoster, and probably contact with articles recently contaminated by that fluid, can also transmit the virus. The incubation period for chickenpox is 10 to 21 days. The communicable period starts 1 to 2 days before the appearance of the rash, and lasts approximately 5 days after the first vesicles become apparent. Having chickenpox as a child usually provides lifelong immunity against infection. You should have a blood test, titer, performed to ensure that you are immune. If you are not, then you should be vaccinated. When transporting a patient suspected to have chickenpox, place a surgical mask on the patient. Wear gloves when in contact with discharges or drainage from lesions. Post-exposure treatment includes a vaccine if not immune. If you are pregnant or immunocompromised, varicella zoster immunoglobulin should be offered. Pertussis, whooping cough. Pertussis is a disease caused by the Bordetella pertussis bacteria. It has an insidious onset, and is characterized by an irritating cough that becomes paroxysmal in approximately 1 to 2 weeks. This cough may last for 1 to 2 months. In recent years, the incidence of this disease has been increasing in adolescents and young adults. Some cases have occurred in previously vaccinated persons who have diminished immunity. Transmission takes place through direct contact with discharges from mucous membranes and/or airborne droplets. The incubation period is 7 to 10 days following an exposure. This disease is highly communicable in its early stages before the cough becomes paroxysmal, and then becomes negligible in approximately 3 weeks. Prevention includes placing a surgical mask on the patient. If coughing makes this placement difficult, try a non-rebreathing mask. Post-exposure care may include antibiotic treatment. Good hand washing and routine cleaning of the vehicle are the only special measures required after transporting a patient with pertussis. You should be assessed for vaccination if there is any question about your immunity. Other common or serious communicable diseases. Meningitis. Meningitis is an inflammation of the membranes that cover the brain and spinal cord, called the meninges. 2 types of meningitis are distinguished, bacterial and viral. The bacterial form is communicable, the viral form is not. Meningitis is droplet transmitted. Transmission is by direct contact with the patient's oral or nasal secretions. The most common bacterial organisms implicated in meningitis are Neisseria meningitidis, Streptococcus pneumoniae, Group B Streptococcus, Listeria monocytogenes, and H. influenzae. Although H. influenza used to be a common causative organism, it is rarely seen in Canada due to widespread vaccination. The most common type of meningitis is meningococcal meningitis, which is caused by N. meningitis. In the past, sporadic cases of meningococcal meningitis occurred most frequently during winter and spring, especially when people lived together in crowded conditions, such as in college dorms, homeless shelters, or military barracks. The classic signs and symptoms of meningitis are the same for both the viral and bacterial forms: sudden onset fever, severe headache, stiff neck, Kernig sign. The patient cannot extend his or her leg at the knee when the thigh is flexed because of stiffness in the hamstrings. Brzezinski sign. Passive flexion of the leg on one side causes a similar movement in the opposite leg, photosensitivity, and a pink rash that becomes purple. The patient almost always experiences changes in mental status, ranging from apathy to delirium. Projectile vomiting is common. Diagnosis is made by Gram stain. Transmission occurs following direct contact with the nasopharyngeal secretions of an infected person, mouth-to-mouth, suctioning, or intubation with spraying of secretions, or prolonged contact time of 8 or more hours. The incubation period for meningococcal meningitis lasts between 2 and 10 days. The communicable period is variable because it lasts as long as meningococcal bacteria are present in the patient's nasal and oral secretions. The microorganisms generally disappear from the patient's upper respiratory tract within 24 hours after antibiotic treatment begins. When treating a patient with meningitis, place a surgical mask or non-rebreathing mask on the patient. In addition, if meningitis is suspected, you should don a surgical mask or N95 respirator, if available. Transmission from patient to paramedic is rare. Post-exposure treatment typically includes ciprofloxacin, 1 dose given orally, or rifampin for 2 days. This treatment is not appropriate if the person is taking birth control pills, and it should not be offered to pregnant patients. A polyvalent meningitis vaccine is available. It is recommended for college students entering dormitory living for the first time, military recruits, and middle school and high school students. Meningitis vaccine is not routinely recommended for any healthcare worker group. Tuberculosis. Tuberculosis was once widespread in Canada. Now, there are approximately 5 new cases of tuberculosis for every 100,000 people each year. However, it remains quite common in high-risk populations such as human immunodeficiency virus patients, intravenous drug abusers, prisoners, and those who frequent homeless shelters. Despite progress in its control in Canada, tuberculosis remains an important cause of disability and death in much of the developing world. Tuberculosis is not a highly communicable disease. 3 types of tuberculosis exist: typical, which is communicable, and atypical and extrapulmonary, tuberculosis of the bone, kidney, lymph glands, and so on, which are not communicable. Tuberculosis infection. Latent tuberculosis means that the individual has tested positive for exposure to tuberculosis but does not have, and may never develop, active disease. People with tuberculosis infections do not pose a risk to others. Tuberculosis disease means that the individual has active tuberculosis disease verified by laboratory testing and a positive chest radiograph. Tuberculosis is becoming increasingly difficult to control with drugs. Multi-drug-resistant tuberculosis is now commonplace and often seen in an immunocompromised people or those who have not complied with their full course of treatment. Although it was initially an untreatable disease, multi-drug therapies are now available. Signs and symptoms of tuberculosis include a persistent cough for more than 3 weeks plus one of more of the following: night sweats, headache, fever, fatigue, weight loss, hemoptysis, hoarseness, or chest pain. Transmission occurs by airborne droplets from a person with active untreated disease. In general, that type of spread occurs among people who have continued, prolonged, and intimate exposure to the infected individual, primarily those living in the same household. For the paramedic, such intense exposure is likely to occur only when advanced airway procedures are carried out in a patient with active untreated tuberculosis. The incubation period for tuberculosis is 4 to 12 weeks. The disease is communicable only when an active lesion develops in the lungs and bacteria are expelled into the air by coughing. After 14 days of treatment, virtually all patients are no longer communicable. Early infection with tuberculosis can be detected either by a tuberculin skin test or by an interferon gamma release assay blood test. Of those with a positive test, approximately 5% will develop active tuberculosis within 18 to 24 months, and 95% will develop a latent tuberculosis infection. Of the latter group, 90% will never develop active tuberculosis, and only 5% will have a reactivation and develop active tuberculosis at any point after the initial infection. All healthcare providers, including paramedics, should have a tuberculin test at the beginning of employment, and periodically based on the tuberculosis risk assessment. You should consult your emergency medical services agency for tuberculosis screening and testing procedures. As a preventive measure, place a surgical mask on a patient suspected of having tuberculosis. You should also don an N95 respirator while giving care. The patient may require high-concentration oxygen administration and/or airway or ventilation support based on assessment. If preventive measures were not taken, report the incident to your supervisor. Given that the incubation period for tuberculosis is 4 to 12 weeks, if you suspect you have been exposed to tuberculosis, you should assess the need for baseline testing, and then be retested in 8 to 10 weeks. If the test has become positive at that time, you will have a chest radiograph to rule out infection, and usually will be offered a course of antibiotic therapy. Because these drugs can be toxic to the liver, the individual should not consume alcohol while taking the medications, and liver function tests should be conducted monthly. No special decontamination measures are required after transporting a patient suspected of having active tuberculosis. The vehicle should be cleaned as usual. Pneumonia. Each year, thousands of people in Canada die from pneumonia. Pneumonia is an inflammation of the lungs triggered by bacteria, viruses, fungi, or other organisms. More than 50 types of pneumonia have been identified, ranging from mild to life-threatening. Individuals who are most susceptible to pneumonia are older adults, heavy smokers or alcoholics, individuals with chronic illnesses, and immunocompromised individuals. Worldwide, pneumonia is a leading cause of death in pediatric patients, particularly infants. Although antibiotics have been very successful in treating the most common forms of bacterial pneumonia, antibiotic-resistant strains are increasingly common and pose a very serious therapeutic challenge. Other respiratory conditions. Bronchiolitis is an infection of the lungs and airways that usually occurs in children 3 to 6 months of age. The child starts with a runny nose and slight fever. After 2 to 3 days, the child is wheezing and coughing with tachypnea and tachycardia. The cause is usually viral, for example, respiratory syncytial virus, parainfluenza, influenza. Transmission of bronchiolitis generally occurs by inhaling droplets of infected mucus or respiratory secretions. Bronchitis arises when the inner walls of the bronchioles become infected and inflamed. Symptoms include soreness in the chest and throat, congestion, wheezing, dyspnea, and a slight fever. This condition is caused by the same virus that produces the common cold, as well as by common pollutants and smoking or secondhand smoke. Patients with chronic bronchitis cough for periods spanning 3 months or more per year, for 2 or more consecutive years. Laryngitis is an inflammation of the voice box due to overuse, irritation, or infection. Its cause is usually viral, but can be bacterial. Symptoms include hoarseness, weak voice, sore throat, dry throat, and cough. Croup is the inflammation of the larynx and airway just below it. It primarily affects children 5 years or younger. Croup comes on strongest in the night time, and may last 3 to 7 days. Symptoms include a loud, harsh, barking cough, fever, noisy inhalations, hoarse voice, and mild to moderate dyspnea. This infection is caused by a virus, similar to the common cold, as well as by other viruses, for example, parainfluenza, respiratory syncytial virus, measles, adenovirus. It is spread by respiratory secretions or droplets from coughing, sneezing, and breathing. Epiglottitis is a life-threatening condition that causes the epiglottis, and supraglottic tissue to swell. The pus-filled flap of tissue then partially or completely occludes the glottic opening. Although this disease can affect any age group, it is most prevalent in children 2 to 7 years of age. Its incidence has fallen sharply in the past 20 years because of the routine administration of the Hib vaccine to 2-month-old infants. Symptoms include difficulty breathing and swallowing with stridor and drooling. Patients are very anxious, are cyanotic, and have a muffled voice and fever. Epiglottitis is caused by the H. influenzae type B, Hib, bacteria and is contagious by the droplet route via coughing and sneezing. The common cold is an infection of the upper respiratory system characterized by a runny nose, sore throat, cough, congestion, and watery eyes. Any one of 200 viruses can cause the cold, so symptoms may vary. Patients do not have a fever. Colds are very common in preschoolers, but can occur in patients of all ages. Colds usually last approximately 1 week, and are spread by droplets, coughing, hand-to-hand contact, and shared utensils. Many other respiratory conditions may, or may not, be associated with a fever, and may, or may not, be infectious. These conditions range from mild annoyance to potentially life-threatening conditions. Respiratory syncytial virus. Respiratory syncytial virus is the leading cause of lower respiratory tract infections in infants, older adults, and immunocompromised individuals. This virus spreads in the hospital environment as well as in the community. In the community setting, outbreaks generally occur in late fall, winter, and early spring. Signs and symptoms include those of upper respiratory infection, sneezing, runny nose, nasal congestion, cough, and fever. The disease progression moves to the lower respiratory tract, leading to pneumonia, bronchiolitis, and tracheobronchitis. Hypoxemia and apnea are often seen in infants, and are usually the leading cause for the child's hospitalization. Transmission may occur in 2 ways. 1. By direct contact with large droplets that do not extend more than 1 meter, or 2. By indirect contact with contaminated hands or contaminated items. Research has shown that respiratory syncytial virus can survive on hands for less than 1 hour. However, the virus has been shown to survive on other surfaces for as long as 30 hours. The infection's incubation period ranges from 2 to 8 days. Prevention of respiratory syncytial virus transmission relies on proper use of personal protective equipment. Gloves should be worn when caring for the patient with respiratory syncytial virus, and their removal must be followed by good hand washing. The use of alcohol-based foams or gels is acceptable. Post-run cleaning of the vehicle is important, but special cleaning solutions are not required. Post-exposure treatment consists of supportive care. Paramedics who develop respiratory syncytial virus infection should be placed on work restrictions. In particular, they should not care for immunocompromised patients. Mononucleosis. Mononucleosis is caused by the Epstein-Barr virus. This virus is also suspected of causing a related disease, chronic fatigue syndrome. The virus grows in the epithelium of the oropharynx and sheds into saliva, hence the name kissing disease. Transmission occurs via direct contact with the saliva of an infected person. Some cases have also been linked to contaminated blood transfusions. The incubation period is 4 to 6 weeks following exposure, with a prolonged communicable period. Most cases resolve in 2 to 4 weeks. Pharyngeal excretions may persist for a year or more after infection. Signs and symptoms include sore throat, fever, secretions from the pharynx, swollen lymph glands, especially the posterior cervical glands, malaise, anorexia, headache, muscle pain, and an enlarged liver and/or spleen. Prevention involves the use of gloves and good hand washing techniques when in direct contact with the patient's oral secretions. No special cleaning solutions are required following patient transport. Influenza. Influenza, flu, viruses cause acute respiratory illnesses generally presenting a winter epidemic. Each year, there are approximately 1 billion cases of influenza, 3 to 5 million cases of severe illness, and 500,000 deaths worldwide. In Canada, influenza accounts for approximately 12,000 hospital admissions and 3,500 deaths each year, and is now ranked as one of the top 10 leading causes of death in Canada. Infection rates are high in children, but the most deaths occur in the over 65 age group, especially in patients with medical conditions such as chronic pulmonary or heart disease. For this droplet-transmitted disease, transmission occurs from person to person by coughing and sneezing. The incubation period is approximately 1 to 4 days following exposure. The communicable period in adults lasts from the day before symptoms begin until approximately 5 days after the onset of the illness. Signs and symptoms include systemic fever, shaking, chills, headache, muscle pain, malaise, and loss of appetite. Respiratory symptoms include dry, often protracted coughing, hoarseness, and nasal discharge. The duration of illness is approximately 3 to 4 days, and complications may include viral or bacterial pneumonia. Most people become only mildly ill, make a full recovery in 7 to 10 days, and do not need medical care or antiviral medication. Antiviral drugs, oseltamivir, zanamivir, peramivir, may be used to reduce influenza morbidity and mortality for people in high-risk groups or those who are severely ill. New strains of influenza, including the highly pathogenic avian influenza, H5N1, may present an increased risk to patients due to viral factors or changes in the nature of transmission. Any history of travel outside the country to areas of the world with an increased incidence of H5N1, or a history of contact with sick poultry or other animals, should be passed on to receiving facilities so that they can consider further investigation of the nature of the virus strain. Prevention involves placing a surgical mask or non-rebreathing mask on the patient. You should also don respiratory personal protective equipment, surgical mask or N95 respirator, when caring for suspected influenza patients. The key preventive measure, however, is an annual flu shot. Each year, a new vaccine is developed based on the anticipated strains for that year. The injectable form of the vaccine does not contain live virus, so you cannot get the disease from the shot. If you do not receive a vaccine, and have an exposure, you may be offered antiviral drugs within 48 hours to reduce the severity of influenza should you contract it. You may have the right to decline immunization, but if you decline immunization, then you may be prevented from working when your non-immunized status poses a risk to your patients and colleagues. Sexually transmitted diseases. As the name implies, sexually transmitted diseases are usually acquired by sexual contact. While the term sexually transmitted disease ordinarily conjures up diagnoses such as gonorrhea or syphilis, the range of diseases transmitted sexually is very wide and includes such conditions as herpes, hepatitis, and human immunodeficiency virus infection. Hepatitis, human immunodeficiency virus infection, and acquired immunodeficiency syndrome are considered separately in this chapter, as they are more commonly known as blood-borne diseases. This section reviews the features of gonorrhea, syphilis, scabies, and genital herpes infections. Gonorrhea. Gonorrhea is an infection caused by the gonococcal bacteria, Neisseria gonorrhea. Gonorrhea is especially common in people aged 15 to 24 years. Transmission occurs sexually, by contact with the pus-containing fluid from mucous membranes of infected persons. Therefore, anyone who engages in unprotected sexual contact is at risk. The incubation period is usually 2 to 7 days but may be longer. This infection is communicable for months if not treated. If treated, the individual is non-communicable within hours. Signs and symptoms of gonorrhea differ between males and females. Males usually experience a pus-containing discharge from the urethra, and often report pain on urination, dysuria, starting a few days after the exposure. In females, the initial inflammation of the urethra or cervix may be so mild that it passes unnoticed, and the illness may progress until it presents as pelvic inflammatory disease, with signs and symptoms of an acute abdomen. Depending on the patient's sexual practices, gonorrheal infection may also involve the anus and throat. The risk of acquiring any sexually transmitted disease through a route other than sexual contact is remote. Prevention. Standard precautions includes glove use if touching drainage from the genital area, and thorough hand washing. Syphilis. Syphilis is caused by the spiral-shaped bacteria Treponema pallidum. Its incidence has been increasing for the past 5 years. The groups with the highest incidence rates are young people aged 20 to 35 years. High numbers of cases are also reported in urban areas. Transmission occurs by direct contact with the infectious fluids of the primary lesion or lesions or chancre. The bacteria can be transmitted across the placenta from an infected mother to her fetus, by sexual contact, or through blood transfusion. The incubation period is 10 days to 3 months. The communicable period is variable. If treated with penicillin, the individual is considered non-contagious within 48 hours. The primary infection with syphilis produces an ulcerative lesion, called a chancre, of the skin or mucous membrane at the site of infection. Chancres are most commonly located in the genital region. Secondary infection is the term used to describe the presence of skin rash, patchy hair loss, and swollen lymph glands. Complications of syphilis in the tertiary, third, stage can include cardiac, ophthalmic, auditory, and central nervous system complications, and lesions of the tissues and bone. Prevention measures include taking standard precautions, gloves and good hand washing techniques. No special cleaning precautions are required. Genital herpes. Genital herpes is a chronic, recurrent illness produced by infection with the herpes simplex virus. The herpes simplex virus is further classified into 2 types. Type 1 is generally transmitted via contact with oral secretions, and Type 2 is spread through sexual contact. Genital herpes is characterized by vesicular lesions. In women, the vesicles occur initially on the cervix. During recurrent infections, vesicles may also appear around the vulva, legs, and buttocks. In men, lesions commonly occur on the penis, as well as around the anus, depending on sexual practices. Lesions may also be present on the mouth as the result of oral sex. Transmission usually occurs through sexual contact, but infants may become infected if delivered through the birth canal of a woman with active disease. The incubation period is 2 to 12 days. Secretion of the virus in saliva has been noted to persist for up to 7 weeks following the appearance of a lesion. Genital lesions are infectious for 4 to 7 days. This disease is elusive. It can suddenly become reactivated, often repeatedly, over many years. Outbreaks are often stress-related. This disease can be treated with acyclovir, valacyclovir, or famciclovir for 7 to 10 days to reduce outbreaks. There is no cure, however. Preventive measures include the use of gloves when touching drainage from lesions, and good hand washing techniques. No special cleaning precautions are necessary. Chlamydia. Chlamydia infections have the highest incidence of all sexually transmitted diseases. The incidence is increasing, possibly due to the availability of more sensitive screening tests, and the trend toward routine screening. In most women with chlamydia, this infection initially remains asymptomatic. However, in many women infected with chlamydia trachomatis, pelvic inflammatory disease develops. In men, infection may lead to epididymitis, prostatitis, proctitis, and proctocolitis. Transmission occurs through sexual contact. Perinatal infections may result in premature rupture of membranes, premature birth, or stillbirth. The incubation period is believed to be 7 to 14 days or longer. The communicable period is unknown. Signs and symptoms include inflammation of the urethra, epididymis, cervix, and fallopian tubes when the infection is acquired through sexual transmission. Urethral discharge may appear gray or white in color. The amount of discharge is variable. Chlamydia infection is treated with antibiotics. Preventive measures include wearing gloves when in contact with discharge from the genital area, and using good hand washing techniques. There are no special cleaning requirements for the emergency medical services vehicle or linens. Scabies. Scabies is caused by infection with Sarcoptes scabii, a parasite. Incidence of this disease has been increasing over the past few years in both North America and Europe. This infection commonly affects families, children, sexual partners, chronically ill patients, and persons in communal living. Transmission occurs via direct skin-to-skin contact, such as through wrestling, sexual contact, and by sharing undergarments, towels, and linens. The incubation period is 4 to 6 weeks for persons with no prior exposure to the pathogen. The communicable period lasts until the mites and eggs are destroyed by treatment. Signs and symptoms include nocturnal itching, and the presence of a rash involving the hands, flexor aspect of the wrists, axillary folds, ankles, toes, genital area, buttocks, and abdomen. Prevention consists of wearing gloves and practicing good hand washing techniques. Vehicle linens require only routine washing in hot water, with routine cleaning of the vehicle after patient transport. Lindane is a topical treatment for scabies, but no treatment cream or lotion should be applied on a routine basis because of reports of toxicity. In case of documented exposure, treatment will be undertaken and work restrictions from patient care may be ordered. Lice. Lice are small insects that live in hair and feed on blood through the skin. There are 3 types of lice: head louse, Pediculus humanus capitis, body louse, E. humanus corporis, and pubic louse, Thyrus pubis. All types of lice are acquired through direct contact with a person with an infestation. Head and body lice can also be acquired from objects such as hats, combs, or clothes infested with lice. Lice eggs look like small white or tan dots on the skin. The eggs hatch after approximately 1 week, and then the new lice mature in 1 to 2 weeks. Thereafter, an adult will begin to reproduce and will lay eggs over the next 28 days. Head lice can be found in the hair, and in other hairy areas of the head, such as eyebrows, eyelashes, mustaches, and beards. Body lice are usually found in the seams of clothing, and can transfer certain diseases. When discussing lice as a sexually transmitted disease, the focus is on pubic or crab lice. P. pubis is a parasite that is usually grayish in color. Lice are common in individuals with poor hygiene, people living in group homes, and people with multiple sexual partners. Transmission of pubic lice occurs through intimate physical or sexual contact. The incubation period lasts approximately 8 to 10 days after the eggs hatch. The communicable period ends when all lice and eggs are destroyed by treatment. Signs and symptoms include slight to severe itching, and irritation and, possibly, sores. Nits, eggs, can be seen clinging to the pubic, perianal, or perineal hair. Pubic lice can also infest eyelashes, eyebrows, axilla, scalp, and other body hairs. Preventive measures include wearing gloves and practicing good hand washing techniques. Routine cleaning of the vehicle after transport is sufficient. In case of documented exposure, permethrin cream treatment may be prescribed, and restrictions from pre-hospital care may be indicated until the paramedic is free of lice. Blood-borne diseases. Viral hepatitis. Viral hepatitis is an inflammation of the liver produced by a virus. 6 distinct forms of viral hepatitis exist, with hepatitis A, B, and C accounting for more than 90% of acute hepatitis infections. The infections are produced by different viruses, and vary somewhat in their means of transmission. All types present with the same signs and symptoms, so the type causing illness is ultimately determined by blood testing. Hepatitis A and hepatitis E will be discussed as enteric, intestinal, diseases in this chapter, because they are not blood-borne infections. Hepatitis B virus infection. Hepatitis B virus cases have greatly diminished in Canada due to vaccination programs geared toward healthcare providers, all children, and young adults. Transmission is through sexual contact, blood transfusion, or puncture of the skin with contaminated needles. Occasionally other objects, such as shared razors, tattoo needles, or acupuncture needles, have been implicated in transmission. Hepatitis B virus is particularly common in intravenous drug users who share needles. Healthcare providers, especially those involved in surgery, dentistry, and emergency medicine, were deemed to be at a particularly high risk of contracting hepatitis through accidental needle stick injuries until vaccination programs began. Since then, the incidence rate for occupationally acquired hepatitis B virus infection has fallen by 95%. Limited data suggest that this virus can survive outside the body in the medium of dried blood for as long as 7 days, for example, in the presence of dry blood on stainless steel in a hemodialysis center. The incubation period for hepatitis B virus varies widely, from 60 to 150 days, with symptom onset beginning an average of 90 days after exposure to hepatitis B virus. In 2016, according to World Health Organization, An estimate of less than 5% of all people infected with hepatitis B virus will become chronic carriers. 20% to 30% of people chronically infected with hepatitis B virus will experience cirrhosis of the liver and/or liver cancer. Signs and symptoms of hepatitis B infection include loss of appetite, nausea, vomiting, general fatigue and malaise, low-grade fever, vague abdominal discomfort, and sometimes aching in the joints. The very smell of food may provoke nausea, and smokers often notice a sudden distaste for cigarettes. At this point, signs and symptoms may subside for 50% to 60% of infected persons, which explains why many infected individuals never know that they have acquired the disease. For people whose disease progresses into the second phase, the urine begins to turn dark, and then a day or two later, the patient develops jaundice, a yellowing of the skin, and sclerolicterus, a yellowing of the sclera, the whites of the eyes. Type B hepatitis usually lasts several weeks, although complete recovery may take 3 to 4 months. Prevention of hepatitis B transmission focuses on using gloves when handling blood, other potentially infectious materials, or materials containing visible blood. Good hand washing technique is essential. You should be immunized against hepatitis B virus when hired. Vaccination, which is both safe and effective, protects against hepatitis B virus for life. It also protects indirectly against hepatitis D infection because a person must be infected with type B to acquire type D. Vaccine is administered in a multi-dose series. After the series is completed, you should have a blood test, titer, performed 1 to 2 months later to ensure that your immune system responded to the vaccine. Take routine precautions. If you are exposed, notify your supervisor, and seek medical attention immediately. Public health or the hospital will verify the source patient's test results. If you have a positive titer on file, no follow-up treatment is needed. If you do not have a titer report on file, and the patient is positive for hepatitis B infection, a titer test will be ordered for you. Treatment will depend on the results of that titer testing. If you have not been vaccinated, and the patient is positive for hepatitis B virus, you will be offered hepatitis B immunoglobulin and the vaccine series. The risk of infection is 6% to 30% only if you are not vaccinated and did not report the exposure event. Hepatitis C virus infection. The hepatitis C virus is the most common chronic blood-borne infection, and the leading cause of liver transplantation. Prior to mandatory testing of all blood and blood products in Canada in 1992, hepatitis C virus was also transferred through transfusion of blood and blood-derived products. An estimated 1% to 4% of healthcare providers are antibody positive for hepatitis C virus. However, this disease is not efficiently transmitted through occupational exposure, and no healthcare provider group is at increased risk for occupationally acquired hepatitis C infection. Instead, occupational risk is related to a contaminated deep needle stick with visible blood on the sharp, a sharp that has been in the patient's vein or artery, a hollow bore needle, and a source patient with a high viral load. Transmission may occur by blood-to-blood contact with an open area of the skin, sexual contact, blood transfusion, organ donation, unsafe medical practices, and from an infected mother to her infant. Transmission through mucous membrane or non-intact skin exposure is rare. The virus cannot survive in the environment long enough to pose a risk for any means of transmission except via blood-borne contact. Approximately 75% to 80% of individuals with an hepatitis C infection progress to long-term chronic infection. The incubation period ranges from 2 to 24 weeks, averages 6 to 7 weeks. Signs and symptoms are the same as those for hepatitis B virus, and diagnosis is established by testing for hepatitis C virus antibody. Some 75% of infected persons remain unaware that they acquired the infection because they do not develop phase 2 signs and symptoms. To prevent hepatitis C virus transmission, use gloves when in direct contact with blood or other potentially infectious materials, and use needle-safe or needle-less devices. No special cleaning requirements apply, just perform routine cleaning of the vehicle and equipment. If you have sustained an exposure, testing will begin with the source patient in accordance with your province's testing law. If the source is hepatitis C virus positive, you'll have a baseline hepatitis C virus antibody test and liver function test. You should have a repeat test 4 to 6 weeks following the exposure event. If negative, you did not acquire hepatitis C virus from the exposure. If it is positive, you will begin treatment. There is no vaccine to protect against hepatitis C infection, nor can any medication offer post-exposure prevention against infection. However, treatment is available, which is highly successful in preventing chronic infection. In recent years, hepatitis C virus treatment has evolved to include a combination of drugs called direct-acting antivirals, which are now making hepatitis C virus a potentially curable infection. Hepatitis D virus infection. Hepatitis type D, also called delta hepatitis, requires that the host be infected with hepatitis B virus for hepatitis D infection to occur. For this reason, hepatitis D virus is considered a parasite for hepatitis B virus. The highest incidence is noted in intravenous drug users and those with multiple sexual partners. Transmission is generally by percutaneous exposure, as hepatitis D virus is not effectively transmitted through sexual contact. Perinatal transmission is rare. The incubation period for hepatitis D infection ranges from 30 to 180 days. Blood is considered to be infectious during all phases of the illness. Signs and symptoms are the same as those associated with hepatitis B virus. To protect against hepatitis D virus transmission, use gloves when in contact with blood or other potentially infectious materials, use needle-safe or needle-less devices, and perform routine cleaning of the vehicle following patient transport. Do not go through the pockets of known intravenous drug users who are found unconscious because you may get cut with a contaminated sharp. If a documented exposure occurs, testing begins with the source patient in accordance with provincial testing laws. If the source is positive for hepatitis D virus, and you are protected against hepatitis B virus, no further treatment is indicated. Currently, there is no specific antiviral treatment for hepatitis D infection. Hepatitis G. The virus causing hepatitis G was first described in 1995, and is found in 2% to 5% of the general population. It is most often found as a co-infection with other viruses, such as hepatitis B virus, hepatitis C virus, or human immunodeficiency virus, and is transmitted by infected blood or blood products. There is little proof that hepatitis G causes serious liver disease at any age, and it is possible that hepatitis G may not be an actual hepatitis virus. There is currently no recommended treatment for hepatitis G. Human immunodeficiency virus infection. Human immunodeficiency virus type 1 was first identified in the late 1970s. Since the virus was first identified, more than 70 million people have been infected and approximately one-half have died as a result of human immunodeficiency virus. Although human immunodeficiency virus is primarily a sexually transmitted disease, it is also blood-borne and can be transmitted from mother to infant in the birthing process. The rate of infection from mother to child is only 1% to 3% if infected mothers are treated with antiretroviral drugs beginning in the second trimester. Human immunodeficiency virus is also transmitted through blood transfusions, albeit at a very low rate since the initiation of testing for the presence of P24, a protein present from the beginning of the human immunodeficiency virus life cycle, in donated blood. With P24 testing, the virus can now be detected 1 to 6 days after infection. Human immunodeficiency virus is not transmitted through casual or even household contact. Even among individuals who routinely share eating utensils, toothbrushes, and razors with patients who are human immunodeficiency virus positive, there is no evidence of an increased rate of human immunodeficiency virus infection. This disease is not airborne or droplet transmitted. The human immunodeficiency virus pathogen envelops infected cells and attacks the immune system and other body organs. The immune system is then unable to assist in protecting the infected individual from other diseases. It takes approximately 7 days for the virus to envelop a cell, and this process may occur 4 to 6 weeks after the exposure event. The communicable period is unknown, but is believed to span from the onset of infection possibly throughout life. Signs and symptoms may include acute febrile illness, malaise, swollen lymph glands, headache, and possibly rash. Following initial infection with human immunodeficiency virus, most individuals present with enlargement of the lymph nodes but appear otherwise healthy. However, the number of T helper lymphocytes, CD4 cells, gradually declines. T helper cells are essential components of the immune system that mediate both cellular and humoral immunity. Seroconversion occurs, meaning that antibodies can be detected in the blood. This usually occurs within the first 3 months following exposure. However, new testing, rapid, can detect 2 proteins that are present in the beginning of the life cycle of this virus. Persons who are seropositive for human immunodeficiency virus are placed on antiretroviral drug treatment. Prevention focuses on the use of gloves when in direct contact with patient blood or other potentially infectious materials, the use of needle-safe or needle-less devices, good hand washing technique, and routine cleaning of the vehicle after transport. Post-exposure medical follow-up is covered in the acquired immunodeficiency syndrome section that follows. The risk for acquiring human immunodeficiency virus infection is related to handling and disposal of sharps. A high-risk exposure to human immunodeficiency virus includes all of the following: a deep stick with a large-gauge hollow-bore needle, the device has visible blood on it, the patient is human immunodeficiency virus positive with a high viral load, and the device had been in the patient's vein or artery. Following this type of exposure, the risk of transmission is 0.3% for mucous membrane exposure to the eye and 0.09% for non-intact skin. Acquired immunodeficiency syndrome. Acquired immunodeficiency syndrome is the end-stage disease process caused by human immunodeficiency virus. The patient with acquired immunodeficiency syndrome is extremely vulnerable to numerous bacterial, viral, and fungal infections that would not affect a person with an intact immune system. These opportunistic infections include pneumonia in infants or people with compromised immune systems, loss of vision due to cytomegalovirus, reddish or purple skin lesions, atypical tuberculosis, and cryptococcal meningitis. The incubation period of acquired immunodeficiency syndrome spans the time between documented infection, that is, becoming human immunodeficiency virus positive, and development of the end-stage disease. It is determined by the CD4 cell count and the presence of opportunistic infections. The communicable period is presumed to last as long as the patient is seropositive, even before clinically apparent acquired immunodeficiency syndrome develops. Surveys of patients presenting to emergency departments have shown that up to 6% of seriously ill or injured patients are human immunodeficiency virus positive, although this figure varies widely depending on the geographic locale and population. Prevention involves taking standard precautions. Use gloves when in direct contact with blood or other potentially infectious materials, use needle-safe or needle-less devices, practice good hand washing technique, and ensure routine cleaning of the vehicle and equipment. There is no need to restrict pregnant paramedics from contact with patients with known human immunodeficiency virus or acquired immunodeficiency syndrome. If an exposure occurs, the source patient will be tested in accordance with provincial or territorial law, ideally using the rapid human immunodeficiency virus testing method. Its results are accurate and available in less than 1 hour. If the test is negative, then no further testing is indicated for the paramedic. If the source is positive, then a blood sample is sent for assessment of viral load, and you may be offered antiretroviral drugs for a period of 4 weeks. However, with the new data on viral load, the need for these drugs post-exposure has diminished. The criteria for use of these drugs are published by provincial and territorial public health departments. New antiretroviral medications offer protection from transmission through treatment. Antiretroviral drugs are toxic, so careful and complete counseling should be provided to the exposed healthcare provider. Before initiating antiretroviral therapy, baseline laboratory testing should be done, complete blood cell count, liver function, and kidney function. For a female of childbearing age, pregnancy testing is appropriate. These tests should be repeated every 2 weeks during drug therapy. Enteric, intestinal, diseases. Gastroenteritis. Gastroenteritis, also known as the stomach flu, comprises many types of infections and irritations of the gastrointestinal tract. Patients experience symptoms such as nausea and vomiting, fever, abdominal cramps, and diarrhea. In healthy individuals, gastroenteritis is usually not serious. In children, elderly persons, and patients with chronic illness, severe complications such as dehydration may develop. Hepatitis A virus infection. Hepatitis type A, or infectious hepatitis, is the most common type of hepatitis in Canada. In the past, outbreaks of this disease have been reported in several provinces or territories. Transmission is by the fecal-oral route. Epidemic outbreaks are most often traced to contaminated drinking water, milk, sliced meats, and undercooked shellfish. Hepatitis A is often described as a benign disease because once you acquire the disease, you have lifelong immunity to it. A vaccine is available to protect against hepatitis A, and provinces and territories may include this vaccination. The incubation period is usually approximately 2 to 4 weeks, although it can range from 15 to 50 days after ingestion of the virus. The communicable period probably starts toward the end of the incubation period, and continues for a few days after the patient becomes jaundiced. Signs and symptoms in Phase 1 include fatigue, loss of appetite, fever, nausea, and abdominal pain. Smokers will lose their interest in smoking. In Phase 2, patients have jaundice, dark-colored urine, and pale, clay-colored stools. Prevention includes use of gloves and good hand-washing technique if in contact with patient stool. No special cleaning of the vehicle is needed. Hepatitis A vaccine is recommended for people who travel overseas to prevent the risk of acquiring it from infected food and water sources. Hepatitis E virus infection. Hepatitis E virus infection is enterically transmitted and accounts for an estimated 50% of hepatitis cases in developing countries. Transmission occurs via the fecal-oral route by ingestion of contaminated water. In developing countries, there is a strong association between hepatitis E virus and floods, poor sanitation, and primitive hygiene. Rare cases of transmission via transfusion have been documented, and sexual transmission is on record. This disease is not chronic. Its incubation period is approximately 15 to 60 days. The communicable period has not been determined. Signs and symptoms are the same as for other forms of hepatitis. Prevention includes the use of gloves when in contact with stool, good hand-washing technique, and cleaning contaminated equipment. Vector-borne diseases. West Nile virus. West Nile virus is a relatively new disease in Canada. The virus was first discovered in Uganda in the 1930s. Its first identified appearance in the Western Hemisphere was in New York City in 1999. West Nile virus has been identified in birds and other animals across Canada. Each year, there are reports of human cases, particularly in Ontario and Manitoba. Transmission is via bite from a mosquito carrying the virus. Only approximately 1% of mosquitoes carry West Nile virus. This infection is not transmitted from person to person, so there is no period of communicability. West Nile virus has been transmitted via donated blood and organs, as well as during hemodialysis. 2 cases have involved needle stick injuries in laboratory workers working with this virus. The incubation period is usually 2 to 6 days, but ranges from 2 to 14 days after transmission. In most cases, this disease is mild and uneventful. 70% to 80% of persons who acquire West Nile virus infection remain unaware that they have it. The 20% of persons who are symptomatic exhibit fever with symptoms such as headache, fatigue, weakness, joint pain, vomiting, diarrhea, or rash. Mild symptoms appear in older people and immunocompromised persons. In healthy individuals, the immune system fights off the disease. Approximately 1 in 150 symptomatic individuals will go on to develop severe signs and symptoms, which include encephalitis, meningitis that can lead to neurologic complications, and death. Use needle-safe devices systems to avoid a contaminated sharps injury when West Nile virus infection is suspected. If you sustain a contaminated sharps injury involving a patient with West Nile virus, notify your supervisor. There is no recommended medical follow-up treatment. No special cleaning of the vehicle is needed or recommended. Lyme disease. Lyme disease is caused by the bacterium Borrelia burgdorferi. The bacterium is spread through the bite of certain infected ticks. The ticks carrying the bacterium, blackleg ticks and western blackleg ticks, are commonly found in southern and eastern Ontario, on British Columbia's west coast, southeastern Manitoba, and Nova Scotia, but can be found in areas across Canada because the ticks attach themselves to birds. The Public Health Agency of Canada conducts surveillance with provincial and territorial public health organizations in an effort to monitor blackleg tick populations in Canada. Peak season is between June and August. Incidence rates decrease in the early fall. Lyme disease primarily affects the skin, heart, joints, and nervous system. Some patients remain asymptomatic. This disease occurs more often in children younger than age 10 years, and in middle-aged adults. Lyme disease is not transmitted from person to person. Its incubation period ranges from 3 to 32 days. Lyme disease is usually divided into 3 stages: early localized, early disseminated, and late manifestations. The early stage is characterized by a round, red skin lesion. This bullseye rash, so called because it extends outward with a ring in the center, is most common in the area of the groin, thigh, or axilla. If present, it is warm to the touch, and may blister or scab. In the early disseminated stage, secondary lesions may develop within days, and a patient may report flu-like symptoms, fever, chills, headache, malaise, and muscle pain. Non-productive cough, testicular swelling, sore throat, enlarged spleen, and enlarged lymph nodes may be present. Neurologic involvement, including meningoencephalitis and cranial and peripheral neuropathy, occurs in untreated patients within 2 to 8 weeks. Cardiac involvement, including pericarditis, myocarditis, and atrioventricular conduction difficulties, occurs in untreated patients. In the third phase of the illness, arthritis may occur in untreated patients, beginning days to years after the initial infection. Intermittent joint pain may affect patients, and lasts from days to months. Chronic neurologic symptoms are uncommon. Memory impairment, depressed mood, and severe fatigue are the most common symptoms of Lyme disease. Prevention includes wearing long sleeves and pants when in tick-infested areas, plus use of insecticides as necessary. Daily inspection of exposed skin, including the scalp, and removal of any ticks is recommended. If you sustain a tick bite, use the proper technique for removing ticks. Routine post-exposure prophylactic treatment of a tick bite with antibiotics is not warranted or recommended if the tick is found and removed within 72 hours after attachment. If a tick is not found, and not removed within 72 hours after attachment, then prophylaxis is warranted in endemic areas. Because this is a vector-borne illness, there are no additional personal protective equipment or equipment cleaning requirements when caring for these patients. Zoonotic, animal-borne, diseases. Hantavirus. Hantavirus, also known as hemorrhagic fever with pulmonary syndrome, is associated with the deer mouse, white-footed mouse, and cotton rat. Hantavirus is characterized by flu-like symptoms that can progress rapidly to potentially life-threatening breathing problems. It has also been found in rats in urban areas. This disease was first identified in Korea in the early 1950s and in Canada's prairie provinces nearly 2 decades ago. In Canada and the United States, the deer mouse, which carries the synombre hantavirus, is responsible for most cases of hantavirus. Hantavirus is found in the urine, feces, and saliva of chronically infected rodents. Transmission occurs via direct contact with rodent waste matter, often through aerosol inhalation. The incubation period usually lasts 12 to 16 days following exposure, but has been noted to range from 5 to 42 days. This disease is not transmitted from person to person, so there is no period of communicability. Signs and symptoms begin with the sudden onset of fever, which lasts 3 to 8 days. It is accompanied by headache, abdominal pain, loss of appetite, and vomiting. In some cases, it progresses to a cardiopulmonary phase, with cardiogenic shock and lung involvement similar to that in acute respiratory distress syndrome. Treatment is supportive. Prevention focuses on standard precautions. Routine cleaning of the vehicle is all that is indicated. Rabies. Rabies, hydrophobia, is a virus that is highly neurotropic and causes fatal encephalomyelitis once the infection is established and reaches the brain. Once clinical symptoms develop, death typically occurs within 7 to 14 days, although rabies in humans is preventable through prompt appropriate medical care. Rabies is a serious public health problem in many Asian and African countries, with an estimated 60,000 human deaths from rabies each year in Asia and Africa. Domestic dogs transmit the rabies virus in more than 99% of human cases in these regions. Human rabies is rare in Canada. This is largely due to excellent prevention and control programs. Since reporting began in 1925, 25 people have died of rabies in Canada. The most recent death due to rabies was in Ontario in 2012, and in an individual who was exposed to rabies while overseas. The last case of rabies acquired in Canada was in Alberta in 2007, where an individual acquired rabies from an infected bat. In 2016, there were 392 rabies-positive animals reported to Health Canada. The most commonly infected animals across the country are raccoons, skunks, foxes, and bats. The vaccination of domestic animals and the development of a vaccine and rabies immunoglobulin have greatly reduced the number of deaths in humans who contract rabies. While deaths due to rabies are rare in Canada, between 1,000 and 1,500 people in Canada receive post-exposure prophylaxis each year. Transmission to humans is primarily through the bite of an infected mammal. The virus is shed in the saliva of the infected animal from the time it becomes infected. Other, rare, routes of transmission include contamination of mucous membranes, eyes, nose, mouth, aerosol transmission, and corneal and organ transplantations. In general, however, non-bite exposures to rabies, scratches, abrasions, open wounds, or mucous membranes contaminated with saliva or other potentially infectious materials from a rabid animal, are rare. There are no documented cases of human-to-human transmission of rabies. The incubation period is usually 2 to 8 weeks, but varies depending on the severity of the bite and the location of the wound. Signs and symptoms in human infection are generally nonspecific, much like signs of the flu, fever, chills, sore throat, malaise, headache, and weakness. Paresthesia, tingling skin sensation with no apparent cause, may develop at or near the site of exposure. Following these initial signs, the neurologic phase of the disease begins: hyperactivity, seizures, bizarre behavior, and hydrophobia. Patients also fear drinking water as a result of severe spasms of the throat and masseter, chewing, muscles. As the disease progresses, patients may develop paralysis, and mental status may deteriorate, leading to coma. Although rabies is generally viewed as a fatal disease, several cases of survival have been reported recently, even after symptoms had appeared. For prevention, take standard precautions for pre-hospital care and cleaning of the vehicle. If you are bitten or scratched by a suspect animal, you will be offered an injection of human immunoglobulin and started on human rabies vaccine if deemed appropriate. Tetanus. The tetanus toxoid was introduced in Canada in 1940 and has led to a rapid decrease in morbidity and mortality from this disease. While the number of cases reported annually from 1983 and 1999 averaged 5 per year, the number of cases reported annually between 2000 and 2013 averaged 3 per year. Since 2000, only 6 reported deaths have occurred. Tetanus is more common in agricultural areas and in underdeveloped areas, where contact with animal waste is common and immunization is inadequate. This is a vaccine-preventable disease. The tetanus bacillus is found in the intestines of horses and other animals. Transmission occurs when tetanus spores enter the body by either of 2 means. 1. A puncture wound contaminated with animal feces, street dust, or soil, or 2. Contaminated street drugs. Tetanus is not transmitted from person to person. Occasionally, cases have occurred post-operatively or following seemingly minor injuries. The incubation period is approximately 14 days from the exposure, but has been documented to be as short as 3 days. The cases that have short incubation periods tend to feature a higher level of contamination. Signs and symptoms begin at the site of the wound, followed by painful muscle contractions or rigidity, tetany, in the neck, face, jaw, and trunk muscles. The key sign that suggests tetanus, particularly in children, is abdominal rigidity, although this rigidity may be confined to the location of the injury. Dysphagia, hydrophobia, drooling, and respiratory distress may also occur. A patient with tetanus may require airway and ventilation support en route. Oxygen may be ordered along with intravenous fluids. Tetanus immunoglobulin is recommended for treatment of tetanus. A single intramuscular dose of 3,000 to 5,000 units is generally recommended for children and adults, with part of the dose infiltrated around the wound if it can be identified. Prevention involves the use of gloves when handling any patient wounds and drainage. You should receive a tetanus booster dose every 10 years. No special cleaning routines are necessary after transport of a patient with tetanus. Antibiotic-resistant organisms. The overuse and misuse of antibiotics has led some pathogens to develop resistance to the antibiotic drugs commonly prescribed to eradicate them. The medical community has been concerned that some infections would soon be untreatable. This situation has now occurred. Currently, no new antibiotics are under development. Consequently, many medical facility pharmacies and provincial governments now restrict the use of certain antibiotics. There has also been an attempt to educate the population regarding the risks associated with the overuse of antibiotics. Methicillin-resistant Staphylococcus aureus. Staphylococcus aureus became resistant to penicillin in the late 1950s. Today, more than 90% of community-associated and hospital isolates are resistant to penicillin. The drug methicillin was made available in the early 1960s to treat infections with this pathogen. By the mid-1970s, methicillin-resistant S. aureus was present in hospitals. It has since moved into the larger community. Today, most cases are community-acquired methicillin-resistant S. aureus. The number of healthcare-associated cases of methicillin-resistant S. aureus is starting to decline with the increased focus on infection prevention and control. Methicillin-resistant S. aureus strains are also resistant to some other antibiotics, including cephalosporins, erythromycins, tetracyclines, aminoglycosides, and clindamycin. Although vancomycin has been shown to effectively treat methicillin-resistant S. aureus, some mild strains are showing resistance to this drug as well. Newer drugs are used to treat vancomycin-resistant methicillin-resistant S. aureus, but the options to treat these strains of methicillin-resistant S. aureus are very limited. In healthcare settings, methicillin-resistant S. aureus is believed to be transmitted from patient to patient via unwashed hands of healthcare providers. Studies have shown that 50% to 90% of healthcare providers carry methicillin-resistant S. aureus in their nares. The pathogen can subsequently be transferred to skin and other areas of the body through a break in the skin, causing infection. Surfaces contaminated with methicillin-resistant S. aureus do not seem to be important in transmission. The presence of methicillin-resistant S. aureus in ambulances has been documented, which suggests that cleaning routines and good hand-washing techniques are not being followed. Factors that increase the risk for developing methicillin-resistant S. aureus include antibiotic therapy, prolonged hospital stays, a stay in an intensive care or burn unit, and exposure to an infected patient. Many patients who contract methicillin-resistant S. aureus live in long-term care facilities. The incidence of community-acquired methicillin-resistant S. aureus is also increasing. Therefore, antibiotic coverage for methicillin-resistant S. aureus in critically ill patients is often considered when S. aureus is isolated while awaiting antibiotic sensitivities. Patients with methicillin-resistant S. aureus may be either colonized with this organism or infected. The incubation period appears to be between 5 and 45 days. The communicable period varies, as patients who have active infection may carry methicillin-resistant S. aureus for months. In community-acquired cases, methicillin-resistant S. aureus results in soft tissue infections. Its signs and symptoms may involve localized skin abscesses, and cellulites, empyemas, and endocarditis. Sepsis is found in older patients with S. aureus infections. After bloodstream infection with this organism, secondary infections such as osteomyelitis and septic arthritis may develop at other body sites. Most methicillin-resistant S. aureus soft tissue infections will clear following incision and drainage alone. To prevent methicillin-resistant S. aureus transmission, take standard precautions, gloves and good hand washing technique, when in contact with patient wounds and non-intact skin. If you are in direct contact with wound drainage but your skin is intact, no exposure will occur. No post-exposure treatment is recommended, but carefully document the incident. Vancomycin-resistant enterococci. Enterococcus is a common, normal organism of the gastrointestinal tract, urinary tract, and genitourinary tract. More than 450 species of enterococci exist, many of which are resistant to antimicrobial agents. These organisms grow under both reduced and oxygenated conditions. When they become resistant to the main drug used for treating enterococcal infection, vancomycin, the patient is said to have vancomycin-resistant enterococci. Vancomycin-resistant enterococci is primarily a hospital-acquired infection, nosocomial infection. Although a few sporadic cases were previously known, the first outbreak was documented in a renal unit of a Toronto hospital in 1995. Since that time, vancomycin-resistant enterococci has been identified in over 100 healthcare facilities in 10 provinces, and there have been several reported outbreaks of vancomycin-resistant enterococci in Canadian hospitals. Vancomycin-resistant enterococci is not commonly encountered in the community. Patients identified with vancomycin-resistant enterococci outside the hospital setting typically reside in nursing homes or visit hemodialysis centers. Vancomycin-resistant enterococci may be found in urinary tract infections and bloodstream infections. It has also been identified in livestock stool, uncooked chicken, and persons who work at farms or processing plants. The infectious organisms can live on surfaces for long periods of time, so transmission may occur by direct contact with contaminated surfaces or equipment. A person can be either colonized or infected with vancomycin-resistant enterococci, but only infected patients can transmit this organism. Thus, transmission may occur when you have direct contact with wound drainage, and an open cut or sore allows entry of the organism. Prevention relies on taking standard precautions, wearing gloves, and using good hand washing technique when in contact with wound drainage. A cover gown is necessary only if your uniform may come in contact with wound drainage. Post-run cleaning of all areas that came in contact with the patient is important, but no special cleaning solution is required. If you sustain direct contact with an open wound and body fluids from a patient with a vancomycin-resistant enterococci infection, notify your supervisor, and complete an exposure report. No post-exposure medical treatment is indicated. New and emerging diseases. In the past, an emerging infectious disease of global importance would occur every 20 to 30 years. This is no longer the case, with newly emerging infectious diseases being identified every few years. Recent examples include severe acute respiratory syndrome, avian influenza, Middle Eastern respiratory syndrome, Ebola virus diseases, dengue, Zika virus, and chikungunya. Some are discussed due to the concern paramedic and first response agencies may have regarding the threat these may pose to personnel. Severe acute respiratory syndrome. Severe acute respiratory syndrome is a new disease that was first reported in November 2002 in Fushan City, Guangdong Province, China. This viral infection presented as an atypical pneumonia, and patients rapidly deteriorated and often died. In February 2003, the Chinese Ministry of Health informed the World Health Organization of the outbreak, prompting the World Health Organization to issue a global alert about this new disease. The World Health Organization referred to the disease as severe acute respiratory syndrome. By early 2003, severe acute respiratory syndrome had spread internationally, via Hong Kong, causing outbreaks in several countries. The first Canadian death due to severe acute respiratory syndrome occurred in Toronto, Ontario, on March 5, 2003. The index case and her husband were in Hong Kong in late February, staying in the same hotel as a physician from Guangdong Province. A case cluster in Toronto was linked to the index case, and a single Toronto hospital in mid-March. This first cluster included relatives of the index case, paramedics, and hospital-based healthcare workers who cared for the index case, and her relatives. By late March, a large-scale severe acute respiratory syndrome outbreak was underway in the Greater Toronto Area. The outbreak prompted the Government of Ontario to declare a healthcare emergency, activate the Provincial Operations Centre, and require all Greater Toronto Area hospitals to initiate their emergency response plans for an external disaster. Public health officials investigating the Greater Toronto Area outbreak determined severe acute respiratory syndrome had spread from the Index Hospital to several other hospitals and healthcare institutions, in part due to interfacility patient transfers. To prevent further spread, an emergency medical services-based command, control, and tracking system was set up to prevent the spread of severe acute respiratory syndrome among healthcare facilities, healthcare workers, and patients in Ontario due to interfacility patient transfers. A total of 375 probable and suspect cases of severe acute respiratory syndrome were reported in Toronto, with 44 deaths, including 3 healthcare workers. In addition, over 28,000 residents were placed in voluntary 10-day quarantine to prevent the spread of severe acute respiratory syndrome. The World Health Organization reported a total of 8,098 cases worldwide and 774 deaths as a result of the 2003 outbreak. The last cases of severe acute respiratory syndrome were reported in April 2004 in China and resulted from a laboratory accident. Emergency medical services and paramedics were affected by the severe acute respiratory syndrome outbreak. Emergency medical services strengthened their infection prevention and control practices and set up monitoring systems to protect paramedics and to detect the earliest signs of illness. During the severe acute respiratory syndrome outbreaks, there were 5 cases of probable severe acute respiratory syndrome and 3 cases of suspect severe acute respiratory syndrome among paramedics in Toronto. More important, 526 of Toronto's 920 paramedics were quarantined during the severe acute respiratory syndrome outbreaks. Most paramedics required quarantine due to an unprotected exposure to a hospital with a severe acute respiratory syndrome outbreak or exposure to a colleague who had developed severe acute respiratory syndrome-like symptoms following treatment of patients with severe acute respiratory syndrome. Transmission of severe acute respiratory syndrome is by close personal contact, that is, living with and caring for a person with the disease or having direct contact with respiratory secretions or body fluids of an infected person, for example, kissing or hugging, talking within 1 meter, sharing eating utensils. The incubation period is approximately 10 days from the date of exposure. The communicable period has not been well defined. Signs and symptoms include a fever of greater than 38 degrees Celsius, headache, overall feeling of discomfort, and body aches. Initially, severe acute respiratory syndrome resembles any general flu-like illness. However, after 2 to 7 days a dry cough appears, and severe cases may progress to pneumonia. Patients may need respiratory support. Pre-hospital care for a person suspected of having severe acute respiratory syndrome begins with an assessment, taking of a travel history, and inquiry as to whether any family members are ill after recent travel. In the setting of a community outbreak, additional history regarding exposure to healthcare facilities with known severe acute respiratory syndrome is also necessary. Place a surgical mask on a patient who presents with signs and symptoms of severe acute respiratory syndrome to contain secretions. You should wear an N95 or P100 respirator that has been properly fit tested. Under the current reporting system, medical facilities are required to notify public health officials if a patient transported is later diagnosed with severe acute respiratory syndrome. If an unprotected exposure occurs, notify the emergency medical services supervisor and complete an exposure report form. If a true exposure occurred, a 10-day quarantine may be recommended. This time off will be covered by workers' compensation. If exposed, you will be asked to take a temperature check at least daily as well as follow up with the emergency medical services and public health officials. Avian influenza. Avian, bird, influenza is caused by closely related influenza viruses, such as influenza H5N1 and H7N9, that occur naturally in the bird population. These viruses are typically carried in the intestinal tract of wild birds, and do not usually cause illness. However, in domestic bird populations, for example, chickens, ducks, and turkeys, they can be very contagious. Birds acquire the illness from contact with contaminated excretions or surfaces that are contaminated with excretions. If an infected bird is used for food, and is thoroughly cooked, it does not pose a risk to those who eat it. The first cases of avian influenza in humans were reported in Hong Kong in 1997. 18 people became infected and 6 died in this outbreak. In the cases that have occurred since then, the death rate is approximately 25%. The most recent outbreaks, prompting the Canadian government to issue travel advisories, have occurred in Southeast Asia, H5N1, 2015, and China, H7N9, 2019. No rapidly spread human-to-human cases of this disease have been reported. Instead, the cases occurring in humans have involved close contact with infected birds. The transmission risk for humans is quite low. Signs and symptoms of avian influenza include fever, sore throat, cough, and muscle aches. Some eye infections have also been noted. Illness may eventually progress to pneumonia and severe respiratory distress. Preventive measures include placing a surgical mask on the patient to contain secretions. If the patient's condition does not permit this action, you can wear a surgical mask for protection. Medical facilities must notify public health officials if a patient is diagnosed with avian influenza. If an exposure is documented, then an antiviral drug may be offered within 48 hours of exposure. Antiviral drugs do not prevent influenza, but rather reduce the severity of the illness. The Canadian federal and provincial governments developed a stockpile of antiviral drugs, and provincial and territorial governments have reserved use of these antiviral drugs to confirmed or suspected outbreaks of avian influenza. In the setting of an outbreak, the antiviral drugs will be released by public health officials. Finally, you should get an annual flu shot to ensure protection from type A viruses. Although this may not prevent avian influenza, it will protect you against common influenza viruses, and may provide some reduction in the severity of illness if avian influenza is acquired. Middle Eastern Respiratory Syndrome. Middle Eastern Respiratory Syndrome, MERS, is viral respiratory illness first reported in Saudi Arabia in 2012. It is caused by a coronavirus called MERS-CoV, similar to the virus that causes MERS virus is thought to enter the human population through contact with infected camels or camel-related products. It can spread from person to person via close contact, such as when an unprotected healthcare provider is caring for an infected person. Most people who have been confirmed to have MERS-CoV infection experience severe acute respiratory illness, including fever, cough, and shortness of breath. Approximately 30% of people confirmed to have MERS-CoV infection have died. Routine, contact, and airborne precautions are advised for personnel providing care for patients suspected of MERS. There is no specific cure, and treatment of patients with MERS is based on supportive care. Viral hemorrhagic fevers. Viral hemorrhagic fevers are caused by viruses in 5 distinct families, and include infections such as Ebola, Rift Valley, hantavirus, Crimean Congo, and Marburg. Their survival is dependent on an animal host, which acts as the reservoir. Humans are not natural reservoirs for these viruses, and only become infected when they come into contact with infected hosts. However, human-to-human transmission of these viruses occurs, and often causes outbreaks. Ebola virus disease was first identified in 1976 in Zaire, now known as Democratic Republic of Congo. Outbreaks tend to occur sporadically in parts of Central and Southern Africa and can have mortality approaching 90%. The largest recorded Ebola virus disease outbreak began in late 2013, with initial cases reported in Guinea, followed by spread to other countries in West Africa, mainly Liberia, Sierra Leone, and Nigeria. Overall, the outbreak resulted in over 28,500 cases and 11,300 deaths. The latest outbreak, identified in the Democratic Republic of Congo in August 2018, remains contained to the Democratic Republic of Congo and its immediate neighbors. Despite the tens of thousands affected by the virus, and the thousands of deaths during these 2 outbreaks, cases exported off the African continent are exceedingly rare and there has been no global outbreak of Ebola. To date, there has never been a case of Ebola virus disease identified in Canada. Nevertheless, there remains a risk of a case occurring in Canada due to air travel. When outbreaks occur, the virus is spread to others via direct contact with blood and body fluids. Symptoms are nonspecific and include fever, headache, muscle pain, weakness, diarrhea, vomiting, abdominal pain, and lack of appetite. This progresses to unexplained bleeding or bruising, hence the term hemorrhagic. Symptoms typically occur 8 to 10 days after exposure, but can occur up to 21 days after exposure. Appropriate use of personal protective equipment, including gloves, mask, eye protection, face shield, and impermeable gown, is essential to prevent infection. Zika virus. Zika virus is capable of entering the nervous system. It is transmitted primarily as a mosquito-borne infection, but can also be transmitted sexually and through blood and tissue products. While the species of mosquito, and its larvae, associated with transmission of Zika virus have been found in Windsor, Ontario, the mosquitoes are not established in Canada due to the climate, therefore, the probability of mosquito transmission in Canada is low. As of August 31, 2018, 569 travel-related cases and 4 sexually transmitted cases of Zika virus had been reported in Canada since cases were first detected in October 2015. There have been no reported cases of locally acquired Zika virus in Canada. The only cases of Zika virus reported in Canada have been travel-related. Asymptomatic infections are common, with only 1 in 4 infected people developing symptoms. Zika virus ribonucleic acid can be found in the serum, saliva, urine, semen, and vaginal secretions of infected individuals. Of these, it is known to persist the longest in semen. For those who develop symptoms, the main symptoms of Zika virus infection include retroorbital pain, low-grade fever, 37.8 degrees Celsius to 38.5 degrees Celsius, and nonspecific symptoms such as myalgia, headaches, joint pain or swelling, a maculopapular rash often spreading from the face to the body, and conjunctivitis. The incubation period ranges from 3 to 14 days. The symptoms are usually mild and last for 2 to 7 days. Most people recover fully without severe complications, and only require simple supportive care. There is currently no prophylaxis, vaccine, or treatment for Zika virus infection. Congenital Zika syndrome is a distinct pattern of defect that develop following congenital Zika infection. The syndrome is characterized by the following 5 features: microcephaly, with partially collapsed skull, abnormal brain development, hypertonia with spasticity or seizures, club feet, and eye abnormalities. For this reason, travelers to Zika-affected countries or areas should wait at least 2 to 3 months before trying to conceive to allow for a possible Zika virus infection to be cleared from all body fluids. Due to the nature of these emerging infectious diseases, the Public Health Agency of Canada, provincial public health authorities, and many emergency medical services agencies have developed specific response plans for patients suspected of having some of these diseases. Consult your emergency medical services agency for additional information on how to respond to patients at risk for these and other emerging infectious diseases. The most important thing paramedics need to remember, as with all infections, is to maintain a high level of suspicion, use appropriate personal protective equipment, and ensure proper cleaning and disinfection of the vehicle, medical equipment, and all surfaces. These are the essential steps in good infection prevention and control practices. Ambulance cleaning and disinfection. You have an obligation to protect patients from nosocomial infections, infections acquired from a healthcare setting, in this instance, an ambulance. One way to protect patients is by participating in protective vaccine and immunization programs, another is by complying with work restriction guidelines. Reporting for work when you have a sore throat or a cold is not in the best interests of your patients or your colleagues. Another way to protect patients from nosocomial infections is to keep the ambulance interior and its equipment clean and disinfected. When cleaning and disinfecting equipment, select cleaning solutions to fit the equipment category. Critical equipment, items that come in contact with mucous membranes, laryngoscope blades, tracheal tubes, combi tubes, or similar. Use of single patient use equipment or high-level disinfection if approved as reusable equipment, that is, use of chemical sterilants, is the minimum level for this equipment. Semi-critical equipment, items that come in direct contact with intact skin, stethoscopes, blood pressure cuffs, splints, uniforms, personal protective equipment. Clean with solutions that have a label claiming to kill hepatitis B virus. Bleach and water at 1 to 100 dilution fits this requirement. Non-critical equipment, cleaning surfaces, floors, ambulance seats, work surfaces. Hospital-grade cleaner or bleach and water mixture is effective for this equipment. General cleaning routines need to be listed in the service's infection prevention and control plan. A simple approach is to do the following after every call. 1. Strip used linens from the stretcher immediately after use and place them in a plastic bag or in the designated receptacle in the emergency department. 2. In an appropriate receptacle, discard all disposable equipment used for care of the patient that meets your province's definition of medical waste. Most items will be considered general trash. 3. Wash contaminated areas with soap and water or a hydrogen peroxide wipe specifically designed for decontamination purposes. For disinfection to be effective, cleaning must be done first. 4. Disinfect all non-disposable equipment used in the care of the patient. For example, disassemble the bag mask device and place the components in a liquid sterilization solution as recommended by the manufacturer. 5. Clean the stretcher with an approved germicidal or virucidal solution, bleach and water at 1 to 100 dilution, a specifically designed hydrogen peroxide wipe. 6. If any spillage or other contamination occurred in the ambulance, clean it up with the same germicidal or virucidal or bleach or water solution. 7. Create a schedule for routine full cleaning for the vehicle, as required by the Infection Prevention and Control Plan. Name the brands of solution to be used. 8. Have a written policy or procedure for cleaning each piece of equipment. Refer to the manufacturer's recommendations as a guide. 9. Cleaning should focus on frequently touched items, what was used for patient care and items with which the patient was in contact. Every emergency medical services agency should have a detailed, written procedure and plan for vehicle and equipment cleaning and disinfection to ensure paramedics and patients are not exposed to dirty or contaminated vehicles or equipment. Paramedics should be familiar with their agency's procedures and plans for appropriate cleaning and disinfection.
Chapter 46. Abuse. Introduction. Maltreatment, neglect, and assault of children, women, and older people are, unfortunately, all too common. Because these issues are frequently encountered reasons for calls to EMS, it is important for you to recognize the signs and symptoms. You must know not only how to recognize and differentiate among maltreatment, neglect, and assault, but also how to protect yourself from injury while maintaining optimal pre-hospital care for the patient. Victims who survive maltreatment or neglect often have permanent disabilities, both mental and physical. They may themselves become abusive or neglectful caregivers, perpetuating the cycle of mistreatment. Prevention and early detection are key to limiting maltreatment and permitting survivors to heal. Although prevention strategies have improved in recent years, you may be on the front lines for getting help to victims of maltreatment. Child maltreatment. Child maltreatment includes any improper or excessive action that injures or otherwise harms a child or infant or puts a child or infant at serious risk of harm, including physical abuse, sexual abuse, neglect, and emotional abuse. In the last major national report released, 2008, there were an estimated 235,842 investigations related to child maltreatment. 36% of those cases were confirmed cases of maltreatment, or approximately 85,000 children. Child neglect occurs when a child's physical, mental, or emotional condition is harmed or endangered because the caregiver fails to supply basic necessities or engages in inadequate or dangerous child rearing practices. Neglect includes failure to provide adequate food, clothing, or shelter, the caregiver's misuse of drugs or alcohol, failure to provide support or affection necessary to the child's psychological and social development, or child abandonment. Children who are neglected are often dirty or too thin or appear developmentally delayed because of a lack of stimulation. As a paramedic, you will often be called to scenes because of a reported injury to a child. Many maltreated children have permanent or life-threatening injuries, and some die. If suspected child maltreatment is not reported, the child is likely to be victimized repeatedly. Therefore, you must be aware of the signs of child abuse and neglect and cognizant of your responsibility to report suspected maltreatment to law enforcement or child protection agencies. When in doubt as to whether it is an abuse or neglect situation, it is always better to err on the side of caution to protect the victim. It is known now through the scientific literature that permanently withdrawing a child from his or her family environment is a last resort option, and to assure his or her safety. The motivation to report a child maltreatment situation should be driven by a willingness to protect the child from further harm, and not to have a parent put in jail, even if your emotions may cloud the situation. A child's parent, if he or she is the offender, may seem to be the worst person for a child. The attachment bond between a child and a parent is very hard to recreate, so working on the relationship through better socializing and support of the parent is better than placement for many children. Profile of an at-risk child. Child abuse and neglect occurs in all communities, and among all socioeconomic strata. Younger children are at higher risk for fatal abuse and neglect than are older children. Approximately 85% of abused or neglected children who die are younger than 6 years, more than 40% are younger than 1 year. Although no geographic, ethnic, or economic setting is free of child maltreatment or neglect, children from low-income or single-parent families have more reported occurrences of abuse and neglect than children from higher-income families. Table 46-3 lists other factors that put a child at risk of maltreatment. When assessing a potential child maltreatment case, be attuned to suspicious behavioral traits. A child who does not become agitated when a parent leaves the room or who does not look to a parent for reassurance may be maltreated. Children who are maltreated may also cry excessively or not at all, may be wary of physical contact, or may appear apprehensive. People who maltreat children. Child maltreatment can be done by any person who has care, custody, or control of the child, including parents, step-parents, foster parents, babysitters, and relatives. Parents who maltreat their children frequently receive little enjoyment from parenting, and are more isolated from the community than those parents who do not maltreat their children. They have unrealistic expectations of their child, and try to control the child through negative and authoritarian means. Parents who maltreat their children are often afraid of, or emotionally unable to ask for help from, sources of support in their community. Most were themselves maltreated or neglected as children. Many view themselves as victims in life generally or in the parent-child relationship in particular. They feel that they have lost control of their children, and their own lives. When their children behave in a manner that parents perceive as disrespectful, they lash out in an effort to establish control. Caregivers may prefer to discipline using other means but are pushed to violence by stress. Characteristics shared by caregivers of maltreated children include drug use, poor self-concept, immaturity, lack of parenting knowledge, and lack of interpersonal skills. Table 46-4 lists additional red flag caregiver behaviors. Assessment and management of child maltreatment. One of the most important indicators of possible maltreatment is repeated calls to the same home or family for a child injury or medical problem. Nevertheless, the best indicator by far is the physical examination of the child, conducted with a keen ear for inconsistencies in the history. The physical examination must take into consideration the mental and emotional age of the child. Examining the child from toe to head may work best on toddlers and preschoolers, whereas an infant may be best examined in a parent's arms. Pre-adolescents and teenagers have modesty and body awareness concerns, which should be respected. If possible, do the examination with another colleague. This approach will verify your findings, and help prevent false accusations of impropriety. Also, make certain that you are very objective on your documentation. Do not include opinions or draw non-medical conclusions, list only the objective information, and stick to the facts. When assessing for possible child maltreatment, you may find the child abuse mnemonic helpful. C. Consistency of the injury with the child's developmental age. H. History inconsistent with injury. I. Inappropriate parental concerns. L. Lack of supervision. D. Delay in seeking care. A. Affect. B. Bruises of varying ages. U. Unusual injury patterns. S. Suspicious circumstances. E. Environmental clues. Soft tissue injuries are the most common findings in the physical examination of an abused child. Multiple bruises in various stages of healing are another red flag. Be alert for bruises on areas of the body where they would not be expected, such as the buttocks, back, face, and upper legs. Bites and burns may also be noted. Stocking or glove burns and donut burns occur when a child is immersed in hot water. Fractures can result from fall, twisting, or jerking injuries. Multiple fractures or fractures in various stages of healing are indicators of maltreatment, as are self-healing fractures. Head injuries are the deadliest for children. Even if not fatal, they can easily produce permanent disability. Look for scalp wounds, signs and symptoms of hematoma, and concussion. Although abdominal injuries are rare in child maltreatment cases, they are usually serious. Remember, small children have thin and underdeveloped abdominal muscles. Note the color and rigidity of the abdomen and tenderness to palpation. Injuries to the abdomen may result in injuries to the intestines or rupture of the liver. Sometimes, normal physical findings may suggest an inflicted injury. Other benign skin findings can also suggest maltreatment, although the lesions are actually produced by cultural rituals intended to treat illness. Some medical or folk remedies may be foreign to you or inconsistent with your training. For example, cupping and coin rubbing are alarming to most paramedics, but a reasonable explanation of the practice, which is common in some Asian cultures, should allay your suspicions. It is important to observe the scene, including the household dynamics, as you provide pre-hospital care for the patient. Be aware that more than one victim may be encountered. It is important to keep the scene as safe and calm as possible while still providing life support for any critical and moderately distressed patients. In a case involving child abuse or neglect, the patient care report, with objective observations, will be very important to the police and child protective services. In most provinces and territories, the paramedic is a mandated reporter in child abuse or neglect cases. Most provinces and territories have also established toll-free numbers for reporting suspected child abuse or neglect. Do not assume that someone else has already called or that the emergency department will call. It is better to have more than one person call the hotline for the same case than to see the case fall through the cracks. Most communities also have parenting classes available through county social services. Elder maltreatment. The incidence of older patient maltreatment and neglect is growing. The aging of the population, and the strains placed on caregivers, and the nursing home systems contribute to this problem. You must use sound judgment, and learn to develop good observational skills. Because geriatric patients present much differently than children, and younger adults, you must be especially attuned to the possibility of maltreatment in this population. Consider the following scenario. You respond to a call for man down. On arrival, you find an 86-year-old man lying on his side in the living room, bleeding from the mouth and nose. He appears confused, and you cannot understand what he is trying to say. His 56-year-old daughter states that her father tripped and fell. His vital signs are as follows: pulse, 68 beats per minute, respirations, 14 breaths per minute, and blood pressure, 100/68 millimeters of mercury. The patient's skin is warm and wet. You see a walker device in the kitchen, approximately 8 meters away. The daughter states that the patient does not really need it, stating, He just uses it to get sympathy. The daughter is very upset that the police have just pulled up. Your partner tells you that she has been to this home several times before for falls, that the patient has Alzheimer's disease, and that the daughter seems to lose patience with him, sometimes refusing to cooperate with the paramedics. The daughter then states, "Would you people hurry up and get him out of here? He's getting blood all over the rug." In this scenario, the older patient clearly needs assistance, but his caregiver also seems to be overwhelmed. This situation is not unusual. Because people are living longer than ever before, their children, often baby boomers, must assume responsibility for their care. The stress on these caregivers is real. Physical, emotional, and financial burdens can wear them down. Your crews should be familiar with local resources to assist caregivers and patients. This assistance can be as simple as a visiting nurse or a handy van agency to take the patient to his or her doctor's appointments. As with child maltreatment, elder maltreatment involves a direct action causing harm to the victim. Maltreatment of older patients includes sexual abuse, psychological or emotional abuse, neglect, and abandonment. Neglect can be active or passive. Active neglect refers to the deliberate withholding of companionship, medicine, food, exercise, or assistance with mobility. Passive neglect occurs when an older person is ignored, left alone, isolated, or forgotten. Abandonment is the desertion of an older person by a person who has physical custody of the older person or by a person who has assumed responsibility for providing care. Table 46-5 lists the characteristics of older maltreated patients. In domestic maltreatment cases, the perpetrators are quite often the children of the maltreated person. Factors contributing to elder maltreatment. Although paramedics are concerned with treating and managing the results of abuse and neglect, an understanding of why these problems occur can be beneficial in the pre-hospital setting. In some cases, the violence may be a learned response. Children who were maltreated may ultimately be in a position to maltreat their older parents. The stress of caring for an older person may push some caregivers into abuse or neglect. Factors such as a diminishing social network, frailty, and medical illness also put older people at risk for maltreatment. Older people are at an increased risk for maltreatment in nursing facilities that have a history of providing inadequate care, are understaffed, and provide poor training for their employees. Signs of elder maltreatment. The signs and symptoms of elder abuse and neglect can be subtle and, in the emergency setting, can often be overlooked. Evaluate each situation involving an older person with a critical eye toward potential abuse and neglect. Be on the lookout for a fearful patient with unexplained bruises or sores that have not been tended to. Of course, the patient may naturally be fearful of the whole emergency situation, and there may well be a reasonable explanation for the marks on the body. Be alert for a situation in which you find an unkempt, dirty patient while the caregiver is clean. Generally speaking, a solicitous caregiver will keep the patient and the patient's surroundings tidy. Watch for a patient who allows the caregiver to answer all of your questions, while appearing mentally competent to do so. This person may look to the caregiver for approval when you ask the patient a direct question. If a patient tells you that items are being taken or money confiscated, such a complaint may be an indication of paranoia or a symptom of dementia, but it could very well be true. Do not investigate these claims, simply document them thoroughly. Be wary if a patient states that he or she is not allowed to socialize with peers, and is kept in isolation. Generally, maltreated older people do not seek help. This reluctance may be due to fear of being institutionalized, fear of getting the person performing the maltreatment into trouble, polypharmacy, confusion, or brain disorders such as Alzheimer's disease. In such cases, the physical examination, history, and observation of scene surroundings and patient interaction with caregivers are of paramount concern. The physical examination and history should address the following issues. Is the patient capable of answering your questions in an appropriate way? Is the patient fearful? Does the patient look clean? Are the pill bottles marked appropriately and consistent with purchase dates and use? Does the patient have bruises or sores? Is the patient's current history consistent with the report given by the caregiver? Objectively record your observations on the patient care report, avoiding drawing conclusions and giving opinions. Adult Protective Services could use these observations as an indicator of whether assistance is required. As far as the scene goes, ask these questions. Is the home tidy and are the surroundings orderly? Is there food in the refrigerator? What is the heating or cooling situation, and is it appropriate to the weather? Does the patient use a walking or wheelchair device? For patients who reside in nursing homes, signs of maltreatment include undocumented decubitus ulcers, tied-off catheters, and dangerous use of restraints. Some nursing home residents who are victims of maltreatment may not have a way to report the maltreatment, may not know how to report the maltreatment, may not be physically able to report it, or may fear retaliation for reporting it. Others may be victims of maltreatment by visiting family members. Although the aging of the population has placed increased demands on the system, institutional caregivers have a legal obligation to meet accepted standards of care. Most communities have health departments that provide care, and even transportation for older citizens. If the patient is institutionalized and maltreatment or neglect is suspected, you may notify the regulatory commission responsible for overseeing the facility. You should thoroughly familiarize yourself with all local assistance, and keep an up-to-date directory with 24-hour phone numbers. Domestic maltreatment. Violence within the family has a long history. In ancient Rome, for example, husbands had the legal right to administer physical punishment to their wives within their own homes, and in public. Today, paramedics are frequently called for assault and battery in the home. The statistics on intimate partner maltreatment are sobering. Millions of women are maltreated by an intimate partner each year. Calls of this nature will challenge your skills. Scene safety is a paramount concern, and preservation of evidence is a necessity. Consider the following scenario. You are called for a woman bleeding. When you arrive, a man opens the door and tells you that his wife fell down the stairs. You find a 42-year-old woman crying and bleeding from her mouth. She has obvious contusions and abrasions on her face. Vital signs are a pulse of 124 beats per minute, respirations of 28 breaths per minute, and blood pressure of 132/84 millimeters of mercury. The patient is alert and oriented to person, place, and day. Her skin is warm and dry. Her husband tries to answer all of the questions you pose to her. The stairwell is carpeted and has only 7 risers, but there is no blood on the stairs. 2 children, ages 6 and 12 years, are crying in an adjacent bedroom. The father tells them to stay in the bedroom. Police have not been dispatched to this call yet. Is there significance to the husband dominating the patient interview? Should the crying children raise any red flags? The children's concern, and the husband's control of the scene could be perfectly normal behavior. You must look at all the pieces of the puzzle. Document what you have observed, not what you think. As a paramedic, you must be able to recognize the scope of domestic maltreatment and understand its various forms. Physical, hitting, kicking, pushing, shoving, choking, beating. Emotional, making negative comments, calling names, playing mind games. Economic, trying to keep a person from getting a job, and gaining his or her own financial independence. Sexual, making a person perform sexual activities against his or her will. Even though the awareness of domestic maltreatment has been raised in recent years, dealing with these cases in the pre-hospital environment presents a challenge to you as a paramedic. Battered patients may not give accurate details about their injuries, and they may avoid seeking help. Indeed, victims typically report their maltreatment only as a last resort, for many reasons, for example, shame, embarrassment, financial considerations, and low self-esteem. Moreover, many victims do not want the person responsible for the maltreatment to be charged or removed from the home, nor do they want to leave for a shelter. Often they believe the behavior will change, as is often promised by the abuser. Sometimes the victim believes that he or she is the reason for the maltreatment and somehow deserved it. Finally, some victims may fear even greater maltreatment should they disclose the truth about their injuries. Profile of a maltreated spouse. Physical injuries from maltreatment include broken bones, cuts, head injuries, bruises, burns, scars from old injuries, and internal injuries. A maltreated spouse may have feelings of anxiety, distress, or hopelessness and may show signs of depression, make suicide attempts, or engage in substance abuse. Although in the overwhelming majority of cases the victim is a woman, men also are maltreated. Men who are battered may be too humiliated to report the incident as it happened but still feel the same emotions as women: guilt, loss of control, and shame. Because society tends to be less empathetic toward maltreated men, and because fewer resources exist for them, the situation can be that much more difficult. Same-sex relationships can be as fraught with peril as heterosexual unions. A common misconception is that participants in same-sex relationships are on an equal playing field, so that the maltreatment cannot be as serious as that found in heterosexual relationships. In reality, concerns about coming out may prevent these victims from seeking help. You must be aware of and sensitive to their concerns. Battered patients may appear fearful, apprehensive, or nonverbal. They may avoid eye contact, and their answers may be incorrect or inconsistent. Be alert for verbal clues such as "it was my fault, I really shouldn't push him," or "he's a good person, it's just that when he drinks." In many provinces and territories, there are guidelines and policies that direct the police to lay a charge, as defined in the Criminal Code, when they suspect that an assault has occurred. People who maltreat their partners. Research confirms that domestic abusers are a diverse population. Approximately one-half show no psychological deficits or difficulties, whereas others may be overly sensitive, obsessive, paranoid, or threatening. They often abuse alcohol or drugs, and may have access to weapons, or they may exhibit none of these characteristics. Table 46-7 lists other characteristics of abusers. People who maltreat their partners or spouses may use intimidation and threats to maintain their control over the person. They may throw objects in a rage or threaten regarding what he or she will do if the spouse leaves or reports the abusive behavior. A spouse who maltreats his or her partner may also use isolation as a means to dominate the partner, not allowing the spouse to visit friends or talk openly with others, and may feel that he or she is providing discipline or is justified in these actions. Many times, the spouse who maltreats his or her partner is immediately remorseful and promises never to let the problem happen again. Historically, this is rarely true. The maltreatment usually continues and becomes even more violent. Never forget that domestic violence calls can be dangerous. You may be dealing with a potentially violent person, and emotions on the scene will be highly charged. If the person appears to be hostile or violent, remove all unnecessary people, such as family, friends, and bystanders, from the scene. It is imperative that you put your safety, and the safety of your partner first. If there is any doubt about scene safety, call for law enforcement assistance, see Chapter 54. Assessment and management of domestic maltreatment. Identifying a battered patient can be difficult because the victim may be protective of the attacker, frightened, or honestly unable to recall details. Patients may avoid eye contact or be otherwise evasive about their injuries. Listen for verbal clues regarding the incident, such as "we've been having some problems." On approach to the patient, use direct questioning to ascertain the physical harm. Try to empathize and reassure the patient. This caring attitude alone may instill confidence. Be as objective and non-judgmental as possible. Listen attentively, and be supportive. Give the patient a sense of control as much as possible. You may be the last or only chance a victim has to escape this situation, so encourage the patient to consider where he or she can go or whom he or she can call for help. In cases involving domestic maltreatment, the patient care report is more than just documentation of the transfer of care. It is a permanent record of treatment and disposition. More important, from a legal viewpoint, it represents hard evidence for the prosecution and the defense. Your statements and assessments must be objective, non-judgmental, exact, when quoting a statement from the scene, and as neat as possible. If you make an error, and want to change it, draw a line through the error, and initial the crossed-out statement. Usually, before testifying in court, you are allowed to review your patient care report, but remember that your testimony may come many years, and many patients later. Intimate partner maltreatment is not simply a family issue, it is a crime to assault another person, regardless of the relationship. The presence of law enforcement personnel is always helpful in these cases. If the patient refuses to be transported, ask if it is safe to leave information on services and resources, such as victim witness assistance programs or domestic maltreatment shelters that the patient may reference later. Learn what services are available in your area. Sexual assault. Sexual assault is another difficult call that EMS receives. Even more, your beliefs and values may be challenged when realizing what happened to your patient. Consider the following facts, which will help you adopt the necessary attitudes and behaviors that are helpful to victims of sexual assault. Any degree of sexual assault or rape are crimes of power, force, and violence. Although most victims are women, men and children can also be victims of sexual assault. The legal definition of these crimes differs from jurisdiction to jurisdiction, but essentially sexual assault refers to unwanted sexual contact and rape means penile penetration of the genitalia without the victim's consent. They can be classified as simple assault or aggravated assault. When the victim is underage, it is called statutory rape. Rape is an indictable offense, and you have a responsibility to preserve the crime scene in addition to treating the patient. These offenders are often known by the victim, hence the terms acquaintance assault or date rape. Consider the following scenario. You are sent to an assist police call. On arrival at the scene, you find a 20-year-old woman covered in a blanket and bleeding from several abrasions on her face. The police officer pulls you aside and states that the patient may have been assaulted in the alleyway on her way home from night class. Vital signs include a pulse of 134 beats per minute, respirations of 32 breaths per minute and irregular, and blood pressure of 122/80 millimeters of mercury. The patient is alert and oriented to person, place, and day. Her skin is warm and wet. She is very quiet, appears confused, and tells you she does not remember what happened. She wants to go home and shower. The victim of sexual assault is often found in a state of denial or disbelief. Likewise, the desire to shower or douche is common. The patient should be encouraged to go to the hospital, where evidence can be collected, and where access to professional services is more readily available. In general, be alert for signs that drugs were used to facilitate the sexual assault, such as weakness, nausea, disorientation, or memory loss in the victim. In some cases, patients may have multiple system trauma, and may require treatment for shock. Proper care of a victim of sexual assault will be discussed next. Treatment and documentation. You should know about the specific protocols for sexually assaulted victims, and assist the police, and any medical or social services personnel on the scene. Underage patients will need a parent, a guardian, or a legal representative present for the procedures. From arrival on scene to possible judicial system involvement, trust building, respect, and empathy are the keys to proper pre-hospital care. Most important, your concern in caring for a victim of a sexual assault should be to foster empowerment of the victim. Empowering means to let a person take action for himself or herself, regaining control of his or her body, thoughts, and life. It can be done through offering choices to the patient when accomplishing your assessment, and letting him or her have control over simple tasks, like installing the pulse oximetry themselves. Any kind of assault or abuse victim should be treated this same way. Specific treatment and documentation. In promoting proper care and documentation of a possible crime of sexual nature, you must consider the victim's psychological and physical state but also help preserve evidence, while addressing those different matters. A victim of sexual assault may be hysterical, embarrassed, and/or frightened, or he or she may be silent and appear emotionally contained. Denial and disbelief are common. Any reaction at this point is normal. Observe routine precautions. Take the patient's history, and perform a limited physical examination. Preserve the patient's dignity by shielding the patient from onlookers. Further help the patient regain a sense of control by posing open-ended questions, and allowing him or her to make simple decisions. There is no need to have the victim report to you the details of the assault. You may ask for the time passed since the event. You may ask for what took place since the event. Some victims may wish to block out details of the events. Refrain from seeking details that are not immediately necessary to provide emergent care, and leave the detailed inquiries and questions to teams specially trained to investigate such assaults. If you do not observe life-threatening signs and symptoms on arrival, avoid any aggressive treatment approach. As soon as possible, advise the patient not to bathe, douche, urinate, or defecate, if possible, if genital or anal penetration has occurred. If oral penetration has occurred, advise the patient not to eat, drink, brush the teeth, or use mouthwash until he or she can see medical personnel at the hospital, and decide on having a sexual assault evidence collection kit done. Medication should be taken only if prescribed, and if truly necessary. Leave evidence as untouched as possible, such as bringing the patient's unwashed clothes, and take care to establish a chain of custody as required. The police should be notified as per protocol. Treat all other injuries according to appropriate procedures and protocols for your EMS system. The patient may refuse assistance or transport, often because he or she wants to maintain privacy and avoid public exposure. Adult patients have the right to decline care. In these cases, you should follow your system's refusal of treatment policy or procedure for sexual assault victims without being judgmental or condescending to the patient. Your compassion is your best tool to win the patient's confidence, and encourage him or her to get further help. Because you may need to appear in court as many as 2 or 3 years later, you should document the patient's history, assessment, treatment, and response to treatment in detail. Record only the objective facts. Subjective statements made by those on the scene or the patient should be in quotation marks on the patient care report. Thoroughly document all patient statements pertaining to the crime, as well as statements, names, addresses, and contact information of any witness. Like a battered partner, a victim of sexual assault must be treated by EMS and protected by police. Conscientious health care providers will make a huge difference in the recovery of the patient through their professional conduct. Many provinces and territories offer rape crisis teams or sexual assault treatment centers to assist patients. Your EMS system should keep an up-to-date directory of all sexual assault hotlines and assistance available, with 24-hour telephone numbers. Child victims. In most cases of child sexual maltreatment, the person who maltreated the child is an adult who knows the child, and may be living under the same roof. Children of any age, and either gender can be victims of sexual maltreatment. Although most victims of rape are older than 10 years, younger children may also be victims. Child sexual maltreatment usually does not occur as a single incident. It does not always involve violence and physical force, and it commonly leaves no visible signs. The power of authority or the parent-child bond may be used to victimize the child instead of force or violence. The child may be manipulated into thinking that the acts are acceptable and normal behavior. The child may also be made to feel deeply ashamed and powerless or even be kept silent by threats. The insidious nature of this maltreatment makes it difficult to detect unless the child discloses the information to a confidant or a pre-hospital professional. Your assessment of a child who has been sexually maltreated should be limited to determining the type of dressing any injuries require. Sometimes, a sexually abused child is also beaten. In such cases, you should treat bruises and fractures as well. Do not examine the genitalia of a young child unless you see evidence of bleeding or an injury to this region that must be treated. In some cases, the child may present with behavioral or physical problems, such as hostility or restlessness.
Chapter 47. Patients with Special Needs. Introduction. Throughout the ages, Humans have learned to adapt to the challenges they encounter. In the pre-hospital environment, you'll encounter patients who face a variety of special challenges. Some conditions or anomalies are congenital, for example, spina bifida. Others have developed during the patient's lifetime, for example, panic disorders, or occurred as the result of a sudden event, for example, the transection of the spinal cord during a diving accident. Whatever the source of the challenge, these patients will require you to adapt your assessment and management to accommodate their needs. Although you can still use the standard assessment plan with these patients, sometimes you may find it necessary to adapt to best meet a patient's unique needs. Can a patient see you? Can a patient hear you? Can a patient normally move all extremities? You'll need to formulate a plan to care for these patients in a short amount of time. Be willing to incorporate the patient, family members, or caregivers as essential teammates. Learn to solve problems as part of a group, and remember your ultimate goal, to give the patient the best care possible, in the most efficient way, and still accommodate for his or her individual needs. Your confidence and caring attitude will promote trust between you, your patient, and the other members of your team. Physical challenges. Humans use all 5 senses to gather information, but we often take that sensory feedback for granted. Imagine what it would be like to go bowling while blindfolded. You hear the pins dropping, but did you knock down a couple of pins, get a strike, or just leave a 7 to 10 split? Imagine how frustrating it might be to see that you need to tie your shoe but to be unable to do so because an injury resulted in the loss of motor function in your hand. Hearing impairments. Hearing challenges are classified into 2 types, conductive and sensorineural deafness. Conductive deafness is a usually curable temporary condition caused by an injury to the eardrum, an infection, or simply a buildup of earwax in the external auditory canal. Sensorineural deafness, which is permanent, may be caused by a lesion or damage to the inner ear, or damage to the 8th cranial nerve. This type of hearing impairment may be congenital or secondary to a birth injury, but it may also have occurred over time from disease, medication complications, viral infections, or tumors. People may also have hearing loss due to aging, called presbycusis, or from prolonged exposure to loud noise. Hearing impairment may range from a slight hearing loss to total deafness. Some patients may have difficulty with pitch, volume, and distinguishing speech. Some have learned to speak even though they have never heard speech. Others may have heard speech and learned to talk, but have since had a loss of some or all of their hearing, leading them to speak too loudly. Parkinson's disease or other disease processes may cause the patient to slur words, speak very slowly, or speak in a monotone voice. Interaction with a patient with hearing loss. Clues that a person could be hearing impaired include the presence of hearing aids, poor pronunciation of words, or failure to respond to your presence or verbal questions. While communicating, face the patient so that he or she can see your mouth. Do not exaggerate your lip movements or look away. Position yourself approximately 50 centimeters directly in front of the patient. Most people who are hearing impaired have learned to use body language, such as hand gestures and lip reading. Because patients with a hearing impairment typically have more difficulty hearing higher frequency sounds, if the patient seems to have difficulty hearing you, do not just speak louder, try lowering the pitch of your voice. Ask the patient, "How would you like to communicate with me?" American Sign Language may be the patient's preferred method of communication. An interpreter, family member, or friend may prove to be a valuable teammate. If an interpreter is not readily available, call the receiving facility early on to request one. Ideally, an interpreter will arrive before you begin your assessment. Other patients may prefer written communication or communication of concepts or procedures with gestures or pictures. Simply asking a team member to retrieve the patient's hearing aid or auditory electronic enhancement device may help a great deal. Here are some helpful hints for working with patients with hearing impairments. Speak slowly and distinctly into a less impaired ear, or position yourself on that side. Change speakers. Given that 80% of hearing loss is related to the inability to hear high-pitched sounds, look for a team member with a low-pitched voice if you think this may be the issue. Provide paper and pencil so that you may write your questions, and the patient may write his or her responses. Only one person should ask interview questions, to avoid confusing the patient. Be sure to speak directly in front of the patient or toward the good ear, if there is a difference. Try the reverse stethoscope technique. Put the earpieces of your stethoscope in the patient's ear, and speak softly into the diaphragm of the stethoscope. This will amplify your voice. Hearing aids. A hearing aid is essentially a device that makes sound louder. Hearing aids cannot restore hearing to normal, but they do improve hearing and listening ability. Several types of hearing aids are available. In the canal and completely in the canal. These hearing aids are contained in a tiny case that fits partly or completely into the ear canal. In the ear. All parts are contained in a shell that fits in the outer part of the ear. Behind the ear. All parts are contained in a plastic case that rests behind the ear. Conventional body type. This older style is generally used by people with profound hearing loss. To insert a hearing aid, follow the natural shape of the ear. The device needs to fit snugly without being forced. If you hear a whistling sound, the hearing aid may not be in far enough to create a seal, or the volume may be too loud. Try repositioning the hearing aid, or remove it and turn down the volume. If you cannot insert the hearing aid after 2 tries, put it in the box, take it with you, and document the transport and transfer of the hearing aid to hospital personnel. Never try to clean hearing aids, and never get them wet. If a patient's hearing aid is not working, try troubleshooting the problem. First, make sure the hearing aid is turned on. Try a fresh battery, and check the tubing to make sure it is not twisted or bent. Check the switch to make sure it is set on M, microphone, not T, telephone. For a body aid, try a spare cord because the old one may be broken or shorted. Finally, check the ear mold to make sure it is not plugged with wax. Speech impairments. For most people, the spoken word is the primary mechanism for communicating thoughts and ideas. For some, speech may be delayed by psychological or psychosocial factors. For others, it may be altered by injury, illness, or hearing impairment. Articulation disorders. Articulation disorders cause the majority of speech difficulties. Dysarthria, the inability to make speech sounds correctly, results from a lack of muscle control and coordination of the larynx, tongue, mouth, and lips. Speech can be slurred, indistinct, slow, or nasal. Commonly, articulation disorders result from damage to nerve pathways passing from the brain to muscles in the larynx, mouth, or lips, delayed development from hearing problems, or slow maturation of the nervous system due to brain damage or motor disability. Articulation disorders affect both children and adults. Language disorders. Stroke, traumatic head or brain injury, brain tumor, delayed development, hearing loss, lack of stimulation, or emotional disturbance may cause damage to the language center of the brain, and lead to aphasia. Aphasia is the loss of ability to communicate in speech, writing, or signs. It can range from being very mild to making communication with the patient almost impossible. Aphasia may primarily affect a single aspect of language use, such as the ability to recall the names of objects, to put words into sentences, or to read. When communicating with a patient with aphasia, remember to talk to the patient as an adult, not as a child. Use focused questions rather than open-ended questions, and minimize background noise. Fluency disorders. In fluency disorders, the person's speech pattern is broken, interrupted, or repetitious. An example of this type of disorder is stuttering. Stuttering may be noticed only when the person attempts certain words or sounds, and it may become worse when the individual is under stress. Stuttering is normal for young children, and will disappear gradually over time. The specific causes of stuttering are unknown. When interacting with a person who has a fluency disorder, patience is the key. Impatience with or interruption of a patient who stutters may frustrate the patient more and cause the stuttering to get worse, making assessment and history taking difficult. Voice production disorders. Voice production disorders refer to the way the voice sounds. These may be slightly easier to understand than other speech impairments. Signs of these disorders include hoarseness, harshness, inappropriate pitch, or abnormal nasal resonance. Causes include the closure of vocal cords, hormonal or psychiatric disturbance, or severe hearing loss. Hypernasality may be a complication of a cleft palate, a deformity in which the two sides of the palate fail to fuse in the midline during in utero development, or it may accompany enlarged adenoids. Inflammation of the larynx may produce laryngitis. Laryngitis is a common occurrence in cases involving overuse of the voice, throat infections, heavy smoking, smoke inhalation, allergic reaction, or exposure to fumes. The cause of the laryngitis may provide clues about the patient's reason for calling for your services, and the severity of the situation. Chronic laryngitis may point to long-term exposure to laryngeal irritants, which may cause polyps to develop in the larynx. Occurring more commonly in men, progressive hoarseness is usually the chief complaint in such cases. Long-term exposure to toxins such as chemicals, smoking, or weakened vocal cords from continuous strain are other risk factors. The most ominous cause of chronic laryngitis is carcinoma of the larynx. A laryngectomy, either partial or total removal of the larynx, may be performed to treat the cancer. In the case of a total laryngectomy, the patient would have aphonia, which is the inability to produce normal speech sounds. The patient would receive a stoma, and might communicate by burping sounds or by using an electronic or mechanical device. Interaction with the patient with a speech impairment. When establishing communication, ask the patient how he or she would be most comfortable communicating with you. Allow an appropriate amount of time for a response, and listen carefully to establish an understanding, or enlist someone who knows the patient to interpret. For instance, small children often have speech difficulties that spontaneously resolve, but may be difficult for a stranger to understand. If the patient prefers to speak, your ability to understand the patient will likely be affected. When working with the patient with the voice production disorder, offer a pencil and paper or listen carefully if the patient prefers to speak. Repeat what the patient said to allow for correction or further clarification. Avoid speaking for the patient or finishing sentences for him or her. Above all, be patient. Visual impairments. Visual impairments may result from a multitude of causes: congenital defect, disease, injury, infection, for example, cytomegalovirus, or degeneration of the eyeball, optic nerve, or nerve pathway, for example, with aging. The degree of blindness may range from partial to total. Some patients lose peripheral or central vision, while others can only distinguish light from dark or discern general shapes. Visual impairments may be difficult to recognize. During your scene assessment, look for signs that indicate the person is visually impaired, such as the presence of eyeglasses, a white cane, or a service dog. Make yourself known when you enter the room, and introduce yourself and others in the room, or have them introduce themselves so that the patient can identify their placement and voice. In addition, retrieve any visual aids to make the interaction more comfortable for your patient. A person with a visual impairment may feel vulnerable, especially during the chaos of a crash scene. He or she may have learned to use other senses such as hearing, touch, and smell to compensate for the loss of sight, and the sounds and smells of the crash may be disorienting. Remember to tell the patient what is happening, identify noises, and describe the situation and surroundings, especially if you must move the patient. To ambulate safely, the patient may use a cane or walker. Even if the individual will be carried out on your stretcher, do not forget to take the patient's cane, walker, or eyeglasses. Unless the patient is critical, a service dog can remain in the room, and will provide reassurance for the patient, and prevent delays in transport. In some provinces, service animals are allowed in the ambulance with the patient. However, if you need to arrange for the care or accompaniment of the dog, a friend or animal control officer can be helpful in this situation. An ambulatory patient may be led by a light touch on the arm or elbow. You may also allow the patient to rest his or her hand on your shoulder, as this may enhance the patient's sense of balance and security while moving. You may also ask the patient which method he or she prefers to use while traveling to the ambulance. Patients should be gently guided, but never pushed. Obstacles need to be communicated in advance. Statements such as "you're approaching the stairs," and instructions about how many stairs to expect, will allow the patient to anticipate and navigate the obstacle safely. They will also appreciate your consideration and concern. Paralysis. Paralysis is the inability to voluntarily move one or more body parts. It may be caused by a head trauma, cerebrovascular accident, stroke, spinal cord injury, malignancy, neuromuscular diseases, trauma, or birth defects, among other things. Paralysis does not always entail a loss of sensation. In some cases, the patient will have normal sensation or hyperesthesia, increased sensitivity, that may cause the patient to interpret touch as pain in the affected area. Paralysis of one side of the face may cause subsequent communication challenges as well. Patients who are paralyzed may have diaphragmatic involvement requiring the use of a ventilator. They may also rely on specialized equipment such as halo traction, Foley catheters, tracheotomies, colostomies, or feeding tubes. Each spinal cord procedure requires its own equipment and may have its own complications. See Chapter 48. Dysphagia, caused by a partial paralysis of the esophagus, is the inability to swallow. Patients with dysphagia may choke or aspirate food and drink very easily, leading to the need for emergency airway interventions. If patients have a loss of some or all of the sensation in the affected limbs, they cannot tell you when you are hurting them. Always take great care when lifting or moving a patient who is paralyzed. Because paralyzed limbs lack muscle tone, provide intravenous access and medication administration on the non-affected side whenever possible. Check intravenous sites frequently for infiltration, especially after medication administration. Bariatric patients. Obesity is the result of an imbalance between food eaten and calories used. The solution to the obesity problem may sound relatively simple: re-establish the balance and cure the problem. Unfortunately, obesity can be a much more complex situation. Causes of obesity are not fully understood and, in many cases, are unknown. Often, this problem may be attributed to low basal metabolic rate or genetic predisposition, but there are other causes. Bariatrics is the branch of medicine that studies and treats patients who are obese. The term obese is used when someone is 20% to 30% over his or her ideal weight. In severe or morbid obesity, the person is 20 to 40 kilograms over the ideal weight. Obesity afflicts approximately 1/4 of all Canadians. These individuals may be ridiculed publicly and sometimes are victims of discrimination. Mobility and the patient's general quality of life are often negatively affected by their oversized status, and the extra weight can cause myriad health problems. Interaction with the patient who is obese. Patients who are obese may be embarrassed by their condition or fearful of ridicule as a result of past experiences. Some of those negative interactions may have occurred at the hands of an insensitive healthcare professional. As with any patient, work hard to put these individuals at ease early. Establish the patient's chief complaint, and then communicate your plan to help. Many of these patients have a complex and extensive past medical history, so mastering the art of conducting a patient interview will serve you well in your interactions with these individuals. If transport is necessary, plan early for extra help and do not be afraid to call for more help. Many service providers have specialized equipment for these patients that make movement safer for all involved. These devices ensure the safety and comfort of the patient, while also taking into consideration the logistics and safety of providers that need to move the patient. These devices can include inflatable mats and larger polypropylene sheets. Stretchers are also now designed with increased load capacity and adjustable side supports to accommodate these patients. Pneumatic stretchers also assist in the safe movement of these patients. Patients who are obese may overcome mobility difficulties by pulling, rocking, or rolling into a position. This constant strain on their body's structures may leave them with chronic joint injuries or osteoarthritis. Be conscious of these accommodations, and sensitive to be able to assist when asked. Some patients have a condition called obesity hypoventilation syndrome, also known as Pickwickian syndrome. Patients with Pickwickian syndrome are usually extremely obese. They experience hypoxemia, deficient oxygenation of the blood, hypercapnia, excess carbon dioxide in the blood, and polycythemia, overabundance or overproduction of red blood cells. Physical findings may include headache, apnea, especially during sleep, sleepiness, red face, muscle twitching, and signs of right-side heart failure. Some of these symptoms may necessitate emergency intervention in the pre-hospital environment. Weight reduction is the ultimate remedy for Pickwickian syndrome. Some patients may be on a carefully monitored diet, and others may benefit from surgical intervention, such as gastric bypass surgery. Surgery carries a high risk of complications, however, and not all patients are suitable candidates. When you are moving a patient who is obese, follow these helpful tips. Treat the patient with dignity and respect. Ask your patient how best to move him or her before attempting to do so. Avoid trying to lift the patient by only one limb, which would risk injury to overtaxed joints. Coordinate and communicate all moves to all team members prior to starting. Ensure the most appropriate device is used for safety of all. If the move becomes uncontrolled at any point, stop, reposition, and resume. Look for pinch or pressure points from equipment, as they could cause a deep venous thrombosis. Very large patients may have difficulty breathing if you lay them flat. Keep this possibility in mind when you position these individuals. Many manufacturers now make specialized equipment for patients who are obese, and most areas have specially equipped bariatric ambulances for such patients. Become familiar with the resources available in your area. Plan egress routes to accommodate for a large patient, equipment, and the lifting crew members. Remember, do no harm. Notify the receiving facility early to allow special arrangements to be made prior to your arrival to accommodate the patient's needs. Mental challenges. Mental or emotional impairment. Mental illness is a generic term for a variety of illnesses that result in emotional, cognitive, or behavioral dysfunction. Mental illness can occur in persons with mental or emotional disability just as it can arise in people without a disability. The care of patients with specific mental illness is discussed in depth in Chapter 40. In the broader sense, a person's mental status can influence his or her physical well-being, and vice versa. Emotionally or intellectually disabled individuals may be difficult to assess due to the body's normal stress response, which may alter their respiratory rate, heart rate, or perception of physical illness. Gathering a detailed history will be useful in the assessment and development of a treatment plan for these patients. Calmly ascertain the chief complaint, and treat the patient accordingly, with care and understanding. One of the key components of effective communication, with any type of patient, is to be a good listener. Always listen carefully to your patient, not just the words spoken, but also heeding the patient's tone, facial expressions, and body language. Watch for signs of aggression, clenched fists, or aggressive or agitated movements or speech. They may be your only warning of an impending dangerous confrontation. Implementing active listening skills by repeating what you heard will reassure the patient that you understand and are there to help. Although these patients may present an assessment challenge, they are still patients, and are prone to the same illnesses and disease processes as anyone else. Consequently, treatment and transport of such patients should focus on the chief complaint, and supportive care. When treating patients with emotional or intellectual disabilities, take care in establishing communication with the patient and/or the caregiver. Establish a baseline for the patient's emotional or mental ability so that you will be able to identify any changes. Speak in a calm voice, even if the patient does not have the ability to understand, and explain what you are going to do before doing it. Developmental disabilities. The current terminology in Canada is persons with disabilities, with emphasis on the person rather than the disability, be it intellectual, behavioral, developmental, or emotional. A developmental disability is a permanent condition that means a person develops more slowly and differently than others do. Individuals with a developmental disability may have difficulty learning and processing information with abstract ideas, and changing to meet the needs of normal daily life. It may be caused by genetic factors, congenital infections, complications at birth, malnutrition, or environmental factors. Prenatal drug or alcohol use may also cause disability, as in fetal alcohol syndrome. Postnatal causes may include traumatic brain injury or poisoning, for example, with lead or other toxins. Although IQ testing can identify the extent of the person's ability to learn and reason, just speaking to the patient and family members will give you a good idea of how well the patient can understand and interact with you. A person with a slight impairment may appear slow to understand or have a limited vocabulary, Such an individual will often act immature in comparison to developmentally normal peers. Because the individual may also have difficulty adjusting to change or a break in routine, an emergency call that generates a room full of strangers can be overwhelming. The patient may become more difficult to interact with as his or her anxiety level increases. A severely disabled person may not have the ability to care for himself or herself, communicate, understand, or respond to the surroundings. Treatment of these patients should be based on the chief complaint, unless the illness is related to the mental disability. Patients with developmental disabilities are prone to the same disease processes as any other patients, including diabetes, heart disease, and respiratory difficulties. Transport should be accomplished without causing any more stress than necessary. In most cases, supportive care is all that is needed. Down syndrome. Down syndrome is characterized by a genetic chromosomal defect that can occur during fetal development, resulting in a developmental disability, including mild to severe intellectual impairment. The normal human somatic cell contains 23 chromosomes. Down syndrome, which is also known as trisomy 21, occurs when chromosome 21 fails to separate, so that the ovum contains 24 chromosomes. When the ovum is fertilized by a normal sperm with 23 chromosomes, a triplication, trisomy, of chromosome 21 occurs. Increased maternal age, more than 35 years old, and a family history of Down syndrome are known risk factors for this condition. A variety of abnormalities are associated with Down syndrome: a round head with a flat occiput, an enlarged, protruding tongue, slanted, wide-set eyes, and folded skin on either side of the nose, covering the inner corners of the eye, short, broad hands, a small face and features, congenital heart defects, thyroid problems, and hearing and vision problems. Patients do not usually have all of these symptoms, but will have a combination of them to such a degree that the diagnosis is rapidly made at birth. Patients with Down syndrome are at increased risk for medical complications, including those that affect the cardiovascular, sensory, endocrine, musculoskeletal, dental, gastrointestinal, neurologic, and hematologic systems. As many as 40% may have congenital heart disease, for example, endocardial cushion defects, or ventricular or atrial septal defects. Emergency treatment should therefore include airway management, supplemental oxygen, and intravenous access. In patients with heart failure, administer diuretics with judicious fluid resuscitation only if necessary. Because people with Down syndrome often have large tongues and small oral and nasal cavities, intubation of these patients may be difficult. These individuals may also have malocclusions and other dental anomalies, for example, abnormal contact of the upper and lower teeth. The enlarged tongue and dental anomalies can lead to speech abnormalities as well. In an emergency situation, if airway management is necessary, bag mask ventilation and intubation can be challenging. In the case of airway obstruction, a simple jaw thrust maneuver may be all that is needed to clear the airway. In an unconscious patient, either the jaw thrust maneuver or a nasopharyngeal airway may be necessary. Many people with Down syndrome have epilepsy. Most of the seizures are of the tonic-clonic type. Management is the same as with other patients with seizures. Autism and autism spectrum disorders. Autism and autism spectrum disorders are conditions involving developmental delay that are being diagnosed with increased frequency. These complex disorders of brain development are characterized by difficulties in social interaction, repetitive behaviors, and verbal and nonverbal communications. Increased rates of diagnosis may be due to better awareness and screening or an actual increase in the occurrence of autism in the population. Patients demonstrate a wide variety of symptoms that often relate to communication, social interaction, sensory processing, the ability to purposefully shift attention, and the ability to play. A large number of people with autism will either be completely nonverbal throughout their lifetime or become nonverbal during periods of stress. Developmental regression in absence of another cause in young children should raise concerns for the possibility of autism. Cognitive function can vary significantly among people with autism. Some people with autism may have impaired cognitive function, meeting the criteria for intellectual disability. Other people with autism may demonstrate highly sophisticated skills with mathematics, puzzles, memory, or art. Some patients will achieve a large degree of independence while others will continue to rely on others for basic needs throughout their lives. When you are treating patients with autism, you should be extremely mindful of your actions when you are attempting to communicate and initiate physical contact. Commotion and excess stimuli may cause a patient with autism to have bizarre or aggressive behaviors. Any physical contact should be preceded by a careful explanation, and go from distal to proximal on the patient. Any questions should be repeated to the patient in a variety of ways to determine whether there is a consistent response. Patients with autism may exhibit minimal reactions to significantly painful injuries or may experience great discomfort with minor physical contact or injuries. You should be prepared for many possible challenges while providing care to patients with autism. Including the caregivers in assessment, treatment, and transport will often be extremely helpful. Interaction with patients with developmental disabilities. When caring for a patient with any developmental disability, specifically intellectual or behavioral, obtain a complete history, treat the presenting illness, and provide supportive care. It is normal to feel somewhat uncomfortable when initiating contact with this kind of patient, especially if you have encountered such situations infrequently. Simply treating the patient as you would anyone else is the best plan. Approach the patient in a calm and friendly manner, watching him or her for signs of increased anxiety or fear. Remember, you are a stranger, and are approaching with a group of people. The patient may not understand your uniform or realize that you and your crew are there to help. It may be helpful to have the members of your team hold back slightly until you can establish a rapport with the patient. You can then introduce the team members, and explain what they are going to do. This method will slowly bring forward the other paramedics, instead of mobbing the patient all at once. You might interact with the patient as follows. Hello, Mr. Pemberton. I'm a paramedic, and my name is Jerry. Shake Mr. Pemberton's hand if he will allow it. We're here to help you. Your sister called us. She says you're not feeling well today, and we're here to help you feel better. My friend Tim is going to take your blood pressure. Do you remember having that done before? Allow Mr. Pemberton to see and touch the blood pressure cuff as Tim moves forward. Move slowly but deliberately, explaining beforehand what you are going to do, just as you would with any other patient. Watch carefully for signs of fear or reluctance from the patient. Do your best to soothe the patient's anxiety and or discomfort as you work through your assessment and treatment. By initially establishing trust and communication, you'll have much better luck successfully executing your treatment plan, even if you eventually need to do something painful such as starting an intravenous line. Pathologic challenges. Pathologic challenges require special consideration when you formulate your treatment plan. Pathologies you may encounter during your career may include arthritis, cancer, cerebral palsy, cystic fibrosis, multiple sclerosis, muscular dystrophy, poliomyelitis, previous head injury, spina bifida, and myasthenia gravis. Many of these patients will be well versed in the progression, treatment, and unique nuances of their current health status. Cancer. Simply stated, cancer is the uncontrolled overgrowth of normal tissue cells. If this growth is left unchecked, these cells have the ability to spread, destroy body systems, and kill. More than 200 different kinds of cancer are believed to exist. The type of cancer is determined by where it originates. Cancer is discussed in greater detail in chapters 6 and 48. Numerous types of treatment regimens are available for cancer: surgery, medications, radiation, and chemotherapy, to name a few. Cancer treatment may follow a single pathway or be orchestrated into a complex combination of therapies and medications. Surgical removal has long been one of the primary methods of controlling or terminating cancer's progression. It is often used in tandem with other therapies. Cerebral palsy. Cerebral palsy is a non-progressive, bilateral neuromuscular disorder in which voluntary muscles are poorly controlled. It results from developmental brain insults in utero, for example, cerebral hypoxia, maternal infection, or kernicterus, brain trauma at birth or in early childhood, or postpartum infections, for example, encephalitis or meningitis. Patients often have spastic movements of their limbs and display poor posture, which impairs their ability to move in a controlled manner. Symptoms of cerebral palsy can range from mild to severe. As children grow, these symptoms may either become exaggerated or stay the same. Related complications include visual impairments, hearing and language difficulties, seizures, and developmental disability. Some children with severe cases of cerebral palsy are able to learn to walk with assistive devices, whereas others need support even to sit and cannot stand, walk, or speak. If the patient is able to speak, grimacing and uncontrolled movement may make speech difficult and hard to understand. To cope with ordinary tasks, many patients use computerized household controls and speaking aids. Mechanized wheelchairs may be controlled with a joystick or mouth control. Specially shaped chairs and pillows may be custom built to facilitate the patient's comfort and ease movement. Toys may also be adapted to allow for learning and play. In addition, computers may be specially configured to aid the patient with speech simulation and provide the ability to perform household tasks, such as temperature control and lighting. Thanks to these technologies, many patients with cerebral palsy lead near normal lives and live independently. When caring for a patient with cerebral palsy, note the following. Do not assume that patients with cerebral palsy are always intellectually disabled. Although 75% of patients have some intellectual disability, many people with cerebral palsy have no intellectual disability or only slight intellectual disability. Patients' limbs are often underdeveloped and are prone to injury, for example, from a fall from a wheelchair. Patients who have the ability to walk may have an ataxic or unsteady gait, and are prone to falls. If the patient has a specially made pillow or chair, pediatric patients, the patient may prefer to use it during transport. Remember to pad the patient to ensure his or her comfort, and never force a patient's extremities into any position. Whenever possible, take walkers or wheelchairs along during transport. Approximately 25% of patients with cerebral palsy also have seizures. Be prepared to care for a seizure if one occurs, and keep suctioning available. Cystic fibrosis. Cystic fibrosis, also known as mucoviscidosis, is a chronic dysfunction of the endocrine system that targets multiple body systems, but primarily the respiratory and digestive systems. It is estimated that 1 in every 3,600 children born in Canada has cystic fibrosis. Although it is found in all races and ethnic groups, it most commonly occurs in Caucasian individuals of Northern European descent. The disease is usually fatal, with most children not living past their teens. With aggressive management and careful monitoring, some patients may live well into their 30s. Cystic fibrosis is caused by a defective recessive gene, which makes it difficult for chloride to move through cells. This causes unusually high sodium loss, resulting in salty skin and abnormally thick mucus secretions. The secretions in the lungs cause breathing difficulties and provide an ideal growing medium for bacteria, leaving the patient highly susceptible to infection. Ultimately, the lung damage from the condition leads to lung disease, which is the primary cause of death in affected individuals. Respiratory difficulties associated with cystic fibrosis include tachypnea, productive cough, shortness of breath, barrel chest, clubbed fingers, and cyanosis. The thick mucus may also collect in the intestines. Malnutrition and poor growth rate are common, as are intestinal blockages. Physicians strive to reduce the progression of the disease with physical therapy, exercise, vitamin supplements, and medications. Some patients may also benefit from a lung transplant. Care of these patients should primarily focus on treating the individual's chief complaint. Keep a keen eye out for respiratory insufficiency, signs of a respiratory infection, intestinal blockage, or cardiac dysrhythmias, as a result of the electrolyte imbalance. Suctioning, high-flow supplemental oxygen, and breathing therapies may also be required during transport. Multiple sclerosis. Multiple sclerosis is a chronic disease of the central nervous system characterized by destruction of the myelin and nerve axons within the brain and spinal cord. It has no known cause, but is an autoimmune disorder. In some cases, it is genetically inherited. This disease strikes women in their 20s to 40s at a rate 2 to 3 times more often than men. Canadians have one of the highest rates of multiple sclerosis in the world. Every day, 3 new cases of multiple sclerosis are diagnosed. It is the most common neurologic disease affecting adults in Canada. Myelin is a fatty covering that shields the axons. Axons are responsible for electrical conduction from neurons to muscles, leading to muscle response and communication from the body to the brain. Multiple sclerosis causes areas of myelin in random places to become inflamed, detach from the axon, and ultimately self-destruct. The area of destruction becomes scarred over, hence the name multiple, many, sclerosis, to harden. Two types of multiple sclerosis are distinguished: relapsing or remitting and progressive. The relapsing or remitting form affects 90% of patients, presenting with bouts of worsening symptoms. Signs and symptoms of multiple sclerosis can be divided into those associated with the brain, and those associated with the spinal cord, and include numbness or tingling in parts of the body, unexplained weakness, dizziness, fatigue, double or blurry vision, and vision impairment. Periods of relapse leave the patient feeling marked improvement, with stiffness and weakness lingering for some. The other 10% of patients have the progressive form, in which symptoms get progressively worse with no periods of improvement or relief. 1/2 of all people who have the relapsing or remitting form of the disease will develop the progressive form within 15 years if they remain untreated. There is no cure for multiple sclerosis, although many treatments can significantly reduce the frequency of attacks and lessen symptoms when they occur. As with other illnesses, your treatment may be limited to supportive care. You may also be called to the patient's side due to tertiary complications of multiple sclerosis, such as a fall. Because of the disease process, the patient may lack feeling, so the physical examination may be difficult. A detailed medical history will help elucidate the diagnosis. As with patients with paralysis, you must take special care when lifting and moving patients with multiple sclerosis. When these individuals are in crisis, they may not be able to walk even with their assistive devices. Muscular dystrophy. Muscular dystrophy is an inherited muscular disease that causes progressive degeneration of the muscle fibers. In many cases, the destroyed fibers are replaced by fat or connective tissue. The result is a gradual weakening of muscles, slowing of motor development, and loss of muscle contractility. More than 30 types of muscular dystrophy have been identified. Some begin in early childhood and progress rapidly. Others do not surface until the late teens into the 40s and progress much more slowly. Duchenne muscular dystrophy, the most common type, affects 10 out of every 100,000 male births. Muscular dystrophy may not be apparent in infancy, but rather appears as the child grows, presenting as muscle weakness during childhood or early adulthood. Parents or physicians may notice a delay in the normal developmental landmarks such as sitting, walking, or climbing stairs. The wasting of skeletal muscles ultimately leads to increasing disability and deformity. Kyphoscoliosis, an outward hump of the upper spine accompanied by curvature of the lower spine, may compromise pulmonary function. Cardiac involvement may also be present in as many as 95% of patients. Unfortunately, only 25% of those affected live to age 21 years, with pulmonary or cardiac complications usually being the cause of death. Poliomyelitis. Poliomyelitis, polio, is a highly contagious viral infection. First identified in 1789, it was once a worldwide plague, with its incidence growing to epidemic proportions from late spring through fall. Canada was declared polio-free in 1994. The last major Canadian epidemic of wild polio virus occurred in 1959, with 1,887 paralytic cases reported. Following the release of the Salk and Sabin polio vaccines in 1955, the number of cases of polio declined rapidly, and the only polio cases now seen in Canada are polio-infected visitors from other countries or vaccine-associated paralytic polio, which is caused by contact between an unvaccinated individual and a person who has recently been inoculated with a live vaccine. Although live vaccines have not been used in Canada since 1996, they are still administered in many other parts of the world. Thanks to worldwide vaccination programs, promoted by the World Health Organization, the goal is to eradicate polio worldwide. However, sporadic outbreaks of polio still occur in countries where immunization programs have lapsed, where civil unrest prevents immunization programs from taking place, or where migration brings new polio cases from areas where polio is still present. Humans are the only known hosts for the poliomyelitis virus. This pathogen enters the body by direct contact through the mouth, replicating in the pharynx, gastrointestinal system, and local lymphatic system. The virus then enters the bloodstream and spreads to the central nervous system. The spinal cord and brain are affected, which may cause paralysis or death. In 80% to 90% of cases, usually involving young children, the illness is mild, presenting with malaise, sore throat, headache, vomiting, and slight fever. The initial symptoms are followed by a period of apparent wellness. Symptoms of major illness, fever, severe headache, stiff neck and back, deep muscle pain, or paralysis, then appear after a few days. In non-paralytic forms of polio, recovery is complete. In paralytic forms, muscle function may gradually and completely return. However, any weakness or paralysis lasting longer than 12 months after the infection is a sign of permanent damage and disability. Patients with paralysis will need special attention in order to safely lift, move, and position them. They may also need special equipment, such as ventilatory assistance via a tracheal tube or tracheotomy if they experience respiratory paralysis. They also may have an indwelling catheter in place if the lower extremities are paralyzed. Spina bifida. Spina bifida is the most common permanently disabling birth defect. In Canada, approximately 120 children are born with spina bifida each year. In this disorder, during the first month of pregnancy, the fetus's spinal column does not close properly or completely and vertebrae do not develop, leaving a portion of the spinal cord exposed. Faithfully taking the B vitamin folic acid prior to becoming pregnant reduces the risk of spinal defects. Other maternal risk factors for spina bifida include previous neural tube defect. Pregnancy increases risk by 20%, diabetes, medically diagnosed obesity, some anti-seizure medications, exposure to increased temperature in early pregnancy, that is, hot baths or hot tubs, infection resulting in fever, Caucasian or Hispanic ethnicity, and lower socioeconomic status. Symptoms of spina bifida may include partial or full paralysis, usually of the lower extremities, bladder or bowel control difficulties, learning disabilities, and latex allergy. In addition, as many as 70% to 90% of individuals with the most severe form of spina bifida also have hydrocephalus. In hydrocephalus, an increase in the amount of cerebrospinal fluid results in increased pressure on the brain. A shunt is inserted to relieve this pressure on the brain by draining excess cerebrospinal fluid. The shunt will stay in place throughout the patient's lifetime. Patients with spina bifida will likely benefit from the same considerations that you offer when treating a patient with paralysis or difficulty moving. When you are caring for these patients, ask how best to move them if possible. Remember to rule out a fall or other event that may have caused an injury. Check carefully for injuries, as patients may not be able to feel them, or the pain of an infiltrated intravenous line, for that matter. Also, be aware that these patients may have urinary catheters or other aids in place. Patients with head injuries. Traumatic brain injury is a potentially devastating condition associated with many serious short and long-term complications. You may encounter patients immediately after they experience the injury. Care of these patients in emergency situations is discussed in depth in Chapter 24, Head and Face Injuries. Once the acute crisis has resolved, many of these patients continue to experience serious or life-altering long-term complications. Patients with a previous head injury may face a complex array of challenges related to their injury. In such cases, gathering a complete medical history from the patient, family, and friends will assist you in the formation of a treatment plan. Treatment will primarily be supportive care. Your interaction with the patient will need to be tailored to his or her specific abilities. Take the time to speak with the patient and the family to establish what is normal for the patient, for example, whether the patient has cognitive, sensory, communication, motor, behavioral, or psychological deficits. When you are caring for a patient with a previous head injury, talk to him or her in a calm and soothing tone, and watch the patient closely for signs of anxiety or aggression. In some cases, The patient may need to be specially positioned or restrained to ensure the safety of both you and the patient. Do not expect such an individual to walk to the ambulance or stretcher. As always, treat the patient with respect, use his or her name, explain procedures, and reassure the patient throughout your care. Myasthenia gravis. Myasthenia gravis is a rare autoimmune disorder characterized by chronic fatigability and weakness of muscles, especially in the face and throat. It is the result of a defect in the conduction of nerve impulses at the nerve junction, caused by a lack of acetylcholine. In myasthenia gravis, antibodies keep acetylcholine from reaching the muscles by blocking or damaging the receptor sites. This interruption in communication results in sudden bouts of muscle weakness, usually during activity, although the condition improves with rest. Although it affects all ethnic groups and sexes, myasthenia gravis is most commonly found in women younger than age 40, typically between 20 and 30 years, and men older than age 60. The first symptoms usually present as weakness in eye or eyelid movement. Myasthenia gravis may also affect facial muscle control, changing the person's facial expression. In many cases, the disease is noticed initially as a sudden difficulty swallowing or chewing, or as slurred speech. Other symptoms may include blurry vision, weakness or difficulty moving the neck, shortness of breath, and weakness or difficulty moving limbs. Myasthenia gravis may be difficult to diagnose because these symptoms can be attributed to many illnesses and disease processes. A crisis may occur if the patient's respiratory muscles are damaged by infection, stress, side effects of medications, or even menstruation. These muscles could become so weak that the patient experiences an acute onset of respiratory failure. In such a case, you need to intervene immediately with airway management, ventilatory support, and possibly intubation. End-of-life care. Unfortunately, some illnesses cannot be cured. As healthcare providers, you and your team will often be called on to assist a patient who is in the end stages of a terminal illness. Signs of impending death include decreased intake of food and drink, decreased orientation, irregular breathing patterns, and bradycardia or tachycardia. If you recognize these signs, reassure the family that you will help their loved one in a most respectful and dignified manner. Although the goal of end-of-life care is to provide patients with the meaningful, dignified, and comfortable death, there's a surprising lack of data describing what patients and their families believe constitutes a good death. While some patients with terminal illness choose to have the most aggressive care possible, others have a goal of comfort rather than cure or prolongation of life. In general, seriously ill patients identify pain and symptom management, preparation for death, and achieving a sense of completion as important factors in a good death. If you are called to a scene in which death is imminent, the actions you take will have a lasting impact on the family. This is a time when compassion, understanding, and sensitivity are most needed. Some scenes may be chaotic. The family may be having a difficult time coping with the situation, and they may act out with anger and hostility. Treat everyone with compassion and understanding. The other members of your team may be able to separate individuals and speak with them individually to diffuse intense emotions and restore order to the situation. Terminally ill patients usually need only supportive care. Therapy is often aimed at making the patient as comfortable as possible. The patient may have a displaced urinary catheter, need assistance in returning to bed, or need intervention in a pain crisis. Some patients may also be receiving care from hospice or a home health nurse. You may have been called because of a delay in the arrival of the regular care provider or for transport to take care of an immediate need in a clinical setting. Because terminally ill patients may use a complex array of pain medications, transdermal patches, or self-administered pain management devices, you may need to consult medical direction for guidance in their care. If the patient has a valid do not resuscitate order, cardiopulmonary resuscitation is not indicated or appropriate if the patient's heart stops and/or he or she stops breathing. If you have any question regarding the validity of a do not resuscitate order or the level of interventions the patient wants, you should start resuscitation while contacting direct medical control for further instructions. When no resuscitative measures are attempted, aggressive comfort measures are required. These include oxygen administration, salbutamol-based breathing treatments, and narcotics for pain and respiratory distress, as per local protocol. Place the patient in a comfortable position. Although the decision for a do not resuscitate order had already been made, family members may not understand what to do, and they may not be ready to face the death of a loved one. In such a case, take a thorough history, and compassionately discuss the patient's wishes. Ask to review the do not resuscitate order, and keep it with the patient during transport. Ascertain the family's wishes about having the patient remain in the home versus transport to the hospital. During transport, contact direct medical control, and advise the receiving hospital of the situation. If a family member requests to accompany the patient, he or she should be allowed to do so. If the family wishes the patient to remain at home, this request should be honored provided it is in accordance with your local or regional protocol. Protocols for handling the death of a patient vary, so you must learn your local or regional regulations. Your protocol will identify whether the coroner needs to be called to report the death and, if so, who is responsible for contacting the coroner. Also determine whether a pronouncement of death is required and, if so, who makes it. Patients with communicable diseases. Some patients may have communicable diseases, which explains why appropriate personal protective equipment and routine precautions need to be followed with every patient, every time. Gloves and eye protection should be considered basic attire. Gowns, masks, and other protective measures should be deployed if the situation warrants. Safety for yourself, your crew, and your patient is paramount. At the same time, you should treat patients with communicable diseases with the same compassion you would give to any other patient. Clues that a patient has a communicable disease include rashes, coughing, ill appearance, health or travel history, and medications. Offer patients with immunocompromised conditions a mask prior to their arrival at a hospital to safeguard them from further exposure to illness. Masking a patient early during your assessment may be the quickest and easiest method of preventing disease transmission. See chapters 2 and 39 for more details. Financial challenges. Many patients, particularly the elderly, may be concerned about the financial aspect of the ambulance ride to the hospital. Remember, they have experienced the times before the institution of universal health care in Canada. I can't go to the hospital. I don't have the money. These statements are heard from many patients who do not understand the concept of universal health care. Many of these individuals do not have private health insurance that covers ambulance services. By engaging in careful, compassionate communication with your patient, you should try to determine the source of his or her anxiety. Share with the patient your concerns about his or her current health. Chapter 53. Hazardous Materials Incidents. Introduction. One of the inevitable consequences of living in an industrialized world is the proliferation of hazardous materials. The product of our civilization require the manufacture, transport, storage, use, and disposal of thousands of potentially toxic substances. Approximately 10,000 hazardous materials releases occur in Canada each year. 10% of these are related to transportation incidents. This chapter will take a broad look at the special considerations involved in responding to incidents that may involve hazardous materials. It is not intended to be a comprehensive coverage of hazardous materials. The general rule for paramedics responding to industrial, highway, and many other types of incidents is to maintain a high index of suspicion, and to stay away from the hazardous materials incident. Laws and regulations. Training requirements and standards are put forth by the 2018 edition of NFPA 472. Standard for competence of responders to hazardous materials or weapons of mass destruction incidents published by the National Fire Protection Association. All paramedics should receive training to the basic awareness level, and those more involved, working on medical monitoring or decontamination of the team, will need to be trained to the operations or technician level. With awareness level training, you may be the first to discover a hazardous materials release. Topics covered in the course include recognizing hazardous materials, isolating the area, and calling for appropriate assistance. The operations level, emergency medical services or level 1 responder, of training will allow you to perform defensive actions against hazardous materials. You can perform patient pre-hospital care activities in the cold zone, The Command and Support Center, at an incident for patients who no longer present a significant risk of secondary contamination. The technician level, emergency medical services or level 2 responder, of training will allow you to perform patient pre-hospital care activities in the warm zone at a hazardous materials incident, working with patients who may still present a significant risk of secondary contamination. At this level, you should be able to use specialized equipment, care for patients during the rescue, and manage the incident, and all personnel at the scene. Federal, provincial, and local rules govern the use, storage, and transportation of hazardous materials. These regulations and standards are designed to improve the public's ability to know, and to help protect workers and emergency responders as they try to protect the public. You should become familiar with the laws of the provinces and localities in which you serve. Paramedics and hazardous materials incidents. Paramedics must use their street smarts to identify potential hazardous material scenes, and determine how to handle the scene if they are the first responders. You should know how and when to access specific toxicologic information, reference sources, poison control center, medical control, and/or a hazardous materials team. You should understand how a hazardous materials scene is organized from a command and control perspective, including how you fit into the command structure and operational plan. You also need to be familiar with the different types of personal protective equipment used at a hazardous materials scene, how the hazardous materials team or other responders will decontaminate patients, and how to assess and treat exposures. In addition, you may be called on to support hazardous materials teams through on-scene medical monitoring and/or provide treatment in the event responders are exposed. Hazardous materials incidents may include the following: a highway or railroad incident in which a substance is leaking from a cargo tank or railroad tank car. A leak, fire, or other emergency at an industrial plant, refinery, or other fixed facility where chemicals or explosives are produced, used, or stored. A leak or rupture of an underground natural gas pipe. Incidents in an agricultural setting in which insecticides may be in use or accidentally released. Build-up of methane or other byproduct of waste decomposition in sewers, sewage processing plants, or landfills. An incident with criminal intent in which a suspected hazardous materials agent is intentionally released. A clandestine laboratory involved in the manufacture or processing of illicit drugs. Often, the presence of hazardous materials is easily recognized from warning signs such as victim or patient signs and symptoms, placards, labels, or other clues found at the scene. Placards or labels may be found in the following locations: on buildings or in areas where hazardous materials are produced, used, or stored. On trucks and railroad cars that transport certain types or amounts of a hazardous material. On drums or other storage vessels that contain a hazardous waste or hazardous material. When you first arrive at a call and recognize a hazardous materials incident, your most important job will be to identify the hazardous materials. Unfortunately, identifying materials can be difficult. Sometimes, transporters do not label containers or vessels appropriately, and the labeling of packages and transport vehicles can be misleading. In most cases, the package or tank must contain a certain amount of a hazardous material before a placard is required. A truck carrying 100 kilograms of hazardous material number 1, hazardous material number 2, and hazardous material number sign may not be required by law to display any labels or placards, because the quantities are so small, there is no law governing these materials. The truck may show only "Please drive carefully" on its flip placard. Although a collision involving this truck might not seem serious, the wise paramedic will keep a high index of suspicion when approaching the scene of any truck or train tanker collision. Maintain that high index of suspicion as you follow up on your first assessment of the scene. Some substances are not hazardous until mixed with another substance. The hazardous material number 1 and the hazardous material number 3 in the truck collision may become highly toxic if they combine. As a paramedic with a high index of suspicion, you need to remember that there may be no regulations against carrying such substances together on one truck or railroad car, or adjacent tank cars. The driver of a commercial truck, and the conductor of a train, however, must carry papers that identify what is being transported in their care. If you can, Without sacrificing your own safety or pre-hospital care, look for these papers. These papers may be your first clue that you are in a hazardous materials incident. You can often identify leaks or spills of hazardous materials by the following: a visible cloud or unusual-looking smoke or vapor resulting from the escaping substance. A leak or spill from a tank, container, truck, or railroad car with or without hazardous material placards or labels. An unusual, strong, noxious, acrid odor in the area. Manufacturers may add substances that produce a strong noxious odor to indicate the presence of normally odorless toxic gases or fluids during a leak or spill. However, there are a number of dangerous substances that are odorless and can be detected only by air monitoring instruments, for example, carbon monoxide. To that end, never rely solely on your sense of smell to identify the presence of a hazardous material. If you smell it, you are exposed. Remember, a large number of people, including you, could be exposed before the presence of a hazardous materials incident is identified. If you approach a scene where more than one person has collapsed or is unconscious or in respiratory distress, you should suspect the presence of a hazardous materials agent. If you do not follow the proper safety measures when faced with a hazardous materials incident, you and many others could end up needlessly injured or dead. The safety of you and your team, the other responders, and the public must be your most important concern. Dead heroes cannot save lives. There will be times when the ambulance is the first vehicle to arrive at the scene. If, as you approach, any signs suggest that a hazardous materials incident has occurred, you should stop at a safe distance, upwind and uphill from the scene. After rapidly sizing up the scene, isolate the hazardous area to the best of your ability, deny entry to the affected area, and call for additional resources. Provide as much information as possible when calling for additional resources, including your exact location, atmospheric conditions, if appropriate, the size and shape of containers or cargo tankers, the exact name of the substance, if known, the chemical ID number or symbols if visible, the number of victims, including signs and symptoms, if observed, the type and number of additional resources requested, the location of safe staging areas for incoming resources, and the location of incident command post. Do not re-enter the scene, and do not leave the area until you have been cleared by the hazardous materials team, or you may contribute to the situation by spreading hazardous materials. Hazardous materials assessment. If the dispatch center says there could be a hazardous material involved in the call you are going on, assume that you have a hazardous materials incident. If you are responding to an incident that involves a commercial vehicle or a non-commercial vehicle, and a train, maintain your high index of suspicion. Tractor-trailers, tanker trucks, alternative fuel vehicles, and pesticide control vehicles should be high on your list. Be suspicious if you are called to industrial facilities, warehouses, tank farms, pipeline facilities, manufacturing operations, water treatment facilities, and chemical plants. Agricultural operations and supply stores use many different chemicals that, in spite of the benign nature of the business, demand utmost care and alertness. Consider the possibility of terrorist incidents in places such as large offices, government buildings, and shopping centers. Remember, hazardous materials may be solids, liquids, or gases. When you approach any scene, be alert for evidence of spilled liquids or powders, vapor clouds, or odors. If a dispatcher reports that there are many people who seem to be ill or people with symptoms that raise your index of suspicion about exposure to a toxic material, you should stop far away from the scene and think through your approach, assessing the risks of the scene. Use binoculars to get a clearer picture of what is going on. The standard rule of thumb for hazardous materials scene assessment says that if the entire scene cannot be covered by your thumb held out at arm's length, you are too close. You should use every piece of technology at your disposal to get information about what has happened, who is involved, how many patients there are, what their injuries or symptoms are, and, if possible, what hazardous materials may be involved. Identification of hazardous materials. One of the most valuable pieces of information at a hazardous materials scene is the identification of the specific material involved. This information will be of tremendous value to the responding hazardous materials team. Particularly if there are a number of casualties, This knowledge is critical to prepare for the possible health effects on patients, and to alert the emergency medical services teams that will be dispatched to help you. Take no risks, but when applicable, try to read the marking and placards required at hazardous materials storage sites, and on vehicles. If you are at a permanent manufacturing or storage facility, you should ask anyone you can for the safety data sheets for in-depth information about the hazardous materials. What you do at this point, even though you might rather be using your patient skills, could save lives later. Hazardous Materials Placarding System. Different systems of placards are used at fixed facilities and on transportation vehicles, and it is important for you to recognize them. The most common is the 4-digit numbers that are part of the United Nations or North American Hazardous Materials Coding System for identification of hazardous materials. These numbers identify the specific material being transported and correspond with information in the Transport Canada's Emergency Response Guidebook. You can download a free copy of the Emergency Response Guidebook by visiting the CANUTAC website, http://www.tc.gc.ca/ing/canutech/menu.htm. The most recent edition of the Emergency Response Guidebook should be carried on every emergency response vehicle. The Emergency Response Guidebook provides information on specific properties and hazards of substances, what is shown on placards, and recommended isolation distances. Figure 53-2 shows examples of hazardous materials placards and hazardous materials warning labels. In addition to the numbers, symbols are used to help identify different classes of hazardous materials. Other good sources of information for identifying hazardous materials in transport include the bill of lading, or freight bill, which should be carried by the truck driver in the cab, and the waybill or consist, which is carried by the conductor of a train. The dispatch center may assist in collecting further information from organizations such as CANUTAC, which operates a 24-hour telephone line. Call collect at 613-996-6666 or star 666 from the mobile phone, and has an extensive database to assist emergency responders. To be of assistance, CANUTAC needs to know the product involved, the shipper, and the transporter. CANUTAC has a website listing many educational events and activities for all hazardous materials responders, including paramedics. There are a variety of online and downloadable tools available to paramedics and hazardous materials response teams to help identify hazardous materials and their effects. The Wireless Information System for Emergency Responders, WISER, from the United States National Library of Medicine, an agency for toxic substances and disease registry, United States Centers for Disease Control and Prevention, contain detailed information on the necessary personal protective equipment, toxicology, symptoms, and treatment of thousands of hazardous materials. Paramedics should become familiar with the specific tools used by their emergency medical services agency before they are needed on a hazardous materials incident. Initial isolation and protection distance. Until the hazardous materials technical team arrives to determine the hazard zone, you should be aware of the safety perimeters that are necessary for hazardous materials that are toxic, poisonous, and those that pose danger of fire or explosion. In general, the safe distance is a lot further away than most people would believe. Remember the rule of thumb described earlier. Also, the Emergency Response Guidebook can help determine appropriate safe distances for isolation of the incident. However, if you are able to read placards with the naked eye, you may already be too close and should consider moving farther away. In general, you should stay uphill and upwind from any hazardous materials seen. To help determine wind direction, a piece of narrow roller bandage approximately 1 meter long can be tied to the top of your antenna. Be sure to check the wind direction periodically, and relocate if a change in wind direction dictates. Once on the scene, hazardous materials teams have many sophisticated tools to help identify hazardous materials, and to establish safe scene perimeters. Hazardous materials teams use air monitoring equipment to help determine explosive limits, oxygen levels, and the concentration of hydrogen sulfide and carbon monoxide. They will also be able to determine the pH of spills and may have the capability to perform specific agent testing using colorimetric devices. They may also use tools such as computer-aided management of emergency operations to help predict downwind concentrations of hazardous materials based on the input of environmental factors into a computer model. Classification of hazardous materials. The National Fire Protection Association 704 hazardous materials classification ranks hazardous materials according to health hazard or toxicity levels, fire hazard, chemical reactive hazard, and special hazards, such as radiation or acids, for permanent facilities that store hazardous materials. Levels of personal protection gear are rated according to the toxicity of the material. Before you enter any potential hazardous materials area, you must know the type and degree of health, fire, and reactive hazard protection needed to operate safely near these substances. Much of this specialized personal protective equipment is not carried on the ambulance on a daily basis and needs to be acquired through a hazardous materials team. Figure 53-3 shows hazardous materials classifications from the National Fire Protection Association. Toxicity level. Toxicity levels are measures of the health risk that a substance poses to someone who comes into contact with it. There are 5 toxicity levels: 0, 1, 2, 3, and 4. The higher the number, the greater the toxicity. Most ambulances are unlikely to have the specialized protective gear that would be required for dealing with any hazardous materials over level 0. Level 0 includes materials that would cause little, if any, health hazard if you came into contact with them. This is the only level that does not require special personal protective equipment. Level 1 includes materials that would cause irritation on contact but only mild residual injury, even without treatment. Level 2 includes materials that could cause temporary damage or residual injury unless prompt medical treatment is provided. Both levels 1 and 2 are considered slightly hazardous, but require the use of a self-contained breathing apparatus if you are going to come into contact with them. You would need training in using the self-contained breathing apparatus in a hazardous materials incident. Level 3 includes materials that are extremely hazardous to health. Contact with these materials requires full protective gear so that none of your skin surface is exposed. Level 4 includes materials that are so hazardous that minimal contact will cause death. For Level 4 substances, you need specialized gear that is designed for protection against that particular hazard. Table 53-1 further describes the 4 hazard classes. Hazardous materials scene management. Establishing safety zones. If you discover that an ordinary ambulance call is really a hazardous materials incident, you must take the following steps. Protect yourself first. Isolate the incident as much as possible to avoid the risk of further harm to other people, laypeople, emergency medical services staff, firefighters, and law enforcement responders. No one should risk his or her life or health at a hazardous materials incident. The Emergency Response Guidebook, which you should carry in your vehicle, can help determine initial isolation distances. Notify your dispatcher, and any other emergency medical services, fire, or law enforcement responders that a hazardous materials incident is in progress. Inform incoming responders of what you observe about wind direction, terrain features, and a safe response route. Keep in mind the rule of thumb: if you cannot cover the scene with your thumb held at arm's length, you are too close to the hazardous material. As the hazardous materials incident progresses, hazardous materials specialists will establish the hot, warm, and cold zones. The hot zone is the contamination zone where only properly trained rescuers wearing appropriate personal protective equipment are allowed. The warm zone surrounds the hot zone. Typically, the decontamination corridor is located in the warm zone. This zone should only be entered by trained hazardous materials specialists wearing appropriate personal protective equipment. The cold zone provides a further buffer from the hazards present in the hot and warm zones. Paramedics normally perform triage and patient treatment in the cold zone. Personal safety. You should be familiar with the personal protective equipment used at hazardous materials scenes even if you are not trained to use it. Hazardous materials technicians call this personal protective equipment level A through level D, and the equipment is used depending on what and how much of the hazardous material is at the site. Most paramedic ambulances do not carry this equipment. Level A provides the greatest respiratory and skin protection from exposure to hazardous substances because it is fully encapsulating. These garments fully cover the body, and the self-contained breathing apparatus or other supplied air system worn by the responder. The suits are rigorously tested by the manufacturers to determine resistance to many chemicals. Because they are considered gas-tight and completely cover the wearer, you may be asked to monitor or evaluate the technicians for heat stress. Additionally, you should familiarize yourself with the procedures for getting into and out of these types of garments in the event a responder has an in-suit emergency, and you are called on to provide patient care. Level B is called for when the responder needs a high level of respiratory protection, but the released substance does not pose a lethal threat via skin absorption. It is not fully encapsulating like Level A, and it is worn with self-contained breathing apparatus, or supplied air on the outside of the suit. Level B protection is often worn by the hazardous materials responders who are performing decontamination. Level C is designed to protect against a known substance. The equipment provides minimal splash protection, and is worn with an air purifying respirator or powered air purifying respirator that must have filters specifically chosen to provide protection against the known agent. Receivers of exposed patients in the emergency department and law enforcement officers providing perimeter protection at a scene would be good candidates for wearing Level C protection. Level D is typically not worn in hazardous materials incidents by anyone other than support personnel working in the cold zone. This level of protection is worn when there is little or no threat posed by the released substance, and the responder is wearing no respiratory protection other than perhaps a dust mask. The hazardous materials team should determine the appropriate personal protective equipment needed for a specific hazardous material. After identifying any hazardous material, the hazardous materials team will consult a permeability chart to determine breakthrough time for the fabrics the level of suits are made of. The hazardous materials team will also determine which type of gloves and boots will be worn. The team might decide that a double or triple glove system is necessary for the incident. The dangers that hazardous materials present to the human body depend on the ability of the hazardous materials to interfere with the body's processes. The bodily harm caused by a hazardous material is affected by the route of exposure, the dose and concentration, how long the toxin was in contact with the body, and whether it exhibits acute or delayed toxicity. If a patient has a chronic pre-existing condition, like a respiratory ailment, then a minor anhydrous ammonia exposure could prove to be more dangerous than would be expected. Primary and secondary contamination. There are two basic types of contamination, primary and secondary. Primary contamination is the direct exposure of a patient to a hazardous material. Secondary contamination takes place when a hazardous material is transferred to a person from another person or from contaminated objects. Routes of exposure. The physical properties of hazardous materials, and the physical surroundings at the hazardous materials incident can expose your patient in different ways. Air temperature, the concentration of the hazardous materials, and the amount of time that a patient is exposed will help you determine what your primary concern in treating your patient should be. If a material is not volatile and does not give off vapor but touches your patient's skin, it is called a dermal exposure. Many hazardous materials can be taken into other body systems through the skin. Skin conditions like abrasions may accelerate the absorption. Dermal exposure, also known as topical exposure, may result in only a local effect, such as reddening of the skin, localized pain, or the formation of blisters. However, if the hazardous material is absorbed through the skin, a systemic effect may occur. Hazardous materials, when absorbed through the skin, can have a significant adverse effect on the neurologic, renal, or hepatic systems. These toxic effects may be seen immediately in the pre-hospital environment or may be delayed for hours or even years, eventually presenting in the form of cancer. When the reaction shows up hours or days after your initial treatment, your careful documentation becomes invaluable to patients. Your records should include a description of the scene, anything the hazardous materials team told you about the substance, how your patient looked initially, the treatments rendered, and the positive or negative changes since initial contact. Regardless of the route or type of exposure, the dose effect principle applies. The greater the length of time or the greater the concentration of the material, the greater the effect probably will be on the human body. For example, People who have a substance briefly splashed on their skin will be exposed to a much lower dose of toxin than if they were lying in a puddle of that same substance for 30 minutes. The cycle of poison action includes absorption into the body, delivery to target organs, and binding to the organs. The cycle continues with biotransformation and elimination of the toxin through the gastrointestinal, renal, or respiratory systems. These concepts should be considered as decontamination decisions are made with the hazardous materials team. In addition, you should be aware that a synergistic effect may occur when two hazardous materials interact, producing a much greater impact than either substance alone. If your extrication patient is lying in a puddle of gasoline, his or her level of consciousness will be compounded if also exposed to carbon monoxide. Respiratory exposure can be efficient, rapid, and lethal. Many hazardous gases, the gases formed when some liquids spill, or even dust-like powders can harm the respiratory membranes or be absorbed into the body by passing through the bronchial tree or alveoli directly into the bloodstream. When hazardous materials are injected into the body or are absorbed through an open wound, this is known as parenteral exposure. Parenteral exposure could occur at a vehicle collision if your patient has an open wound that is exposed to a toxin leaking from a container. Gastrointestinal exposure occurs when your patient swallows a hazardous material like an organophosphate pesticide. You'll need all your patient communication skills when assessing such a patient, because often the ingestion is deliberate. Chemical terms. When you are working at the scene of a hazardous materials event, you can often assess the scope of the problem by considering the physical properties of the toxin in relation to environmental factors. For example, if the liquid leaking from a tank has a high boiling point, and the air temperature is low, then you will have less concern that the vapors of the liquid will be a respiratory hazard. If vapors rise as the liquid turns to gas, it is important to know that as the air temperature becomes hotter, the vapor pressure of a hazardous material will also increase, as should your concern for more toxin being released to affect you and your patients. Vapor density is another concept for figuring out where a gas or vapor might go. Vapor density compares the hazardous material gas to air. Air has a vapor density of 1. If the gas is heavier than air, the gas will sink into little valleys and ditches. Gases such as propane, butane, and carbon dioxide are heavier than air. But if the vapor rises and dissipates as it travels with the wind, then the vapor density is less than that of the air. Gases like anhydrous ammonia, acetylene, methane, and hydrogen are lighter than air. This is why you are taught to approach a scene from upwind and uphill. Of course, the situation changes dramatically if a fire is involved. If a hazardous material reaches a temperature at which its vapors can be ignited by a spark, then it has reached its flash point. If it gets warmer than the flash point, the vapors will burst into sustained burning. It has reached its ignition temperature. If the percentage concentration of the hazardous material as it mixes with air reaches its lower explosive limit, also known as lower flammable limit, then it can burn in the air, or explode. If the concentration of the hazardous material gets too high, or too rich, there will not be enough oxygen to support the combustion in air, and the mixture has exceeded its upper explosive limit. Hazardous materials teams can, in many cases, cool down the heat or dissipate the concentration of vapors by pouring on streams of cool water. However, before any water is applied, the hazardous materials team will make critical decisions about whether or not the material may be water reactive or water soluble. If they are going to use water, they will also determine the hazardous material's specific gravity, whether the hazardous material will sink or float in water. Toxicology terms. Chemistry experts and medical providers should communicate with each other using agreed-upon terms to describe the health hazards any incident might present. You'll be a better provider and incident historian if you can master these terms. Safe and unsafe concentrations of various substances are often expressed in parts per billion or parts per million. The threshold limit value is the maximum concentration of a toxin that someone can be exposed to for a 40-hour work week. If you look up a chemical in a reference text, and find that it has a very low ppb number for its threshold limit value, this means it is more dangerous than if it had a high threshold limit value. The threshold limit value short-term exposure limit is the concentration that a person can be exposed to for a limited number of brief time periods, for example, 4 15-minute exposures per day. The threshold limit value ceiling level is the concentration that a person should never be exposed to. A permissible exposure limit is the maximum concentration of a chemical that a person may be exposed to. In Canada, occupational exposure limits are set by provincial or territorial regulations. Sometimes you will hear the experts refer to the lethal dose, which is the amount of the substance sure to cause death. You might hear the hazardous materials responders refer to immediately dangerous to life and health, which means that the atmospheric concentration of any toxic, corrosive, or asphyxiant substance will pose an immediate threat to life, irreversible or delayed adverse effects, or serious interference for a team member's attempt to escape from the dangerous atmosphere. Decontamination and treatment. Treating hazardous materials patients can be a difficult and emotionally challenging experience. Remember, your safety comes first. If you are first on the scene, you cannot immediately begin pre-hospital care. Even when a patient is visible and in need of rescue, you must not rush in. Staying safe is a tough decision that requires discipline and emotional coolness. You must work as part of the team to prevent more casualties. Use the incident command system, which permits only properly trained and equipped hazardous materials personnel to enter the hot zone. Wait until your patients have been decontaminated. Then you can apply your knowledge and skills to actually treat the patient safely in a hands-on fashion. Because hazardous materials can cause harmful effects, protecting the environment should be one of your considerations. If your patient's injuries are treated, and not life-threatening, environmental issues should be a major consideration. You should take steps to prevent runoff during decontamination. If your patient is suffering, environmental considerations are still important, but a lower priority than patient pre-hospital care. Decontamination. Decontamination methods will depend on the type of hazardous materials involved, the stability of the scene, and the number, condition, and location of patients. Decontamination is undertaken to reduce the dose of hazardous materials in contact with the patient, and decrease the risk of secondary contamination to others, including rescuers and hospital personnel. Protection of the environment during decontamination is important. Plans should be made for containment of runoff. When lives are at stake, however, containing runoff is secondary. There are 4 types of decontamination methods: dilution, absorption, neutralization, and disposal. Dilution is the most common method, and the easiest to perform in the pre-hospital environment. Dilution typically relies on the use of copious amounts of water to flush the contaminant from the skin or eyes. This action decreases the dose effect of the hazardous material on the patient. Sometimes a simple soap, such as tincture of green soap, is used in the decontamination process. Other decontamination agents are rarely used. Vegetable or mineral oil is sometimes used if the contaminant is a water-reactive substance. Be cautious when you are using brushes. Abrasion of a patient's skin increases the potential for hazardous materials absorption. Pay special attention when your patient has been exposed to a solvent. Solvents are especially difficult to remove from the skin with water only. The patient may still have a solvent odor for quite some time after decontamination has been performed. Be aware of this during transport, or you may fall victim yourself to the off-gassing of solvents. Absorption is accomplished with large pads that the hazardous materials team carry to soak up liquid and remove it from the patient. Towels can also be used in the same way. Neutralization involves the use of a chemical to change the hazardous material into less harmful substances. Neutralization on the skin is almost never used by hazardous materials teams because of the dangers of uncontrolled exothermic reactions. When acids are used on bases, or vice versa, heat is generated as a byproduct of the reaction. Such reactions could be detrimental to the patient, making neutralization an action that is almost always contraindicated. Disposal is not so much of a decontamination strategy as it is a result of the process. Emergency medical services responders should be mindful of removing as much of the patient's clothing as possible, in some cases, all of it, to reduce the amount of contamination that contact the body. Simply removing the clothing of a person exposed to chemicals can reduce the level of contamination by as much as 80% to 90%. Emergency decontamination in fast-breaking situations. In some of the most difficult situations, you may be faced with the need to make an immediate decision about whether to treat patients despite the fact that they are contaminated. In this case, you may be responsible for deciding whether to proceed with rapid emergency decontamination. In all cases, you must ensure you have the appropriate protection to protect yourself against the threat, and stay clear of the product. Do not make physical contact with it. In such situations, you must still don appropriate personal protective equipment. Even if no respirator is available, you should take maximum barrier precautions. Put on turnouts or a splash-resistant, Tyvek, jumpsuit, eye protection, mask, such as a high-efficiency particulate air mask, and at least 2 layers of gloves. In addition, booties should be worn over footwear if possible. In general, nitrile gloves offer superior protection against many hazardous materials. Leather materials should be removed because these often absorb hazardous materials. Once you are protected as much as possible, you should instruct patients to disrobe and remove as much of the hazardous materials from their bodies as they can. If you can, give the patients plastic bags in which they can place their personal belongings and clothing. If the hazardous material is a powder, then it should be brushed away first. If the hazardous material is water reactive, then no water should be used during decontamination. Most often, however, water is considered to be the universal decontamination solution. In any emergency decontamination method, you need to minimize the risk to yourself. This type of decontamination is also referred to as the two-step approach to decontamination. Unmanned hose streams can be set up by the fire department to douse patients with large amounts of water. An example of such a setup is the creation of an emergency decontamination corridor made by parking 2 fire engines parallel to each other and approximately 3 to 6 meters apart. Nozzles can be attached to the side discharge ports of the engines and set to create a fine particle fog stream decontamination shower. Patients should disrobe on one end and enter the shower in single file. From a remote location, patients could be advised how to decontaminate and directed to pay special attention to the areas of the body that are difficult to rinse, such as the axilla, between fingers and toes, around the groin, the scalp, and between the buttocks. Soap and soft brushes should be made available. At the other end of the shower corridor, towels, blankets, and temporary garments should be available. Hypothermia may be a concern for some patient populations, such as young children and older adults, after decontamination. It is at the end of this corridor that you would make initial contact with the patients and begin the triage process. Ideally, the runoff water from decontamination should be contained. At a minimum, the runoff should not be allowed to become a source of secondary contamination. Technical decontamination. Technical decontamination is the process used by the responders to clean personal protective equipment, tools, and equipment. It is a thorough cleaning process, and the process and setup may differ from jurisdiction to jurisdiction. You'll hear the hazardous materials team refer to an 8-step process, which is only carried out by trained personnel. 1. Responders exit the hot zone and approach the decontamination corridor. 2. Contaminated tools and equipment should be left behind at the hot zone end of the decontamination corridor. 3. Hazardous materials personnel are showered and washed using water, brushes, soap, or other appropriate decontamination agents to remove all surface contaminants. This is done with the assistance of other hazardous materials personnel, the decontamination team, who should not wear more than 1 step lower personal protective equipment than the entry team. Because technical decontamination is not aimed at life safety, it is done in a manner that will contain the runoff. Often this is accomplished inside a small wading pool or other disposable basin. 4. Paramedics should stay alert for signs of an ongoing primary or potential secondary contamination problem. 5. The team members move into an area of the decontamination corridor where they are helped out of their personal protective equipment by another member of the decontamination team. Contaminated protective clothing and equipment are placed into a bag or receptacle for later decontamination or disposal. 6. Respirators and/or self-contained breathing apparatus masks and undergloves are removed last and placed in plastic bags or in other forms of containment. 7. Ideally, the responder should proceed to a location where they can take a personal shower to further reduce the potential for contamination. This is not always possible, but is the best course of action when possible. 8. Entry team personnel undergo medical monitoring. Treatment of patients exposed to hazardous materials. In general, the treatment of hazardous materials patients is straightforward. You can use many of the concepts learned in the chapters on burns and toxicology. However, there are some special considerations for hazardous materials patients. One of these is that invasive procedures should be minimized if possible. If you know from the hazardous materials team that your patient is contaminated, the process of tracheal intubation may expose the patient to airway contamination. Placement of an intravenous or intraosseous line may allow contamination to bypass the skin barrier. You'll need to weigh the risks of invasive procedures against their benefits. You should be familiar with references and how to access technical expertise when deciding how to treat patients during a hazardous materials incident. Some assistance may be obtained from the Emergency Response Guidebook and CANUTEC. In addition, you may consult with Poison Centers, the Agency for Toxic Substances and Disease Registry, and your local direct medical control. The hazardous materials team may have comprehensive reference textbooks that can guide you in treatment decisions, and also be of assistance to emergency department physicians. Never forget that you are the eyes and ears of the physician in the pre-hospital environment. Share the knowledge you have gained from the hazardous materials team for your patient's sake. Corrosives. Acids and bases. Corrosives are chemicals that include both acids and bases. Some examples are toilet bowl cleaner, lye, and hydrochloric acid. Acids have a low pH, from 0 to 7, while bases have a high pH, 7 to 14. Substances with either high or low pH can cause severe burns to the skin, eyes, and mucous membranes. Signs and symptoms include skin irritation, reddening or other discoloration, and blistering. Exposure of the mucous membranes to fumes can also cause burns, including severe life-threatening airway and lung burns. Decontamination of materials with a high pH will require considerably more time to flush from the skin. High pH materials react with skin to form a soap-like resistance to being flushed from the skin as compared to low pH acids. Once the patient is decontaminated, treatment is generally supportive. Ensure a patent airway, oxygenate the patient, treat for pain if indicated, and treat burns appropriately. Some emergency medical services agencies carry calcium chloride or calcium gluconate, which can be used when directed by medical control to treat the pain and hypocalcemia that is caused by hydrofluoric acid, even when no burn is apparent. Consider transport to a burn center if necessary. Patients showing signs of pulmonary edema secondary to an inhalation exposure may need to be treated for this with diuretics. However, you should always consult medical control to determine the proper course of action when you are treating patients with chemical exposures. Hydrocarbon solvents. Solvents may be liquids, solids, or gases. Common solvents include paint thinner and nail polish remover. Solvents are substances that are capable of dissolving other substances. Many of these solvents give off potent vapors that can be inhaled and can also be absorbed through the skin. Respiratory exposure in particular can cause immediate pulmonary symptoms such as pulmonary edema. Prolonged dermal exposure can cause symptoms as well, including cardiac dysrhythmias and seizures. Pulmonary irritants. Many gases react with the moisture of mucous membranes to cause irritation ranging from minor to severe or choking. Examples of such gases are chlorine gas and ammonia. The first thing to do for your patients is to make sure they, and you as well, are away from the contamination, and in fresh air. Removal of clothing may help dissipate trapped gases. Pulmonary edema should be treated according to protocols. Pesticides. Exposure to organophosphate and carbamate pesticides can produce severe signs and symptoms. These hazardous materials interfere with the enzyme acetylcholinesterase, which promotes uptake of the neurotransmitter acetylcholine. Runaway nerve stimulation produces a syndrome that is known by the mnemonic sludge, salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis. Also look for excess pulmonary secretions. As always, You should protect yourself from secondary contamination, including that from emesis when the exposure has been gastrointestinal. Treatment of pesticide poisoning includes aggressive decontamination, protection of the airway with intubation and frequent suctioning when necessary, high-flow oxygen, and the use of atropine to block the overstimulation of muscarinic receptors of the parasympathetic nervous system. The use of pralidoxime is recommended for organophosphate exposures, but not for carbamates. Chemical asphyxiants. Any gas that displaces oxygen from the atmosphere is termed an asphyxiant. Colorless, odorless gases, for example carbon monoxide and hydrogen sulfide, that are confined to an area may represent a deadly trap when would-be rescuers rush in to help a collapsed victim. Substances known as chemical asphyxiants interfere with the use of oxygen at the cellular level. Cyanide is a common example of such an agent. Hydrogen cyanide is used in many industrial processes. The 1984 release of methyl isocyanate in Bhopal, India, was a major hazardous materials incident that caused thousands of fatalities. Cyanide poisoning can also occur during exposure to the byproduct of combustion at structure fires, which is the most common exposure scenario for hydrogen cyanide. 2 commercially available kits are available for treatment of cyanide poisoning. One treatment kit consists of hydroxycobalamin, which binds to cyanide and forms a non-toxic byproduct. When using hydroxycobalamin, the receiving hospital must be made aware as it has an intense red color that renders many blood tests unreliable. Alternatively, cyanide exposure, for patients whose exposure was not due to smoke inhalation, can be treated with amyl nitrate ampoules that the patient should inhale for 15 seconds of every minute. This step is followed by the intravenous administration of 300 mg of sodium nitrite, followed by 12.5 grams of sodium thiosulfate. Because of potential toxicity of the amyl nitrate and sodium nitrite, it is no longer a first-line treatment for cyanide poisoning. Another common exposure that results in a chemical asphyxiation is carbon monoxide. This gas ties up hemoglobin to the extent that oxygen in the blood becomes inaccessible to the cells. Treatment includes removal of the patient from the source and administration of 100% supplemental oxygen, no matter what the apparent oxygen saturation reading shows. Severe carbon monoxide poisoning is sometimes considered for hyperbaric oxygen therapy. This can affect transport destination, and typically requires a protocol or a discussion with direct medical control. Transportation considerations. The ideal transportation scenario at a hazardous materials incident would be to have a team of paramedics who were not involved with decontamination or cold zone patient treatment standing by to transport patients to the hospital emergency department. However, if the incident is a large one, the cold zone paramedics may well need to both treat and transport patients. You should remember that patients received after decontamination should not be assumed to be completely decontaminated. Accordingly, you should take certain precautions to prepare yourself and your equipment for assuming pre-hospital care of the patient from the hazardous materials team, and for getting the patient to the hospital. First, you should wear the appropriate personal protective equipment. The hazardous materials team may be able to supply some of the personal protective equipment if you do not have access to a splash protective garment, for example. In addition, you should be given a complete report on what hazardous materials have been involved, the patient's source of exposure, and what has been done to decontaminate and treat the patient. In no event should you transport a patient if decontamination has not been sufficient. An example of insufficient decontamination would be when hazardous material on the patient continues to produce toxic gases, such as after a smoke exposure or a liquid splash exposure. Before receiving and transporting a patient exposed to hazardous materials, you can do several things in preparation. One principle is to reduce the amount of supplies and equipment that the patient will come in contact with. You could remove the mattress from the stretcher, because the patient will probably be carried on a backboard. Removing the mattress will make decontamination easier later. In general, use as much disposable equipment as possible. Supplies and equipment inside the ambulance should be removed and set aside in a clean, safe place for later retrieval. It is impractical and time-consuming to line the inside of the ambulance with plastic. Instead, Plan to isolate the patient by wrapping him or her in a sheet or other available covering to reduce the potential for secondary contamination. A double wrap procedure is preferable. In this procedure, the patient is first wrapped in a cloth or plastic sheet, preferably one that helps protect the patient from hypothermia. Then the patient is placed on a backboard, and the backboard placed on the stretcher. You should know which hospitals in your area have facilities for receiving patients with possible hazardous materials contamination. Give the hospital plenty of notice prior to the transport so that they can assemble the appropriately trained personnel and prepare equipment. Often hospitals will have a separate or dedicated treatment and decontamination room for these situations. There have been instances in which patients who were not adequately decontaminated caused secondary contamination inside hospitals. Receiving hospitals may sometimes stop paramedics from bringing patients into their facility until they can complete their own decontamination and assessment. Medical monitoring and rehabilitation. You may be asked to assist with medical monitoring of the hazardous materials team. Wearing personal protective equipment often causes heat stress and, of course, the toxins the team is working with can cause serious health effects. Factors that influence hazardous materials team members' health include level of physical fitness, activity, level of personal protective equipment, and environment factors such as temperature. Medical monitoring should include documentation of the incident factors, including the hazardous materials involved, the toxic effects, what personal protective equipment was worn, its resistance to permeability with the hazardous materials, and what type of decontamination was used. You should have a plan for treatment, transport, and potential availability of antidotes in the event that a hazardous materials team member needs medical assistance. You might be asked to assess hazardous materials team members before they suit up for entry into the hot zone, and then again after they come out. Your assessment should include complete vital signs, temperature, and body weight. Team members should be encouraged to hydrate with water or a sports drink prior to entering the hot zone. Working inside a level suit is like being inside a sauna, with no way to lose heat through evaporation, conduction, convection, or radiation. A useful fact that can help you with your assessment is that some hazardous materials teams keep a file of their members' baseline medical status. Be sure to ask for this information. Before being allowed to re-enter the hot zone, the hazardous materials team should be evaluated by the paramedic in the rehabilitation area, located in the cold zone, for hydration status, vital signs, and any potential symptoms of exposure to the toxic agent the incident involves. Team members should take off their protective clothing and be given a chance to rest. Reassess vital signs and perform a neurologic assessment, for example, orientation to time, place, and events, as well as an assessment of fine motor skills. Team members with elevated temperatures should be monitored closely for possible heat stroke. The loss of body weight is a direct correlation to the loss of fluids, and the risk of dehydration and hypovolemia. Members should be encouraged to rehydrate by drinking water or other appropriate fluids. If there are abnormalities in vital signs or if team members have signs or symptoms, they should not be allowed to return to work until their physical status returns to normal. An example of a hazardous materials team rehabilitation log that can assist paramedics in the hazardous materials rehabilitation sector is shown in Figure 53-8.